मिस्टर सुनील,
यस सर।
ये मुझे मेरा खुद का वीडियो जरा ब्लड दिख रहा है
सर अभी
आर यू एबल टू सी मी क्लियरली?
यस सर वी कैन सी यू।
ओके
सर ऑल गुड सर।
ओके फाइन।
वी आर लाइव सर, वी कैन स्टार्ट।
Sunil, can I start?
Yes sir, we are live sir.
Good morning, delegates, speakers, coordinators, and observer. Welcome back to day 2 of KGCON 2022. Hope you have enjoyed yesterday's session. I am extremely overwhelmed for the opportunity to address all of you. I am Dr. Vinod Rajankar, Secretary of IMA KHAMGAON, Secretary Buldana OBGYN Society, practicing gynecologist at Rajankar Hospital KHAMGAON. आज 30 जानेवारी राष्ट्रपिता महात्मा गांधी यांची पुण्यतिथी. या शहीद दिवशी मी महात्मा गांधींना श्रद्धांजली वाहून आजचा सेशन चालू करतो. The plan for today is scheduled to have 2 sessions. In pre-lunch session, we will have 2 lectures following by short inaugural function, and then we will have 4 lectures. To start our day, I am extremely happy to welcome Dr. Sumit Agrawal with his topic, Evaluation and Non-Surgical Management of Benign Prostatic Enlargement. This lecture will be chaired by Dr. Ashok Gaikwad sir and Dr. Nilesh Tiblewal. I would now like to invite Dr. Nilesh Tiblewal sir to introduce our speaker.
Good morning, everybody. Today we are starting with the first lecture. I am audible? Hello?
Yes,
Hello?
sir. Yes, sir.
I am audible?
Yes, sir. You are audible.
Good morning. Today we will start with our first lecture. It was given by Dr. Sumit Agrawal. He is well-known urologist. Dr. Sumit Agrawal is MBBS, general surgeon, and he has done DNB. He is member of many societies like IMA, Surgical Society of India, Urological Society, and American Urology Society. He has presented many papers and thesis in various international and national conferences. So with this short introduction, I would like to invite Dr. Sumit Agrawal, sir, to start with his lecture. Dr. Sumit Agrawal, sir.
Yes sir, thank you sir for the introduction. I would like to start sharing my screen. Myself, Dr. Sumit Agrawal, would like to present to you evaluation and non-surgical management of benign prostatic enlargement. Can I start, sir? Hello?
Yeah, sir.
Yes, sir. Yes,
okay, I'll continue. This topic will be seen in various headings like definition, history taking, examination, investigations, and management. So what is the definition of benign prostatic enlargement? As such, there is no consensus. Generally, a prostate volume of 20 ml is regarded as normal, and anything above 20 ml can be regarded as an enlarged prostate. Coming to the history part, in history, the most important part is the IPSS score. In IPSS score, we take 7 different points, 7 different symptoms. First would be the incomplete emptying, whether the patient is able to completely empty his bladder or not. Whether he is having frequency, that is whether the patient needs to go to washroom every 2 hourly. Intermittency, whether whenever the patient starts voiding, whether his urine stops in between and again starts. If the patient is having urgency, that is patient needs to go to the washroom immediately whenever he has an urge. If the patient is having a weak stream, accordingly up to 5 points are given. Whether the patient is giving a history of straining, that is, he needs to use abdominal straining for voiding, and nocturia, that is, after sleeping, how many times the patient has to get up in the night. Depending on this score, patient is divided into mild, moderate, and severe. Mild is if he has 0 to 7, moderate is 8 to 19 score, and severe is if the patient has 20 to 35 score. Then in history, we also ask whether the patient is having a history of hematuria, any urinary tract infection, diabetes, any nervous system disorders like Parkinson's disease or stroke, any history of urethral stricture disease, urinary retention, whether the patient is on any drugs like anticholinergic, which are generally prescribed by psychiatrists, any sympathomimetic drugs like presently in winter season, many common cold medications have sympathomimetic drugs which affect the urinary symptom, urinary passage. Whether there was history of prior lower urinary tract surgery. We also asked the patient to maintain a bladder diary and frequency volume chart. Coming to the examination part, other than routine general examination, an abdominal examination is done to exclude an overdistended, palpable, or percussible bladder. We check for the external genitalia to exclude any local pathology like phimosis, meatal stenosis, is there any growth. We also do a digital rectal examination to see for the grade of prostate, whether the patient is having a prostatic tenderness, any prostatic nodule, how is the rectal mucosa, is it free, and anal tone. And lastly, a focused neurological examination, that is perianal sensation and bulbocavernosal reflex, is also checked for. Coming to the investigation part, routine investigations like hemoglobin, complete blood count, serum creatinine, it is done. There are specific indications for serum creatinine as far as the books are concerned. It is done if there is renal impairment is suspected, if the patient is having hydronephrosis, or if there was any prior urological intervention. If patient is having a renal insufficiency, the risk of post-operative complications are raised during routine examination. Imaging of the upper urinary tract is also indicated in particular scenario, that is when the patient had a history of hematuria, if the patient had a history of UTI, renal insufficiency, was there any history of urolithiasis, or any history of urinary tract surgery. In all these scenarios, imaging of the upper urinary tract is mandatory. Serum PSA. Serum PSA is done if cancer detection would clearly alter the lower urinary tract symptom management. 28% of men with histologically proven BPH have a serum PSA that greater than 4. That is, if a patient is having a serum PSA more than 4, it is not necessary that the patient is having CA prostate, carcinoma prostate. So we need to see serum PSA report with caution. So what is the role of serum PSA in benign condition? It acts as a guide to prostate volume. It acts as a guide to check the response to therapy with 5-alpha reductase inhibitor. It acts as an indication of risk of LUTS or BPH progression. Many a times finasteride or dutasteride, that is 5-alpha reductase inhibitors, are given empirically to the patient. So if the patient is on finasteride or dutasteride, we need to weigh serum PSA report with caution. That is 40 to 50% serum PSA is reduced after 12 months of treatment with finasteride or dutasteride. Any other additional diagnostic test is required in mild symptoms. If the patient is having only mild symptoms, generally no additional diagnostic test is required. But if the patient is having PSA score of 8 to 35, additional diagnostic tests like post-void residue measurement, urine flow rate, that is uroflowmetry, pressure flow urodynamic study, or cystoscopy in very selected cases can be. Post-void residue measurement, normal men generally do not have any significant, or up to 12 ml of post-void residue is acceptable. If the increasing amount of post-void residue is there, it indicates LUTS or BPH progression, and it is an indication for surgery. But a large post-void residue is not in contraindication to watchful waiting or medical therapy in some selected patients. Post-void residue may predispose to UTI and irreversible bladder dysfunction, secondary to and overtension. Patients Qmax, what we get from uroflowmetry is Qmax and Q average, that is the peak flow rate, and Q average, that is the average flow rate. In this graph, as you can see, the maximum flow rate is around 8 ml per second. A dynamic study of the transportation of urine. Or like in our region, it's only like last since 2 years that we have started this urodynamic study. Diffuser underactivity is present in 9 to 48% of men undergoing urodynamic evaluation for non-neurogenic clots. This statement signifies the importance of urodynamic study in patients with lower urinary tract symptoms. What are the indications of urodynamic study? That is, if the initial evaluation, flow rate, and PVR are not significantly suggestive of bladder outlet obstruction, especially if an invasive treatment is considered, that is surgery. If surgical treatment has failed, if the patient is having any known neurological disease which affects the bladder or sphincter function, and if the patient is having normal flow rates but symptoms are very bothersome, that is, there is no explanation for his symptoms, in those cases urodynamic study is indicated. This is the graph that we get after an urodynamic study. The first line would indicate the bladder pressure. This is the voiding phase when the patient generated this much amount of bladder pressure, that is up to 100 centimeter of water. Bladder pressure was generated. Green line shows the abdominal pressure that he used for voiding. That is, he had contribution of 20 up to 20 centimeter of water for bladder abdominal pressure. Then this is the diffuser pressure that actually the patient had used. That is, the patient voided with a diffuser pressure of around 80, and this represents the flow rate. Coming to the management part, hello.
You are audible, sir.
I am audible. Okay, sir. Coming to the management part, in non-surgical therapy for benign prostatic hyperplasia, watchful waiting is an important aspect. That is, fluid management can significantly reduce the patient's symptoms. That is, we generally ask patient to reduce his fluid intake up to 1.5 to 2 liters. We ask them to maintain a frequency volume chart wherein we can adjust his volume intake as per his frequency. And patients who have nocturia, we would generally advise them to reduce fluid intake after 8 p.m. Caffeine intake reduction is also helpful. We also ask whether the patient is on any concurrent medications so that we can adjust when the patient is taking that medication. If like patient is on a diuretic, antihypertensive, so we can avoid that medication if patient is on a long journey or when the patient is out in public. We can replace antihypertensive diuretic with some other antihypertensive which is not having significant diuretic effect. We can also ask a psychiatrist to change his medications because many antipsychotic medications have anticholinergic effect on the bladder. Types of toilet and bladder retraining, that is double voiding. Patients who have significant post-void residue, we ask them to double void so that and their residue decreases. Urethral milking for men with post-maturation dribbling is also helpful. Bladder retraining techniques are there, in which distraction techniques, that is predetermined mind exercise, perineal pressure, or pelvic floor exercises are asked. What is the aim? Is to increase the minimum time between voids to 3 hours and or minimum voided volume to between 200 to 400 ml in a day. Urge to void should be suppressed initially for 1 minute, then for 5 minutes, then 10 minutes, and so on, increasing on a weekly basis. Frequency volume charting. This is very important. We generally give a booklet to the patient wherein how much fluid that he has taken, the patient notes that, and at what time and how much amount of urine generally the patient has voided. That is noted in that frequency volume chart. And constipation. Lastly, constipation, avoiding constipation is very helpful. What are the indications for medical therapy? Patients who lack indication for surgery are generally advised medications. Patients who have symptoms that are bothersome and negatively affect quality of life. What would be the contraindications for only medical therapy? That is, these patients are candidate for surgical intervention. They can be given add-on medical therapy. These are patients with refractory urinary retention, that is failing at least one attempt of catheter removal. High pressure chronic retention patients, patients with recurrent UTI, patients with recurrent gross hematuria, which is resistant to 5-alpha reductase inhibitor therapy, patients with bladder stone, renal insufficiency patients, and patients with a large bladder diameter. What drugs generally we use in medical therapy? Alpha adrenergic blocker, these are the most commonly used drugs. 5-alpha reductase inhibitor, antimuscarinic, and beta-3 agonist. Coming to alpha-1 adrenoreceptor blockers, tamsulosin, this is the most commonly used. It is almost like over-the-counter drug. It exhibits some degree of specificity for the alpha-1A adrenoreceptor. It is one of the most commonly used alpha blocker. In a symptomatic review of 14 studies with a total of around 4,000 patients, the mean change in symptom score was 12% for 0.4 drug, 0.4 mg dose, and 16% for 0.8 mg dose. Side effect wise, dizziness, asthenia, rhinitis, and abnormal ejaculation is generally a side effect profile for tamsulosin. Then alfuzosin. It is described as a uroselective drug due to lack of adverse effect and blood pressure changes. It is preferred in sexually active male due to very less incidence of abnormal ejaculation. Silodosin. It is selective alpha-1A adrenergic receptor antagonist. It is fastest acting alpha blocker. That is, it increases urine flow in 2 to 6 hours after the initial dose. It improves symptoms in 3 to 4 days in majority of the patients. There is lower incidence of orthostatic hypotension and syncope, fainting, and dizziness. So it is kind of preferred drug in old age patient more than 60 years of age who have low urinary tract symptoms. An alpha blocker is to be prescribed in them. But most common drug-related side effect is retrograde ejaculation, that is an ejaculation. Finasteride. It is 5-alpha reductase inhibitor, which is type 2 isoenzyme specific. It lowers serum and intraprostatic dihydrotestosterone level. There was a PLES trial, press study, which showed that cumulative incidence of acute urinary retention at 4 years in finasteride and placebo group were 7% and 3%. That is, there was 57% of risk reduction of acute urinary retention. The cumulative risk rate for undergoing BPH-related surgery were 10% and 5% in the placebo and finasteride group. That is, there was 55% risk reduction for BPH-related surgery if the patient was on finasteride. Then coming to dutasteroid, it is a dual inhibitor of 5-alpha reductase 1 and 2, and it has a greater impact on suppressing serum DTH level. There was an RCT conducted in which around 4,000 men were included. It showed a symptom score improvement of up to 21%. The maximum flow rate improved significantly by 2.2 ml. The risk reduction for acute urinary retention was around 57%, and risk reduction for BPH related surgery was around 48%. That it is more or less same with finasteride. Coming to anticholinergic, that is antimuscarinic receptor blocker, tolterodine is generally the drug of choice. It has symptomatic benefit without increased acute urinary retention in men with overactive bladder with proven bladder outlet obstruction. Now, tolterodine is generally avoided in men who have a significant residue that is more than 200 mg. Then beta-3 agonist, that is mirabegron. This is a recently introduced drug in management of lower urinary tract symptoms. A beta-3 agonist, it enhances bladder relaxation during bladder filling by blocking the beta-3 adrenoreceptor in the diffuser muscle. It increases bladder capacity without blocking contractility. And various combinations of alpha blocker with tolterodine or alpha blocker with mirabegron has also come up. Thank you.
Thank you, Dr. Sumit, for your wonderful lecture. Now, I would like to call Dr. Ashok Gaikwad, sir, to present any queries and his concluding remarks.
Dr. Sumit, sir,
Yes, sir.
you have covered almost all the points in benign hypertrophy of the prostate.
Yes.
All the points, all the details you have covered.
Yes.
And the topic itself suggests non-surgical management of the prostate, benign prostate hypertrophy.
Yes.
And there is a cold in the morning, and we are having the first lecture and on the prostate.
Yes, sir.
Nowadays, the patients, they are getting more and more. Now, in the age of 60s, the most of the people, they are having benign hypertrophy of the prostate.
Yes, yes.
Almost 50%.
Yes, majority.
And at the age of 90 or 80, all the peoples, they are covered with benign hypertrophy of the prostate.
Yes, sir. They are on some of the other alpha blocker. They invariably require some medication.
Yeah. And you have narrated, you have given the details of everything. There's nothing to ask. But I just want to know whether there is a role of yoga in prevention of the benign hypertrophy of the prostate. Is there a role nowadays?
Role of, sir, in watchful waiting, non-surgical management, I had mentioned there were some pelvic floor exercises.
Yeah.
What books like from foreign authors, they won't use word of yoga. They will use, instead of yoga, pelvic floor exercises. Yoga is indirect form of that word. Pelvic floor exercise indicates yoga. So it has a role, though yoga will have some effect on the symptoms of the patient. It won't alter the disease progression. That is, benign enlargement is like hormonal changes are very important. They play a major role in benign enlargement of prostate. So doing yoga, there it can benefit the patient to reduce his symptoms and avoiding some medication to certain degree. But only yoga for patients who have significant symptoms won't benefit much.
Sir, there is any role of herbal medicine. In market, they are saying that we are reducing the prostate by this much, these things, take the 45 days medicine, and it will reduce by 9.2, 4.2. How it is possible?
These
I think it is not recommended nowadays.
Yes, sir.
In general.
Officially, we cannot recommend herbal medications because as such we don't know what is the exact content those herbal medications have. Directly or indirectly, some amount of finasteride or dutasteride is there. As far as our medicine is concerned, we have specific molecules. This molecule has this effect. Many of the herbal medications, we do not know exactly what is the content in those herbal medications, because many have actually these drugs in them, which reduces testosterone level of the patient. And if the testosterone level is reduced, it has effect on prostate enlargement. So unless until we don't know what is actually in what is the molecule that those herbal medications are having, we cannot prescribe, sir.
Gaikwad sir,
Yes, sir.
I am Dr. Tarwalkar. Can I have a question?
Yes, sir.
Yes, sir. Yes, sir.
Yeah, actually, I have a comment and a question for Dr. Sumit.
Yes,
The comment is, Dr. Sumit, you have very wonderfully taken out this topic, which is very common topic, and you have
Very
given
common.
us the practical tips.
Yes.
Every man of us is going to have that phase in his
Yes,
life.
sir.
So it's so common. I always label it like a cataract. Everybody is going to have a cataract.
Very good.
Like that.
Yes, yes.
And you have given very, very, very practical tips to us. One I would appreciate is the important thing is the use of diuretics. As a physician, everyone has to remember that the diuretics are usually to be given in the morning for all
Yes,
medical
sir.
purposes also. But in routine practice, unfortunately, we see too many prescriptions where diuretics are given twice a day or maybe only at bedtime, which is
Bedtime.
absolutely inadvertent. So many times what I have to do is the change the timing of the tablets, which is definitely going to change the symptoms of PPH. That is one
Yes.
thing. Yes. Secondly, I have a small question. Which agent to prefer in which patient? Finasteride or dutasteride? How do you select the patient for particular drug?
Practically, sir, there is no difference in finasteride or dutasteride.
Exactly.
All the studies that were conducted with finasteride as a drug and dutasteride as a drug, ultimate risk reduction for acute urinary retention is 57% in both the groups, and PPH related surgery is around 48 to 50% risk reduction in both the groups. So practically, even if finasteride is used or dutasteride is used, it makes no difference.
Okay. As regards the age, is there any difference in the post-void residue?
Sir,
How much should we permit in elderly individuals?
no, sir.
Reports, and we failed to understand post-void residue 30 ml, 45 ml. So which is significant?
In general practical purposes, 1/3 of pre-void is regarded as significant post-void residue. Post-void residue, only seeing at post-void residue is not significant. We also need to see what is the pre-void of the patient. Like if there is 300 of pre-void, 1/3, more than that is 100 ml. More than 100 ml of post-void residue is significant. If the patient is having up to 100 ml, so we can advise him either watchful waiting, or we can advise him some drug treatment, alpha blockers, depending on how much symptomatic the patient is. Only taking when we need to take what is the symptom, what is the symptom score, whether the patient is having mild, moderate, or severe symptom score, how much is the prostate bothering him, and everything we need to take into accountability, then we can advise him.
Fine, thank you.
Sumit sir.
Sumit, sir.
Yes, sir.
Sumit sir, I have one question.
Yes, sir.
There are a lot of drugs with combination available in the market.
Yes, sir.
So we can use single drug or combination drug, and in which patient we use single and in which use combination drug?
Generally, the effect and the combination is like alpha blocker with dutasteroid is available.
Yeah.
Alpha blocker with finasteride is available.
Yeah.
Combination drug by studies is recommended if the patient's prostate volume is more than 40 grams. That is 40
Okay.
cc. Many a times the patient has a prostate that is just 30-35 grams. So in those cases, practically only alpha blocker should be used. If the patient is not having a prostate volume of more than 40 grams, then using dutasteride or finasteride makes no difference in his symptom score.
How can we? How long we use alpha these drugs? Like we have patient came to us. We started with alpha blocker and antagonist. Then patient said that after 6 months he has improved in symptoms. but prostate remain in long life.
Enlarged.
So
Yes, prostate.
Yeah.
As such,
how
once the
long we
patient
use
has
these drugs?
once the patient has been started on alpha blocker, many times, like after 3 months, 4 months, he gets symptomatic relief, and
Yeah.
generally the patient stops. Many times when he comes back to us, he says कि सर जब तक का वो गोली चल रही थी तब तक का symptoms अच्छे थे. Once he starts tapering off the drug, or once he stops the drug, he again starts getting lower intact symptoms. So in those cases, we need to continue alpha blockers lifelong. If
Okay.
the prostate volume is like more than 40 gram, then using dutasteride or finasteride for long term, that is up to 6 months or 1 year, so their prostate volume would reduce. So in those cases, after 1 year or 1.5 years, we can reassess. We can reassess his symptom score, whether he is again in mild, moderate, or severe group. We can use uroflowmetry as a guide, because many times patient says कि नहीं मेरा urine volume अच्छा है, when I am voiding with good stream, but when we see uroflow report, his peak flow rate is actually very less. So only subjective evaluation, we have to evaluate the patient objectively with the uroflow, and then decide ki whether we need to continue alpha blocker or not.
A patient came that said that he's improved the symptoms. Can we stop the drugs, or we continue with the drugs? If
We
there
can
is
give a
significant
trial.
improvement
We
in the symptoms.
We can give a trial, like we can say the patient ki you don't take the drug for at least a week and see how the symptoms, whether
Okay.
if the symptoms reappear, then he need to continue those alpha blockers.
Okay.
Sumit sir,
Yes, sir.
there is a question from our audience. Which surgery is better for BPH, robotic or TUR?
That is totally different. Robotic has just been introduced in benign conditions. Robot is generally, for practical purposes in India, robot is only preserved for carcinoma prostate patients, wherein a radical prostatectomy is advised. In national urology conferences, there were some video live presentations where robot was used for benign prostatic conditions, but practically for India, presently robot is just for carcinoma patients where a radical prostatectomy with lymph node dissection is required. And in surgical treatment, debate is between routine TUR, monopolar or bipolar TUR versus holmium enucleation.
Is there any side effect of Siladol D? There is a question from audience.
Silodosin causes anejaculation. So generally in young population, like patients who are 40 to 50 years, who have low urinary tract symptoms, in those cases, if he is sexually active, so silodosin is generally avoided, because patients have actually come up, they were advised silodosin, and they have actually come up ki they could not ejaculate, and stopping silodosin immediately gives them the result. Otherwise, as far as dizziness and fall in BP is concerned, silodosin is very safe, so it can be used in old age patients.
Sir, it's a game of hormonal imbalance, benign hypertrophy of the prostate.
Yes, sir.
That means there is no such magic bullet for the treatment in benign hypertrophy of the prostate. Only you can prevent the symptoms.
Yes, sir, definitely. Alpha blockers are like symptomatic. They would relax
Sir.
the bladder neck, they would relax muscle in the prostate. So they are symptomatic. As far as reducing the prostate volume, dutasteride and finasteride long-term use, they do have some role.
Yeah.
Either they retard further growth, or they retard the prostate volume when used for long term.
There is one question. Any role of Uttar Basti Ayurvedic treatment?
Sorry, sir, I'm not the correct
Okay, okay.
person.
Another question. Neurosurgeons advise first cataract surgery or first prostate surgery if both need treatment.
As far as cataract surgery is concerned, there is an entity that is floppy iris syndrome. This is generally encountered in patients who are on long-term alpha blocker. That is, patients who have taken tamsulosin. Those patients, while during cataract surgery, surgeon can encounter floppy iris syndrome. So, if a patient is scheduled for a cataract surgery, we generally advise them to stop alpha blocker prior to 15 days. And then go ahead with cataract surgery. Once cataract surgery is done, he can restart on alpha blocker. Now, as far as surgical part is concerned, cataract surgery, ophthalmologists are generally skeptical that if the patient is having a urine tract infection, then they can get infected. If the eye can get infected due to urine tract infection. So many times we get a reference from ophthalmologist, the patient is posted for cataract surgery and his urine routine shows pus cells. So either we can treat him with antibiotic, and if his symptoms are manageable on alpha blocker, we can continue his alpha blocker, let him get operated for cataract, then come back for prostate surgery. If the prostate symptoms are too bothersome, if the patient has landed up in catheter retention, and if surgery is indicated, we would like to post him for prostate surgery. Once he has recovered, then let him go for cataract surgery. Cataract as such is not an emergency.
Yeah.
So we need to weigh which surgery is to be done first. What is the actual condition of the patient, his presenting symptoms. Generally, both surgeries together is not advisable. Like many times, even hernia surgery is scheduled with prostate surgery. So there are some risk of mesh getting infected. So it would, although practically it has been done, but better to get operated in two different settings so that risk of infection to the mesh is minimized.
The last question. Urinary continence after prostate surgery, is it reversible?
Urinary incontinence after prostate surgery, if it is due to sphincter damage, there are also different grades of sphincter damage. Generally, there is, after holmium enucleation, there is in many patients, like up to 30% of patients, there is transient sphincter damage, which over time, like in 3 to 4 months, those patients regain continence. In very less, like 5 to 10% of patients, there is permanent sphincter damage. So in those patients will require some kind of intervention. Nowadays, there are some artificial sphincters that has been introduced by some pharma companies, like the AMS, or they can use penile clamp for at least when they are scheduled for any sphincter reconstruction surgery. So penile clamp is pretty good technique for the patient to like wait for 3 months, 6 months, so that many transient sphincter injuries generally respond in 3 to 6 months of conservative treatment.
Sumit sir,
Yes.
last question from my side. Is there any advice for 50 plus age persons for prevention of the benign hypertrophy?
So as you
Prevention is
said,
better than cure. Is there any advice from your side?
सर घ्यायची इच्छा आहे का? सरांना काळजी झाली, 50च्या वरती झाली. चालू करून द्या, काही टेन्शन घेऊ नका.
Sir, as you said, it is a hormonal imbalance. So
Okay, sir.
there are no
Definitely.
definite like
सर हार्मोनल
management
इम्बैलेंस
strategy.
प्रिवेंट करने के लिए कुछ है क्या कि 50 के पहले चालू कर
स्टेरॉइड
दो?
वो है ना सब, बाकी वो उसके बाद हार्मोन इम्बैलेंस को रोकता है ना, उसके लिए तो
नहीं, वो
देते हो।
हार्मोनल इम्बैलेंस नहीं रोकता है, वो सही रोकेगा, वो स्मूथ मसल रिलैक्स करेगा, लेकिन हार्मोन जो इम्बैलेंस होगा एज के हिसाब से उसको रोकने के लिए कुछ है क्या?
Sir,
Thank you, sir. Thank you.
Okay,
Thank you very much. Thank you very much
thank you,
for the
sir.
nice lecture. Thank you.
Thanks, sir,
Thank you, sir.
for
Thank you.
allowing me to be a part of KGCON 2022. It was great, sir, presenting you all. Thanks a lot.
Okay, sir. See you, sir.
Thank you, Dr. Sumit Agrawal. Really, it was very interactive topic. Now, for the next lecture, I am extremely delighted to invite Dr. Vivek Tadwalkar sir to present his topic, Approach to a Patient of Anemia in Various Clinical Settings. This lecture will be chaired by Dr. Nilesh Tapre and Dr. Ramesh Bhutra sir. I would now like to invite Dr. Ramesh Bhutra to introduce our speaker.
Hello. Good morning. Jai Gajan.
Good morning, sir.
Yeah. First of all, congratulations to KGCON-2022 team for wonderful academic feast. And thanks for giving me this opportunity. Myself, Dr. Ramesh Bhutra. Here I am to introduce Dr. Vivek Talwarkar sir. Dr. Vivek Talwarkar is MD DMLS, a senior physician from Aurangabad. For few years, sir had worked as a senior physician at Ruby Hall, Pune. Formerly, he was HOD Medicine Department at Dhoot Hospital, Aurangabad. Sir has having a vast experience of 34 years managing multiple complex cases in internal medicine at various referral hospitals at Aurangabad. He is having one more feather in his cap that he secured a distinction in medico-legal qualification. He was awarded with Quality Assurance Accreditation in Diabetology by globally reputed Steno Denmark. This is a chain of hospital dedicated for only diabetes. Sir is having a 12 year of experience as recognized DNB teacher. He is instrumental in various activity of Physician Association of Maharashtra. Sir was scientific chairman of State Physician Conference. He is an academic life member of IMA, API, CSI, RSSDI, GSI. Sir had delivered national and international deliberations. Last but not least, he is a MMC accredited speaker. He is so multi-talented, but very humble and ground to earth. I remembered, sir, we took a CME at KHAMGAON. With a short notice, he came to KHAMGAON and delivered his lecture. So I welcome sir and invite him to deliver his lecture. Thank you.
Good morning. Thank you, Dr. Bhutra sir, for those kind words of introduction. First of all, my hearty greetings to KGCON and sincere thanks for your kind invitation to be amongst you today. My topic today is approach to anemia in primary care setting. Anemia, as you know, is a major health problem. Anemia is the most common hematological disorder. It's a major health burden worldwide. It affects 1/3 global population. See the magnitude, 1/3 global population. Anemia is one of the WHO global nutrition targets for 2025. What is the definition? Basically, anemia is a presentation of underlying disease or deficiency. The basic abnormality is defined as reduction in the red blood cells mass with consequent reduction in the oxygen supply to tissues. The WHO defines anemia as a hemoglobin level less than 12 gram% in women and less than 13 gram% in men. Now, what are the factors contributing for developing anemia? There is a wide variety of factors. the commonest of them being nutritional deficiencies. Then chronic diseases, inflammatory process, medications, renal dysfunction, malignancy, and of course, bone marrow disorders. There is a definite disease association of anemia with some diseases. Higher prevalence of anemia is noted in diseases like hypertension, congestive heart failure, coronary artery disease, hypothyroidism, rheumatologic diseases. What are the public health impacts of anemia? Very important. First of all, there is a reduced physical development of the population affected by anemia, which is seen as decreased work output and work capacity of the anemic individuals. Then there is a tremendous impact on pregnancy outcomes, another very important aspect of anemia. As you know, about 20% of maternal deaths are caused by anemia worldwide, not only in India, worldwide. Then reduced cognitive development of children. There is diminished concentration, disturbance in the perception, delayed psychomotor development of children, impaired language skills, impaired motor skills, and overall a diminished IQ. And of course, economic impact. Now, with this brief background of anemia, let's see how to approach the problem. Now, as you know, it many times does not need a consultant like me or some subspecialist to diagnose anemia. It's predominantly the domain of a general practitioner to start with. So majority cases diagnosed by primary physicians. And how is that done? First of all, detailed history, physical examination, laboratory tests, and some radiological investigations. Now, the causes of anemia can be classified into the groups like production defects of red blood cells. Then there could be maturation defects of red blood cells or survival defects. The red cells may have survival problems. They may be destroyed earlier. Then there could be sequestration of the red cells into the organ like spleen. And of course, blood loss by way of, say, trauma because of any reason or some gastrointestinal problems. Sorry. Now, the impaired RBC production, anemias of deficient RBC production, commonest being the iron deficiency anemia, which is often caused by blood loss. Then megaloblastic anemia because of cobalamin or vitamin B12 deficiency, pernicious anemia, then folic acid deficiency, aplastic anemia because of bone marrow depression itself, and many chronic disease associated anemias like chronic inflammatory disorders, chronic renal failure. Then myelothesic anemias. These are the anemias caused by metastatic tumor cells replacing the normal bone marrow cells extensively. Then increased destruction of red blood cells. That is another category of anemia. Anemias due to increased red blood cell destruction are classified as hemolytic anemias. They present usually as jaundice and raised LDH levels, lactate dehydrogenase levels. There are two main types of hemolysis, intracorpuscular and extracorpuscular. I'll not go into the details of these categories. But broadly, the etiological classification of hemolysis could be congenital or acquired. In congenital, we have varieties because of membrane defects like hereditary spherocytosis. There could be enzyme defects like B6PD deficiency, which we commonly talk of, or there could be some globin defects leading to hemoglobinopathies or sickle cell anemia. Then acquired hemolysis could be again either immune etiology or non-immune etiology. In immune category, it could be autoimmune or alloimmune. And in non-immune category, it could be some microangiopathic anemia because of certain infections. Then the third category of blood loss, which could be because of trauma or surgery causing acute blood loss, gastrointestinal lesions causing either acute bleeds like variceal bleeds or peptic ulcer bleeds, or chronic blood loss like some angiodysplasia. Then gynecologic disorders causing blood loss, particularly fibroids. Menstruation disorders, infection by intestinal nematodes feeding on blood like hookworms infection. Now, how is the clinical presentation? The symptoms, of course, depend on the etiology of anemia, the severity of anemia, presence of other comorbidities. So many times it is the comorbidity that brings the individual to the medical attendant rather than anemia per se. So obtaining good history is extremely important. The onset, duration, and progress, which we have learned in our medical schools, they show the clue to the type of anemia. The common symptoms, all of us know, there could be weakness, fatigue, vague headaches, shortness of breath, dizziness or lightheadedness as the patients describe it. Then there could be palpitations or irregular heartbeats, chest pain, paleness of the skin as a whole or yellowness of the skin at times, and cold hands or feet. So common symptoms. Symptoms particularly of B12 deficiency anemia, they could be in the form of tingling or pins and needles sensation at the hands or feet. Diminished sense of touch. Intelligent patients can directly present with the symptom of I'm getting diminished sensation in my extremities, difficulty in walking, clumsiness or stiffness of the arms and legs, and rarely dementia could be the presenting symptom. So if the B12 deficiency is mild, we can have vague symptoms like fatigue, headache, or weight loss. But if it is severe, then as I just told, impaired balance or difficulty walking, muscle weakness, or at times mood changes, especially depression. So rarely a patient can land up first with a psychiatrist who will evaluate and then find nothing else than B12 deficiency anemia. Sickle cell symptoms, they include again fatigue, susceptibility to infection, delayed growth and development in children, episodes of severe pain. This is important. Episodes of severe pain, especially in the joint, abdomen, or limbs, what we call sickle cell crisis. Coming to physical examination, a thorough and proper physical examination is a must in every individual. Pallor of conjunctiva and mucous membranes is important sign. We can have tachycardia, dyspnea could be there, and they are the significant features signifying the severity of anemia. Significant signs also include platinikia or koilonychia. One can have glossitis or cheilosis. So we have to literally dig out for these signs in general examination. Jaundice could be there, hepatosplenomegaly. If the anemia is advanced, edema of the lower limbs, cold extremities, and like that. Now the diagnosis. The blood tests confirm the diagnosis of anemia and may show underlying cause. CBC is the very preliminary and very important test which determines the hemoglobin content and various other parameters of the number, size, and volume of RBCs. Value of MCV, which is shown in the CBC, is very important. And of course, peripheral smear examination. Yesterday, we have listened to Dr. Gopal Soni, sir, who has very elaborately explained about the different peripheral smears and their significance. So peripheral smear examination, particularly by an experienced pathologist, is extremely important in the diagnosis of anemia. So CBC, the fundamental test, which gives us very elaborate information regarding the RBCs, WBCs, platelets, etc. It is very important to interpret the CBC thoroughly and appropriately. So this is the point to be made. Proper interpretation of the CBC is extremely important. Many times in a hurried OPD, we just see hemoglobin and TLC, and okay, it's fine. It's not like that. Every single parameter is telling you some important implication. In CBC, in RBC, we have the parameters of PCV, hemoglobin content, RBC count, red cell distribution width, MCV, MCHC, etc. The WBCs, we have differential counts with individual significance for every type of cell, total leukocyte count, and in platelets, of course, the platelet count. So a CBC can detect infections, anemia, diseases of immune system, and blood cancers. So that is the importance of a properly done CBC. A word about MCV, that is mean corpuscular volume. It refers to the abbreviation of MCV. Normal MCV level is between 80 to 96 or 100. Practically, we can take up to 100. It is in femtoliters per cell in a healthy individual. And there are two categories. High levels of MCV found in anemia of B12 deficiency and alcoholism, chronic alcoholism. Whereas low levels of MCV, they are detected in iron deficiency anemia and sometimes conditions like lead toxicity. So on the basis of MCV, there is one classification of anemia, morphologic classification, classifying anemias into three categories: microcytic, normocytic, and macrocytic. Microcytic means when the MCV is less than 80. Normocytic, that is the MCV is in the normal range, 80 to 100. Macrocytic, where the MCV is more than 100. Now the smear of peripheral blood. Here we have shown the different classical pictures of erythrocytes, neutrophils, basophils, eosinophils, lymphocyte. Now in the peripheral smear of, this is the peripheral smear of a red cell mass. On the left-hand side, there is a normal amount of red blood cell distribution in a normal individual. Whereas on the right side is the picture of a anemia where the amount of red blood cells is quite scarce, quite less. This is again a classical peripheral smear showing iron deficiency anemia. See the normal red cell distribution and size and the content of the red blood cells. Whereas on the right side, there is a scarce quantity of RBC with little lesser size of the RBCs, microcytic, and scanty pigment. This is again a picture on the left side, normal red blood cell with neutrophil. On the right hand side, with we have a megaloblastic picture, wherein the right blood cell size is little larger, macrocytic, what we call, with hypersegmentation of the neutrophils. So these are the features of macrocytic anemia. Same here again, multiple segments of the neutrophils, very classical of megaloblastic anemia. This is in the case of a chronic liver disease and consequent hemolysis. So microcytic normochromic anemia with little rise in the reticulocyte count. I'm just coming to the retic count in a short while. So reticulocyte count, another important parameter. Similarly, serum iron and serum ferritin levels are indicators of body's total iron stores. Levels of B12 and folate, which are the vitamins necessary for RBCs. So these are the basic investigations required in a workup of anemic individual. A word about retic count. The normal range of retic count is 0.5 to 1.5%, maximum 2.6% as per some of the laboratories, and less than 0.1% retic count and above 3% is considered highly significant. So rise in the retic count significant of certain conditions. So this is the group wherein the reticulocyte count is decreased majority of the times, various deficiency anemias, chronic diseases, folate deficiency, iron deficiency, B12 deficiency, and there is a rise in the reticulocyte count, particularly in hemolysis or hemorrhagic conditions, leukemic conditions, and while recovering from vitamin B12 deficiency. Now these are the various normal levels of RBC parameters. Normal serum iron levels, adult males, the range is usually 75 to 175 microgram per deciliter. Females almost same. Then ferritin levels, 20 to 500 nanograms per ml in men, 20 to 200, little less, nanograms per ml in females. This is the vitamin B12 level. Usually 200 to 1000 is the normal range, very wide range in normal individuals. 100 to 200 is considered as a borderline deficiency or mild deficiency of vitamin B12. and less than 100, of course, is labeled as severe deficiency. As regards the folate levels, the normal levels are 6 to 21 micrograms per liter, and folate deficiency is labeled when the levels are less than 4 micrograms per liter. Then certain other blood chemistry tests are required in the diagnosis of anemia. Urea, creatinine, bilirubin. As we just saw, bilirubin is raised in hemolytic anemias, lactate dehydrogenase, and proteins. Urinalysis is another important parameter, wherein the light chain proteins, they are detected in urine. Very fundamental test, particularly for the diagnosis of certain hematologic disorders like multiple myeloma. So light chains presence in proteins. Then RBCs in urine or hemoglobinuria. Sometimes we need other special tests for rarer causes like antibodies or RBC fragility, enzyme defects, hemoglobin electrophoresis, and of course bone marrow examination. When the cause is unclear, it is mandatory to do the bone marrow examination. The need of radiology is particularly for abdominal ultrasound. At the primary care setting, abdominal ultrasound is the essential tool in diagnosis of anemia. Ultrasound findings of liver, spleen, stomach, bowel, gynec alterations, lymph nodes, they guide further investigations to be done in an anemic patient. It is the abdominal ultrasound, it is the test of choice for patients with inflammatory bowel disease. It is a common cause of anemia. Detection of liver lesions like metastasis, it indicates presence of malignancy, which can be very easily detected on a routine test like abdominal ultrasound. Splenomegaly, enlarged abdominal lymph nodes, they are the signs of lymphomas presenting as anemia. Now I come to the treatment part. The therapy for iron deficiency anemia includes, first of all, dietary modification, because nutritional deficiencies are the common causes for anemia. Then therapy includes oral iron or IV iron, and then newer parenteral iron preparations, and rarely blood transfusion. Coming to oral iron, mild to moderate iron deficiency anemia is treated by oral iron, like ferrous sulfate, ferrous fumarate, or ferrous gluconate. The commonly used molecule is ferrous sulfate, wherein 325 milligrams of ferrous sulfate is equivalent to 65 milligrams elemental iron. To promote absorption, patients should avoid tea, coffee with the iron tablets, and they may take vitamin C, particularly 500 unit dose with the iron tablet once daily. So ferrous sulfate 200 milligrams 8 hourly, which gives total of 195 milligrams of elemental iron, because each tablet contains 65 milligrams elemental iron. So that is to be given for a period of 3 to 6 months. That is the recommended dose. If it is intolerance is there, then at least 200 milligrams twice a day should be given. And remember, elemental iron content is important and not the quantity of iron in the particular tablet. So elemental iron is to be considered. And a rise in hemoglobin level by 0.5 to 1 gram per deciliter per week is considered as the optimum response to oral iron therapy. So these are the three common molecules used: ferrous sulfate, 324 or 325 milligram iron content, 65 milligram elemental iron, and 3 tablets in a day are required to give the optimum dose. So that is the most convenient form, because other molecules, ferrous gluconate requires more number of tablets for the optimum dose. Ferrous fumarate, the elemental iron is little more, 106 milligram. So 2 tablets can be sufficient in a day. What are the possible side effects of oral iron? As we all know, constipation could be there, diarrhea could be there, indigestion, stomach cramps, nausea, and of course, black tarry stools. So these are the things which we are got to explain to the patients, that they are likely to have these side effects, which can minimize over a period of time. Then parenteral iron therapy. It is used in cases where oral iron is ineffective, iron absorption is too slow because of certain diseases, or iron absorption is low, as in the cases of inflammation, or there is a non-compliance to oral iron for some reason. So parenteral iron can improve iron stores rapidly as against oral iron. And parenteral iron is also effective for treating cases with inflammatory bowel disease and cardiac conditions like congestive cardiac failure associated with anemia. The intramuscular route, which was used commonly previously, it was found to have some drawbacks like pain at the site of injection, skin discoloration, myalgias, arthritis, etc. And so that particular route of intramuscular injection is now replaced by IV route. So two newer IV preparations are in common use. They are iron carboxymaltose and iron isomaltoside. These two drugs, they give larger infusion doses of iron, elemental iron, over a short period. So that is the advantage of parenteral iron. IV iron has the advantages of complete bioavailability. Whatever iron dose is given, almost completely it is absorbed. Then fewer GI side effects and faster rise in hemoglobin than oral iron. But high cost and small but finite risk, definite risk of hypersensitivity reaction with some molecules. These two things limit the widespread use of IV iron. The dose of parenteral iron, the total iron requirement of the patient needs to be calculated depending on his hemoglobin level. Too many formulae are available, but a simple, useful formula which I found practicable in day-to-day practice is iron requirement in milligrams is 4.4 into weight in kg into hemoglobin deficit. The dose of 1000 milligram is generally sufficient. So with all these calculations, a dose of 1000 milligrams is generally sufficient to treat anemia and also replenish the iron stores. And with the newer parenteral molecules, this 1000 milligram can be given easily at 1 or 2 sittings. So one molecule, ferric carboxymaltose, given up to 1000 milligram, diluted in 100 ml of NS, the infusion is run over a period of 15 to 30 minutes. It's so simple. The infusion may be repeated after 1 week if the deficit is too much. And the dose, if the hemoglobin is less equal to or more than 10, then for an individual of weight less than 70, 1000 milligram is sufficient. If hemoglobin is 7 to 10, then 1500 milligrams is the dose requirement. For larger weight individuals, the dose is larger. Second molecule is iron isomaltoside. It's a slow release iron with elemental iron concentration of 100 milligram per ml. Hence, it permits giving high dose to correct the total iron deficit in a single dose, in a single sitting. Given as an infusion at a dose of 20 milligram per kilogram over 15 to 30 minutes. And the advantage is the test dose is not required. The dose is for women when the hemoglobin is between 10 to 12, 1500 milligram. For men, when the hemoglobin is 11 to 13, again 1500 milligram. If the hemoglobin is less than 10, the dose required is 2500 milligram, which can be given at 2 different sittings. And the use of parenteral iron has largely been recommended by too many published trials recently, particularly in conditions of CKD, chronic kidney disease, then conditions of postpartum hemorrhage. The use is being done very routinely. And lastly, blood transfusion, which is usually recommended at a hemoglobin level less than 8 gram per cent. In those with coronary artery disease, the transfusions are only recommended when the hemoglobin is less than 7 gram. Otherwise, IV iron therapy is the preferred way of treating iron deficiency. Therapy for megaloblastic anemia, oral high-dose vitamin B12, 1 to 2 milligram daily, is as effective as intramuscular injection for correcting megaloblastic anemia and its neurologic symptoms. Intramuscular therapy leads to more rapid improvement and should be considered in severe deficiency or severe neurologic symptoms. Vitamin B12 deficiency is treated with hydroxycobalamin 1000 microgram intramuscular in 5 doses of 2 or 3 days apart. So gap of 2 or 3 days, followed by maintenance therapy of 1000 milligram every 3 months. And ideally it is given over a lifetime period. Folate deficiency, oral folic acid 5 milligram daily for 3 weeks will treat acute deficiency of folate, and 5 milligram maintenance dose once weekly is adequate for maintenance therapy. Prophylactic folic acid is now used in pregnancy. It prevents megaloblastosis in women at risk. So prophylaxis with folic acid in pregnancy, particularly the latter half, second half. And once we start therapy of megaloblastic anemia, the neurologic symptoms usually recede or improve over a period of 6 weeks to 3 months, so little longer duration. And the hematologic picture of anemia, leukopenia, mean corpuscular volume or MCV improvement, thrombocytopenia improvement takes about 8 weeks. Now coming to the important subset of anemia in pregnancy. Iron deficiency anemia is the commonest cause of anemia in pregnancy. The prevalence of iron deficiency anemia in pregnant Indian women is amongst the highest in the world. Untreated iron deficiency anemia has significant adverse feto-maternal consequences. The WHO defines anemia in pregnancy as hemoglobin less than 11 gram per cent. The WHO recommended dose of elemental iron in pregnancy is 120 milligrams. In doses beyond this, doses beyond 120 milligram cause increased GI side effects without improving the efficacy of the molecule. The use of enteric coated and delayed release preparations is again not recommended due to their poor bioavailability. And now the novel concept, a word about Anemia Mukt Bharat. It's a campaign of intensified Iron Plus initiative aiming to strengthen the existing mechanisms and foster newer strategies for tackling anemia effectively. It is under the Poshan Abhiyan run by the Government of India. So the Poshan Abhiyan focuses on 6 target beneficiary groups like pregnant individuals, children, lactating mothers, and adolescent girls, adolescent boys. So 6 target beneficiary groups through 6 interventions. What are the interventions? I'm just coming to that. 6 interventions and 6 institutional mechanisms to achieve the envisaged target under the Poshan Abhiyan. So these are the 6 interventions. Prophylactic folic acid, as I just told, deworming in pregnant individuals, intensified year-round behavior change communication campaign that includes solid body smart mind, including ensuring delayed cord clamping, then testing of anemia using digital methods and point of care treatment, mandatory provision of iron folic acid fortified foods in public health programs, including pregnancy, and addressing non-nutritional causes of anemia in endemic pockets with special focus on malaria. As we all know, malaria is again one of the common causes of anemia, and certain hemoglobinopathies and fluorosis. Looking at the future, let us hope that the Poshan Abhiyan results into the truly pink India. I think that's all I have to say today. Thanks a lot for inviting once again. Thank you so much.
Thank you, Dr. Tarwarkar sir, for your beautiful presentation. Now, I would like to call Dr. Nilesh Tapre sir to present any questions and his concluding remarks.
Very nice and informative lecture. Thank you. There is one question from Dr. Bairagi Praveen. Sir, he is asking, cooking in iron utensil can be recommended to prevent anemia?
Of course, it cannot be denied, but how far the elemental iron can be achieved through those utensils is really not documented. So it's a good practice if somebody is doing that. But that alone may not be sufficient to correct the required amount of deficit.
So
Thank
one
you
more
very much.
question. Yeah,
Yes.
you said, sir, ferrous sulfate dose is thrice a day, but hardly we are using in our OPD.
Exactly. So
what
we should change our habit of clinical practice and emphasize. And as I also showed, if some intolerance is there with the patient, at least 200 milligram BD, because the absorption is a great issue. Every individual has different level of iron absorption, and it really cannot be quantified how much an individual is able to absorb. So at least 200 milligram BD will be able to reasonably achieve the target hemoglobin over a period of 3 to 6 months.
Right, sir. One more question is, sir, if in routine OPD, just viral fever, post-viral fever, we are getting pancytopenia.
Right.
So which patient we should refer further or we should investigate?
As I also showed, acute folate deficiency, which is usually seen in viral fevers, almost in dengue fever, malarial fever, we see thrombocytopenia, leukopenia. So 5 milligram folate per day for 3 weeks is sufficient to correct the acute deficiency. If even after waiting for 3 weeks, the CBC is not getting corrected adequately, then I think we should have a watchful waiting on this patient, or keep a watch, observe for any bleeding tendencies. And then if you really suspect bone marrow deficiency or pancytopenia, they are the candidates for further hematologic reference. Again, there is a lab variation also. So every report we have to, of course, tally with the clinical response of the patient.
Thank you very much, sir.
Thank you.
Sir, as I am gynecologist, our 70% patients are anemic. Our prescription is full of iron and B complex supplementation. My question is that, is there any role of vitamin D in correction of iron deficiency?
Yes, vitamin D is definitely known to improve iron absorption. So if we are giving maintenance dose of vitamin D throughout the pregnancy, maybe once a week dose or once a month, that will certainly help in the response to iron therapy, because vitamin D recently is definitely proved to improve iron absorption.
Thank you, sir.
Thank you very much.
Thank you very much, sir.
Now it's time for our inauguration of our CME KGCON 2022 with all our chief guests present online. I welcome chief guests Dr. Prakash Marathi sir, Dr. Jignesh Taswala sir, Dr. Umesh Revanwar, Dr. Tapre sir. I also welcome Dr. Tiblewal sir and Dr. Vasu sir as an observer for the CME. As the secretary IMA KHAMGAON, I am happy to share some information with you on behalf of IMA KHAMGAON. IMA KHAMGAON branch was founded in 1959. Founder president was Dr. Ekboti sir. He and pioneer member as Dr. Khande Tod, Dr. K.N. Agrawal, Dr. P.M. Chande, Dr. Sauji, and Dr. Narendra Shah has worked hard to establish our branch. It's humongous us that our branch had organized state-level IMA conference in 1961. Our branch is very enthusiastic, energetic, and resourceful. We have been organizing grand annual CME with cultural and sports event since last 13 years. We always have dreamt about making this conference state level. And today, as a blessing in disguise, Corona pandemic made us achieve our dream true. I am very much glad to announce we have over 1,500 plus delegates from all over Maharashtra, with a few international delegates too. I congratulate Dr. Anand Rathi, Organizing Secretary, and Dr. Aniket Mende, Joint Organizing Secretary for this event, who had worked very hard to make this event successful. In guidance of Dr. Surekha Mende Madam, we are able to manage such huge gathering. I am privileged to introduce our President, Dr. Surekha Mende Madam. She had done her MBBS MS ophthalmology from BJ Medical College, Pune. Diploma in AIDS and STD from Thailand, Diploma in Aesthetic and Cosmetology from Mumbai. She worked as a civil surgeon, Assistant Director Mumbai, Secretary's nominee in Human Organ Transplant Committee. She is Vice President of Buldana Ophthalmic Society. She is a life member of MOS, AIOS. She is Lion President, Zone Chairperson, and received International Award of Excellence. She is now working as a Cabinet Officer, District 32-34. Madam had received Anandibai Savitribai Phule and Jizau Puraskar. She, as an ophthalmic surgeon, operated more than 40,000 cataract patients. I welcome Dr. Surekha Mende Madam, President of our IMA branch, for her presidential address.
You are muted.
Thank you, Dr. Rajankan, for giving me the nice introduction. Dear friends, good morning, everyone. I am very much pleased to have our all honorable guest in the inaugural functions of KGCON-2022 webinar. Actually, no goal is too high if we climb with care and confidence. I am very proud to have this session today. As you know, that KHAMGAON is a very small place, not even a district place, where there is a network issue. And at the same time, even you can imagine that the speakers from KHAMGAON, many of them has presented for the first time online. So it was a very big challenge for all team in KHAMGAON, but hats off to all our courage and dedication. कोशिश करने वालों की हार नहीं होती, लहरों से डरकर नौका पार नहीं होती. I welcome our honorable chief guest, Dr. Prakash Marathe sir. He is a senior vice president, Maharashtra IMA, and as well as he is a past president of Maharashtra Ophthalmological Society. At the same time, I am also welcoming Dr. Jignesh Taswala, my batchmate and president of Maharashtra Ophthalmological Society, who supported us with the technical team, Mr. Raman Marke sir and Sunil Latawa, and his experience also. Dr. Uday Revankar sir, he is a vice president first in Maharashtra State IMA. He helped us in communication with the MMC office. Dr. Nilesh Tapre, medical superintendent general hospital KHAMGAON, who always motivated us and helped us by taking active participation in all our events. Our MMC observers, Dr. Ajab Rao Vasu, who is a leading gynecologist from Chikhli, and Dr. Nilesh Tibdewal, who is a general surgeon as well as gastroenterologist from KHAMGAON. They guided us in this event. It was not possible without our honorable eminent speakers, chairpersons and co-chairpersons, and of course all delegates. I welcome our speakers, Dr. Gopal Soni, pathologist from KHAMGAON, Dr. Thete, pediatrician, Dr. Kothalkar, cardiologist from Buldhana, Dr. Sean Chinsole, ophthalmologist from Buldhana, Dr. Ashok Bavaskar, cardiologist from KHAMGAON, Dr. Bhople, pathologist from KHAMGAON, Dr. Namrata Bhagwat, she is an anesthetist and running her pain clinic at Akola. Dr. Narendra Bhagwat, he is a neurosurgeon from Akola. Dr. Sumit Agrawal, neurosurgeon from Akola. Dr. Tadwalkar, he is a cardiologist and diabetologist from Aurangabad. Dr. Ambrish Rathod, he is cardiac surgeon from Akola. Dr. Ashish Tapadia, gastroenterologist from Akola. Dr. Prakash Marathe sir, he is a leading ophthalmologist from Pune. Dr. Prashad Sor, he is an oncosurgeon from Akola. And WealthCom team, the financial education drive for the doctors, from the doctors. Dr. Parag Tapre from Akola, Dr. Gaurav Ladda from KHAMGAON, Dr. Deepak Bhatt from Akola, and Dr. Ashish Jhunjhunwala from KHAMGAON. I also welcome our chairpersons and co-chairpersons, Dr. Prachi Zadhav, Dr. Narendra Pawar, Dr. Gothi, Dr. Shankpal, Dr. Ingre, Dr. Nandurkar, Dr. Akhtar Hussain, Dr. Rahul Khandare, Dr. Nilesh Tapre, Dr. Ramesh Butada, Dr. Gaikwad, Dr. Nilesh Tibdewal, Dr. Gaurav Goenka, Dr. Praveen Patil, Dr. Brahmanand Tale, Dr. Pranali Deshmukh, Dr. Pankaj Mantri, Dr. Sheetal Chauhan, Dr. Anand Jhunjhunwala, Dr. Manish Wankhede, Dr. Parag Mahajan, Dr. Satish Gore, Dr. Hari Vadode, Dr. Amit Deshmukh, Dr. Shirsagar, Dr. R.K. Jadhav, Dr. Samruddhi Mende, Dr. Ashok Bavaskar, Dr. Deepa Mantri, Dr. Tibdewal, and Dr. Sandhya Nagargoje and Dr. Gulab Pawar. Without all these persons' help, we cannot have done this today's event. At the same time, I have to name few persons like our organizing secretary, Dr. Anand Rathi, Dr. Aniket Mende, Joint Organizing Secretary, Dr. Rajankar, IMA Secretary, Dr. Atul Rajput, Treasurer, Dr. Rashmi Rajankar, Women's Wings President, Dr. Smita Deshmukh, Women's Wing Secretary, all BOD members from KHAMGAON, and all other members also from the KHAMGAON, coordinators who help us in doing the registration, Dr. Gothi, Dr. Davange, Dr. Banole, Dr. Wakikar, Dr. Bahekar, Dr. Sate, Dr. Milind Patil, Dr. Vasu, Dr. Nilesh Tapre. So at last, I say I welcome you all friends and all the delegates. At the same time, during the inaugurations, I can thank also you all people who help us in taking this event at KHAMGAON. So I want to share with you all people. एक और एक को दो मानते हैं, दो और दो को चार मानते हैं, मानव हित तथा जीवन सेवा को ही हम जीवन का सार मानते हैं। है यह फर्ज हमारा, है यह फर्ज हमारा, हम कहाँ उपकार मानते हैं, हाँ आपके साथ सहयोग, उपस्थिति तथा मार्गदर्शन का आभार मानते हैं। धन्यवाद।
Now, I would like to introduce our first chief guest, Dr. Prakash Marathe, sir. He is a renowned ophthalmic surgeon and passed his MBBS and MS Ophthalm from BJ Medical Pune. He is a senior vice president, IMA Maharashtra State, past president of IMA Pune, past president Maharashtra Ophthalmic Society and Pune Ophthalmological Society. He had various presentations through electronic and print media for public awareness. He got President's Appreciation Award by National IMA Headquarters, New Delhi in 2018. He got President's Appreciation Award by IMA Maharashtra State for 2013, 14, 18, 20, and 21. He also received prestigious President's Special Felicitation Award by IMA Maharashtra State for 2021. I welcome such dynamic personality as a chief guest for this KGCON 2022. Now I would like to invite Dr. Marathe sir to share his thoughts.
Hello. Good morning. Am I audible?
Yes,
Yes,
sir.
yes.
Thank you, Dr. Rajankar sir, for the wonderful introduction. And I must appreciate the efforts of IMA KHAMGAON under leadership of our president, Dr. Surekha Mende, who is our friend since our BJ Medical days. Not to forget her family members and active IMA KHAMGAON members, Dr. Keshav Mende and Dr. Aniket, her son, who is Joint Organizing Secretary. Just now we have heard Dr. Vinod Rajankar, his Mrs. Dr. Rajankar, then Dr. Anand Rathi, who is Organizing Secretary. Not to forget Dr. Atul Rajput, Dr. Smita Deshmukh, and the whole team of IMA KHAMGAON, the whole organizing team. Along with them, other chief guests, along with me, my dearest friend, who is President of Maharashtra Ophthalmological Society, Dr. Jignesh Taswala, my other friend, Dr. Umesh Revandwar, who is Vice President IMA Maharashtra, and Dr. Nilesh Tapre. I think with this particular team, I am amazed to see 15,000 as delegates at such a remote place in Maharashtra, who is organizing this particular online meet conference. And I think it is first of its own kind. Thanks to Corona pandemic, probably this particular talent amongst you people is seen by this particular way, because otherwise it would not have been possible. Many of you must have presented in physical format at various conferences. I have seen many more specialities working at places like KHAMGAON, Buldhana, Akola, Amravati. There is much more talent hidden in this part of Maharashtra. And Vidarbha is much known for its talent. And recently we have heard one name from that area of Maharashtra, Dr. Himmatrao Bavaskar, who has received Padma Shri recently. I think the talent is not only in metros like Mumbai, Pune, Aurangabad, and Nagpur. I think there are many more places. Only the thing is, this talent has to be recognized by all of us. Not to forget that many more big people, they are from small, remote places in Maharashtra and India. I think with this tradition, I remember as president of Maharashtra Ophthalmological Society, I had that mission, and that was MOS Aplyadari. Under my presidency, I tried to visit whole Maharashtra places. Almost all districts of Maharashtra were visited by me. And in that mission, I had visited Buldhana Ophthalmological Society. My great friend there at Buldhana, Shon Chinchole, he had great hospitality and organized the wonderful CME along with Buldhana Ophthalmological Society and other IMA branches in that area. And that time I had the visit to Shegao Temple. Gajanan Maharaj visit. That particular route was on the way to KHAMGAON. And I shouldn't forget the visit to Mende family, the great hospitality by these people. And then I came to know that there were stalwarts in that part, even at KHAMGAON, Buldhana, Akola. When I heard few of the lectures since yesterday, I think like cardiology, pathology, then urology, then almost touching each specialty and super specialty. What a talent. What sort of presentations I could listen. The remarks, the chairpersons and moderators, they were wonderful. I think this hidden talent must come forward at state level as well as national level. One more thing I would like to emphasize here, that most of you are members of your own society. Like ophthalmologists are members of ophthalmological associations. Urologists are members of urological association. Pathologists are members of pathologist association. Gynecologists are members, then pediatricians are members of their own societies. But there is one apex body amongst us. And that is the main organization which is taking all of you along together. That is Indian Medical Association. Dear friends, at national level, we are almost 3 lakhs members, active 3 lakhs members at Delhi headquarters. And in Maharashtra, we are 50,000 members. Whenever we are dealing with academics, I think you are very well connected with your own branch, because academics is taught in your conferences, in your CMEs. There are talented speakers that are teaching you your own pediatrics, your own gynecology, your own ophthalmology, and you are happy with these associations, their CMEs and conferences. But when the issue of violence comes, when the problem of medical legal aspect comes, when the government rules and regulations and authorities are troubling you, when there is a problem of hospital registration, where are you? Then you are in need of your association, probably, which is not that efficient in getting connected to government and various organizations which are forming the rules and regulations. And in that case, at that particular point of time, probably Indian Medical Association is the organization which is taking to the root problem of that particular cause. May it be hospital registration, may it be medical legal aspect problem, may it be some rules and regulations which is troubling to you a lot. So here, I humbly appeal all of you, though you are member of your own association, your own specialty, your own super specialty, you must be member of Indian Medical Association. Dear friends, you must be members of Indian Medical Association. I know But you have to motivate your colleagues, your friends, your relatives, your batchmates, your classmates, and whatnot, and ask them to get this membership of Indian Medical Association. I think whenever there is violence in your city, it is an unfortunate incident. It is an unfortunate situation. All of us have to come together for that cause of violence. Suppose there is some medical legal issue. Suppose there is some 304 and 304 application by police department. In case of unfortunate death in medical fraternity, that particular patient troubles you a lot. The patient goes to police department and asks, and probably, unfortunately, police department lodges the complaint under 304, and that particular 304 is non-bailable. But there is provision of the law under 304A, which is the bailable one. And when you have to explain this thing in medical legal aspect point of view to police department, it is the IMA. It is the team of IMA, medical legal experts who are there under the heading of IMA helping you a lot. And that need is only taken care if at all you are the member of an Indian Medical Association. Another thing is, today I'm very happy to see more than 1,200 up to 1,500 are the members logged in for this conference. Very happy. You are eager to take the knowledge. It is the feast of knowledge. But dear friends, it is a half truth. Let me tell you, it is not only the knowledge which is taken to you to this conference. Other hidden thing is you want MMC credit points also. That is the need of the hour. You have to renew your renewal registration. That particular renewal was due at the end of next month. That was February end. And now because there are no MMC points with many more doctors, I think it is extended up to June end. So you are taking this opportunity. I must thank Dr. Sureka Mende madam because he has organized this event with very less amount as registration charges, and you are going to get 4 MMC credit points. Dear friends, sitting at your own homes, you are attending this conference. You need not move here and there for getting these MMC credit points, which very less registration charges. I think who is doing this? Who is licensed with Maharashtra Medical Council? Good and bad points, whatever are they, Indian Medical Association is negotiating all these things for you. These wonderful CMEs and conferences across Maharashtra are being organized by our apex body, parent body, that is Indian Medical Association. At each and every district, there are almost 225 branches across Maharashtra. Not only metros I have talked about, that is Pune, Nagpur, Aurangabad, Mumbai. Not only districts like Akola, Amravati, Buldhana, but places like KHAMGAON. They are also taking this interest because our members must get MMC credit points. And by that, you are also gaining the knowledge. And collection of 30 MMC credit points for 5 years is not much more asking for you. I think the big period of 5 years was there, but many more of you couldn't collect these credit points. So take this opportunity. There is also one important news for people, those who have crossed 65 years of age. They need not collect MMC credit points, but still they have to apply for MMC registration renewal. There is a question in many more minds of people, what IMA is doing. See, IMA is doing so many things for you. Only thing is IMA does not have got that particular right to punish or to apply some laws against the patients who are troubling to medical fraternity or to deal with government for various rules and regulations. It is the body which connects government with you. It tries to negotiate on your behalf, like medical legal aspects and various rules and regulations have told. But in addition to this, there are various wings of IMA. There are various schemes of IMA. I'm going to elaborate few of them one by one. First one is CGP, that is College of General Practitioners. So CGP wing is very active at national level, state level, and in your branch also, you can take this membership of CGP. For that, you can be family physician or even specialists, they can become members of CGP. Next important thing is AMS, that is Academy of Medical Specialties. Like most of us are specialists. You can become member of AMS, that is Association of Medical Faculties. Next important thing is HBI, that is Hospital Board of India. Most of you are running the hospitals, your own hospitals. There are problems of hospital registrations in your city, like corporations and various bodies, they are troubling you a lot for renewal of your hospital registrations. There are various issues like fire NOC and biomedical disposal. So many things like rules and regulations. In that case, HBI, that is Hospital Board of India, is helping you a lot. There is Maharashtra body of HBI. You can get membership of this. Then PPS, that is Professional Protection Scheme. Like in medical legal problem, if you are facing, unfortunately, that particular PPS is the wing of IMA Maharashtra state, which is tackling on your behalf all those medical legal problems at various court and litigations level. Only the thing is you have to become member. The PPS office is situated at Nagpur. You can avail that membership. Next important thing is Social Security Scheme. Since last 2 years, I was secretary of Maharashtra State Social Security Scheme. If your age is less than 60 years of age, you can take membership of Social Security. You can pay 200 per day of members of Social Security Scheme, and that you can contribute for them. In Marathi, what we call Swartha ani Paramartha. You can pay for families of the deceased members. In turn, your families will be benefited at the end of your death. So you are not going to waste your amount. Other thing you also can keep in your mind that you are trying to give benefit to the family members of the deceased doctors. Suppose you are going to marriage ceremony or some birthday ceremony, you are going to give some gift. But in the unfortunate death of the member, you just go there, you show your sympathy, you pay your homage, but you don't give anything. So this way you can help your colleagues. That's what the thing you can keep in your mind. The next thing is, like for the lady members, I saw here at this conference, that is Mission Pink Health. That is like anemia problem in women, and most of the social aspects are covered under that mission. Most of the doctors are junior doctors. What they feel, why to become IMA members? We have got not connected to this particular branch of IMA. So those doctors, catch them young. So junior doctors wing is one important wing of IMA. Then medical social network, the same way medical students, when they are in medical colleges, they also can get connected to Indian Medical Association. That is medical students network. So dear friends, there are many more problems in front of medical fraternity, like Clinical Establishment Act, then government rules and regulations like anti-cut practice law. They are going to trouble you in future. So get connected to IMA. Here, I'm very happy to see that all interactions are done here. I must congratulate to the organizers, the team IMA KHAMGAON, and I'm happy to say that you have invited me as chief guest. I'm very thankful for that. Thank you. I've taken your sufficient time of your conference. I'm not going to talk much more. Thank you so much for giving me the opportunity. Thank you.
Thank you, Dr. Marathi sir, for your kind words and suggestions and guidance. Now the next dignitary on dais is Dr. Jignesh Toswala sir. He is President Maharashtra Ophthalmic Society. He passed out MBBS MS Ophthalmology from BJMC. He had done super specialization in vitreoretinal surgery in Sankara Netralaya. He is director of Darshan Eye Care Center, Pune. He is a senior ophthalmologist doing private practice for 34 years since 1987. He has held numerous positions on various platforms as President-elect MOS, past President POS, Member Advisory POS. He is Section Editor, International Journal of Ophthalmology. He was International Conference Coordinator of MOS Tashkent, MOS Spain and Portugal, MOS Scandinavia, MOS South Africa, MOS Croatia and Austria. He was Organizing Secretary, POSCON 2008, Organizing Chairman, POSCON 2010, Organizing Secretary, MOSCON 2011. He was past Secretary, MOS and POS. He is Honorable Faculty for City, State and National Conferences, also faculty for Surgical Skill Transfer course at AIOS, MOS and POS. He was for an Honorable Conference Coordinator for POS Bhutan. He is Honorable Ophthalmologist at Loyan Mukundrao Lele Hospital for last 30 years. He is consultant at Sahyadri Hospital and Inamdar Hospital, Pune. Taswala sir awarded for Sahebrao Satyavati Award by POS for excellent work in community ophthalmology. He is also awarded as Doctor of the Year Award by Pune Congress Committee. Sir has done enormous charitable work as he participated in mega eye camp, both diagnostics and surgical in Kenya. He is serving for 30 years as consultant ophthalmologist at Loyan Mukundrao Lele Hospital, where he conducted eye OPD once a week and operated 4 surgeries every fortnight since last 30 years. He had organized more than 5 charitable eye diagnostic camps under Om Mahavir Charitable Trust. He is doing dedicated honorary services for 5 years as past consultant at Jalaram Mandir Trust, Alandi. He had conducted more than 50 diagnostic eye camps at his own center since last 30 years. I am honored to welcome such multidimensional personality, Dr. Taswala sir, as a chief guest for KGCON 2022. Over to you, sir. Sir, you are muted.
Sorry. Thank you, Dr. Vinod Rajankar, for an excellent overview of my biodata and my resume. At the outset, I would like to thank Dr. Surekha Mende. She is my classmate. She had invited me as the chief guest for this 2022. I've been observing all the speakers and the people who are the guests and the faculties. You are an excellent faculty lined up. The way it is going on, it's at the state and the national level webinar that you're doing. It's a hybrid webinar where we are sitting in Pune and inaugurating the session. I would like to congratulate the whole of the organizing committee of the KHAMGAON, especially Dr. Surekha Mende, Dr. Anand Rathi, all the office bearers of KHAMGAON, Indian Medical Association. They have done enormous work to see. She had asked me, okay, we want some technical support. How are we going to do it? We have a network problem. So our Entort Pharmacy is always there to help us at the Maharashtra Ophthalmological State Society level. So I told her, we please see to it. And now today we see the network and the whole of this 1500 plus delegates have come up. And a very nice lecture by my close friend, my classmate, Dr. Prakash Marathe. And of course, Dr. Revanwar is going to come up, and Dr. Kapre, Nilesh Kapre, my co-chief guest. I told her, Papa, we'd like to have a short presentation. So I would like to just share the screen and talk about my life journey, which is going to be an inspiration not only to the ophthalmologists, but all doctors at large, all the doctor fraternity. So can I do this screen sharing, please?
Yes, sir.
Just give me a minute. Huh? Yeah. Can you see me and hear me very clearly?
Yes, sir. Yes, sir.
Yeah. So I have very tough journey throughout, right from my childhood days till I finish my MBBS, post-graduation, and of course during my practice also. So In the school days, we had only one dress to be used over a period of 3 years, which had to be altered multiple times to fit, and just a pair of shoes to be used till you outgrow the size. At the times we had one meal a day because of the severe financial constraints. Tuition fees of all three, we were elder brother and younger sister were paid with his share of public provident fund. The first day of my MBBS in 1970, my father, who is the sole bread earner, was in hepatic coma, where the chances of survival were just 0.1%, that is almost negligible. So we were really shocked to go. So then one of their close friends, Dr. Pai, who was managing my father's, we took a second opinion of Dr. H.V. Sardesai, so he turned out to be a savior, and my father was saved. And because of his survival, I could become a doctor. So the first day of my medical college, I had a big issue whether to go in for it or leave MBBS. Then I did my MBBS in 1982, got admission after fighting for my MS ophthalm seat. Again here, I had to fight a court case because the university had given my seat, that is the open category seat, to the one person who had lesser marks. And then we had to fight in the High Court of Bombay. So again, the University of Pune. And then ultimately we won the case, and the Pune University was directed by the High Court to create two seats. One for me and for my friend, Dr. Wagmare, the OBC category. And that is how the screen is not moving forward. Yeah. After I won the case, we did my MBBS, and then my first thing was to do some super specialization. So I'd applied for Shankar Nethralaya and also Professor Nagpal at Ahmedabad. Luckily, I got for both. But then I opted for Shankar Nethralaya because it's a premier eye institute next to AIIMS. So there my Dr. Badrinath, he is the chief of the Shankar Nethralaya, was there to take my interview. And I had passed out from a center where checking patients on a slit lamp itself was luxury. So Prakash will be witness to this. There was a pyramidal system there, where in case you don't function properly and you don't work qualitatively, every 3 months, the non-performers were thrown out. So I passed through all stages seamlessly. In fact, I was offered a 3-month extra diabetic research fellowship as chief was impressed. And then I went through it. Once I was back in Pune, daddy had just retired. So again, we had no earning member. My brother was also doing my studies, also looking for a job. So there was no source of income and no house to stay. We did not have because that were company quarters where we used to stay in the bungalow. All the load was on me to carry on the bandwagon. Absolutely with no savings, I had to take a loan. No guarantors were there. That time the banks used to ask for guarantors to sign even a bank document to give me a loan and to buy a medical equipment and a scooter. My schoolmate became a savior by standing as a guarantor. To buy a clinic or the house, everything was on rent. The first decade of my private practice, we were charged a sum of 30 rupees as consultation charges and 400 rupees for cataract. So overall, the monthly collection would just cover my expenses. In fact, to meet the expenses, I had to go to the outskirts of Pune, 50 to 100 kilometers daily, traveling on a scooter, carrying the refraction box, and screening patients at every GP's door. So any the month to buy a clinic or buy a home for my aged parents. Facing a lot of family issues immediately after starting my practice. My wife, the first one who had a psychiatric problem, a lot of had a normal child who had a whole lot of congenital problems, who had to undergo 8 surgeries in the very first 5 years of life. Simultaneously, fighting family court case where I was falsely implicated, which ultimately led to the divorce. Unfortunately, after my second marriage also, within 2 years, a lot of marital problems cropped up as she was suffering from severe bipolar depression. So, my father also fell down and was bedridden for 5 years. and I ultimately had an untimely device in 2005. My brother, who came to stay with me due to his family discord and went into very severe depression as he had huge financial losses in his business and had exhausted all my dad's funds, provident fund. Fully drained, repaying loans for my clinic, my residence, medical and surgical equipments, all expenses of others. Me to tune of 20 per month, 2,000 crore for almost 70 years, medical expenses for my ailing father. My mother also had fallen ill, my brother who was already under depression, and my child who had lots of problems. So mental agony of managing single-handedly my own family with psychiatric problems, my critically ill and bedridden aged parents, and facing family and criminal court cases, and also managing home and my clinic, and of course, no godfather to help me out. My brother had a lot of family discord, so much so that I had to admit him in a mental hospitals multiple times. Ultimately lost him in 2015. Following that, she had morbid obesity and developed hypertension and diabetes and was bedridden for 7 years, and I lost her in July 2020. My only child is now with me. Seeing all this, he also ended up in depression, is undergoing psychiatric counseling and treatment. Due to his physical and mental problems, he was not doing well in academics, was pursuing law and could not pass in spite of multiple attempts. So I made him leave and join optometry. Under my guidance, he passed optometry with flying colors and got a distinction, and now he's with me in my center for further training. Side by side, my professional front. After putting 10 years of my practice, I had a margin money to take another bank loan to buy my own center, my surgical equipments and instruments, and also my residence. Going up the society ladder, I became the joint secretary, and then the president of a local Pune Ophthalmological Society in 2010. Side by side, fighting a court case in a different city, Baroda, that is 900 kilometers from Pune, visiting their family court every month. Then I took over as the secretary of the second largest society in India, that is the Maharashtra Ophthalmological Society in 2013. Then I applied for the vice presidential in 2014, but had to withdraw, respecting a senior advisor in favor of another candidate. Then again fought an election and lost in 2018. I fought another election and then won the home ground of the opposition candidate with a reasonable margin. Now that the COVID times had come, instead of repenting loss of revenue and practice, I started organizing a series of investment webinar for all the ophthalmologists all over India with a viewership of more than 1,000 plus members for each webinar, so they earn an alternate source of income. Learned a lot of hobbies, that is palmistry, feng shui, Vedic astrology. Then as I took over as the president this year, and on the 30th of October, where I came up with novel ideas and started 2 months, my work, all my preparation 2 months prior to my taking over the baton of presidency. I formed up 21 committees, which are already with a theme of overall wellness of the MOS members beyond ophthalmology. No president in the history of MOS has formed so many committees till now. I'm also now working on a day-to-day basis to see that all committees function optimally, and I've already taken Zoom meet with all the committees with the president, secretaries of all over Maharashtra. Different committees, why I'll give you this idea at the IMA level, you can also try and implement certain parts of these committees for the overall wellness of the IMA members. Mentor and mentee committee, what we have, the Guru Shishya Parampara that we have, that was the first in my mind. Then the personality development in public leadership, diabetic retinopathy screening awareness, young ophthalmology, the youngsters have a different ball game altogether during the practice. Women empowerment, the academic committee. Then we have the yoga and meditation. Well, the yoga and meditation, as everybody knows, helps in stability and good health. Sports committee, of course, you know that sports is an integral part of everybody's life. Cultural committee, grievance committee, legal committee, the advocacy committee, where we liaise with the government to solve our issues. As I said, majority of the committees have got so much of benefits that automatically, the moment I took over, people started calling me, I want to become an MOS member. So if you have certain things which are for the benefits of over research, e-library and e-journal club, then we have the committee to keep things ticking, financial literacy committee, public awareness committee. Well, public awareness, as you see, there are a lot of negative feelings of in the eyes of the public. So this year we are trying to focus to see that a positive image is created of our members, not only the ophthalmologists, but overall all the doctors. We are holding TV programs. Next month, we are coming up with an issue where we have doctors and public relationship. Renowned doctors from MOS are going to showcase and tell them on the SAM TV. We are having a program on the 22nd. Do listen to that. Fundraising committee, professional indemnity committee. We have all the insurance for our doctors at 1/3 the rates of what the other insurance companies try and give. And then for the international observership, and that's why this committee. So this is how we are functioning. Overall, this should be a motivation for the youngsters and all at large. I thank once again Dr. Surekha Mende, Dr. Anand Rathi, and the office bearers of KHAMGAON IMA to have invited me for this prestigious function. I wish you all the best for the remaining part of the conference, and we declare it open. Thank you very much.
Thank you, Dr. Taswala, sir.
Yeah.
It was very interesting to know your life journey. There are so many hidden messages one should follow. Thank you, sir. Next dignitary on dais is Dr. Umesh Revanwar, sir, practicing ophthalmological surgeon at Sunetra Eye Hospital, Pusat, Yavatmal. He is Vice President, IMA Maharashtra State. He has been awarded Best President, IMA Maharashtra State and IMA Headquarter. He has been awarded Best President, Rotary District 3030 in Centennial Year. He was President, Vidarbha Ophthalmic Society. He was Treasurer, Maharashtra Ophthalmological Society. We welcome Dr. Umesh Revanwar, sir, as a chief guest for KGCON 2022 and request him to share his thoughts.
Hello.
Yes, sir.
Everyone is visible?
Yes, sir. Yes, sir.
Yes, yes.
Yeah, thanks. IMA खामगाव. सर्वप्रथम मी IMA खामगावच्या सगळ्या कमिटी मेंबरचं मनस्वी अभिनंदन करतो की त्यांनी आज इतक्या चांगल्या रीतीने हा सेमिनार 2 दिवसापासूनचा सेमिनार अरेंज केला आहे. सर्वप्रथम मी अभिनंदन करतो प्रेसिडेंट डॉक्टर सुरेखा मेंढे आणि ऑर्गनायझिंग कमिटी चेअरमन डॉक्टर आनंद राठी आणि पूर्ण खामगाव IMA टीमचं. खरोखरच खामगाव ही जरी सिटी ही सिल्वर सिटी आहे, पण तिथील आज इथल्या डॉक्टरांनी एक गोल्डन चान्स म्हणजे जळगाव पेक्षाही चांगला चान्स त्यांनी आयोजित केला आणि हा कार्यक्रम आयोजित केला आहे. सर्वप्रथम मला इथे डायसवर आज तिथं निमंत्रण दिल्याबद्दल त्यांचं सुद्धा मी मनस्वी आभारी आहे. आणि आताच डॉक्टर मराठे सर आणि आमचे ऑप्थॉलॉजिस्ट प्रेसिडेंट डॉक्टर जिग्नेश तासवाला यांनी IMA आणि त्यांच्या लाईफ जर्नी विषयी आपल्याला सगळ्यांना सांगितलं आहे. मी आज इथे सगळ्यांसमोर एक विनंती करतो की सगळ्या जे आपले डॉक्टर फॅकल्टीज आहेत त्यांनी सर्वात पहिले की IMAचं लाईफ मेंबरशिप घ्यावं आणि जे जॉईन झाले नसेल त्यांनी IMAचं लाईफ मेंबरशिप जॉईन करावं आणि ज्या ब्रँचेसमध्ये जे मेंबर झाले नसतील त्यांनी आज लाईफ मेंबरशिप ही जॉईन करावी आणि सगळ्या ब्रँचेस या IMAच्या लाईफ मेंबर बनावं अशी माझी इच्छा आहे. दुसरी गोष्ट जे मराठे सरांनी सांगितलं आहे की IMAचं जे स्कीम्स आहेत त्या स्कीम्स मध्ये पार्टिसिपेट करणं ही IMA मेंबरची सुद्धा जबाबदारी आहे. कारण की IMA ही आपल्यासाठी जागृत असलेली संस्था आहे, आपल्याला मदत करणारी संस्था आहे. त्यामध्ये ज्या सोशल सिक्युरिटी स्कीम आणि प्रोफेशनल प्रोटेक्शन स्कीम ह्या आपल्या जीवनाशी निगडित असलेल्या स्कीम्स आहेत आणि या स्कीम मध्ये सुद्धा प्रत्येक IMA मेंबरनी जॉईन व्हावं अशी मी आपल्या सगळ्यांना विनंती करतो. आपण बरेचदा आपल्या फॅकल्टीमध्ये जसं आमची ऑप्थॉलॉजी आहे, ऑर्थोपेडिक आहे, सर्जन्स फॅकल्टी आहे, त्यामध्ये जॉईन होतो. परंतु बेसिक जे आहेत ते IMA, आपण पहिले IMA मेंबर आहे, नंतर सुपर स्पेशालिटीचे मेंबर्स आहोत, हे लक्षात ठेवायला पाहिजे. आणि प्रत्येकाने IMA मेंबरशिप जॉईन करायला पाहिजे. कारण ज्या वेळेस कोणत्या एखाद्या मेंबरला जेव्हा अडचण येते किंवा डिफिकल्टी येते, आपली ऑर्गनायझेशन जी आहे, जी आपल्या स्पेशालिटीची जी ऑर्गनायझेशन, ती आपल्याला मदत करते. परंतु शेवटी फायनल मदत जी मागायची असते ती IMA कडेच जावं लागते आणि IMAच त्या मेंबरला प्रत्येक वेळेस मदत करते. मग मेडिको लिगल अस्पेक्ट असो, डॉक्टरांवरील हल्ले असो, किंवा एखाद्यांचा निग्लिजन्समुळे जो काही त्रास झालेला असेल, किंवा पेशंटच्या मिसबिलीव्हमुळे सुद्धा जे त्रास झालेला असेल, ते सगळं सॉल्व्ह करण्याची जबाबदारी आपले सिनियर IMA मेंबर्स करत असतात. आणि आज या प्रसंगी मला आमचे IMAचे रोटरीचे मेंबर सुद्धा डॉक्टर आनंद झुंझुनवाला, हे सुद्धा खामगावचे आहेत. ते पुढच्या वर्षी गव्हर्नर बनत आहेत रोटरी डिस्ट्रिक्ट 3030चे, आणि माझ्याकडे येऊन गेलेले आहेत ते. तर या आनंदचं सुद्धा मी इथे खरोखर अभिनंदन करतो की आनंदनी सुद्धा या कार्यक्रमामध्ये सेमिनार अरेंज करण्यामध्ये खूप मदत केली आहे. मेंढे मॅडमचं मी सुद्धा अभिनंदन करतो. ते त्या फार टेन्शन मध्ये होत्यात की MMCचं रजिस्ट्रेशन मिळेल की नाही, क्रेडिट पॉईंट मिळेल की नाही, त्याच्यानंतर व्हर्च्युअल होईल की फिजिकली होईल. तर त्यांनी ह्या खूप चांगल्या रीतीने खूप मेहनत करून पूर्ण टीमनी आज हे 1500 डॉक्टर्सला अटॅच केलं. आणि ही CME जी अरेंज केली आहे, ही त्यांनी फार प्रॅक्टिकल टाइमला अरेंज केली आहे की प्रत्येक मेंबरला आज रिन्युअल मध्ये त्रास होत आहेत. कित्येकांनी आपले रिन्युअल पॉइंट्स कधीच जमा केलेले नाहीत. आणि अशा वेळेस खामगाव IMAनी इनिशिएटिव्ह घेऊन छोट्या ब्रँचनी, मोठ्या सिटीतल्या ब्रँचेसनी, अकोला, अमरावती, नागपूर, यवतमाळ सारख्या ब्रँचेस नेहमीच घेत असतात, पण छोट्या ब्रँचनी हा इनिशिएटिव्ह घेऊन हे सगळ्यांसाठी मदतीचं काम केलं आहे. त्याबद्दल पूर्ण टीमचं मी अभिनंदन करतो आणि धन्यवाद देतो.
Thank you, Dr. Umesh Revanwar, sir, for your suggestions and guidance. Next dignitary on dais is Dr. Nilesh Tapre, sir. He has done his MBBS from Provaram Institute Medical Sciences, Ahmednagar, and DOMS from Rajawadi Hospital, Mumbai. He worked as registrar at Jaslok Hospital, Mumbai. He worked as a medical officer and RMO at General Hospital, KHAMGAON, and currently working as medical superintendent at General Hospital, KHAMGAON. He was Vice President MAGMO and President of IMA KHAMGAON. He has done enormous charitable work, participated in multiple eye camps held at many places all over the state. He has played a major role in management of COVID-19 pandemic last year. As an ophthalmic surgeon, he has operated more than 6,000 cataract patients. Recently, he is awarded with Samaj Gaurav Puraskar in 2021. He has received number of awards from many organizations for his splendid work during COVID pandemic. We welcome Dr. Tapre sir as a chief guest for KGCON 2022 and request him to say few words.
राजेंद्र सर, सर्व डेलिगेटचं IMA खामगावच्या 18व्या अॅन्युअल CME KGCON 2020 मध्ये स्वागत आहे. सर्वप्रथम मी जे ऑर्गनायझिंग टीम आहे त्यांचं अभिनंदन करतो. IMA खामगावच्या प्रेसिडेंट डॉक्टर सुरेखा मेंढे मॅडम, सेक्रेटरी डॉक्टर विनोद राजनकर, ट्रेझरर डॉक्टर अतुल राजपूत, CME ऑर्गनायझिंग सेक्रेटरी डॉक्टर आनंद राठी, जॉईंट ऑर्गनायझिंग सेक्रेटरी डॉक्टर अनिकेत मेंढे, वुमन्स विंगचे प्रेसिडेंट डॉक्टर रश्मी राजनकर मॅडम, सेक्रेटरी डॉक्टर स्मिता देशमुख मॅडम, आणि संपूर्ण IMA टीम खामगावचे मी अभिनंदन करतो की इतके चांगल्या प्रकारे आपण हे वेबिनार आयोजित केलं. जसं मी म्हटलं, हे 18वं अॅन्युअल CME आहे. खामगाव सारख्या छोट्या टाउन प्लेस मध्ये 19 वर्षा आधी आपण ही परंपरा चालू केली आणि ही लेगसी आता आपल्या या टीमनी पण चालू ठेवली. 19 वर्षा आधी जेव्हा MMC पॉइंट्स नव्हते कंपल्शन नव्हतं त्यावेळेसही ग्रामीण भागातील डॉक्टरांचं नॉलेज अपडेट करण्यासाठी खामगाव IMA ने पुढाकार घेऊन CME ऑर्गनाईज करणं सुरुवात केली व त्यावेळेस फिजिकल CME मध्ये चांगला रिस्पॉन्स भेटून मोठ्या प्रमाणात डेलिगेट्स ह्या CME अटेंड करायला यायचे. पर्यंत आपण 19 वर्ष चालू ठेवली आणि मला सांगायला अभिमान वाटतो की IMA खामगावने दरवर्षी जेव्हा कोविड पॅन्डेमिक नव्हतं तेव्हा दरवर्षी म्हणजे मंथली CME ठेवायचे आणि ॲन्युअल CME व्हायचे. मी आजपर्यंत माझ्या स्वतःचं मी पर्पजली फक्त IMA खामगावच्या CME मध्ये झालेले क्रेडिट अवर्स हे माझ्या रिन्युअलसाठी नेहमी वापरले आणि तितके सफिशियंट असायचे. IMA खामगाव ऑर्गनाईज केलेले क्रेडिट अवर्स रिन्युअलसाठी जितके लागतात तितके सफिशियंट असायचे आणि ग्रामीण भागातील ह्या सर्व डॉक्टर्ससाठी रिमोट एरियामध्ये काम करणाऱ्या वैद्यकीय अधिकाऱ्यांसाठी ही CME फार वरदान आहे. खामगाव IMA जी ऑर्गनाईज करते ज्याच्यात डेलिगेशन फी 100 रुपयापासून सुरू होते मंथली CME ची आणि 1000 रुपये मॅक्झिमम. कमी याच्यातही आपण IMA खामगावनी जो 18-19 वर्षापासून पुढाकार घेऊन सातत्याने जी CME ऑर्गनाईज केली त्याच्याबद्दल मी संपूर्ण खामगाव IMAचं अभिनंदन करतो. आणि सोबतच आम्हाला मदत भेटते शेगाव IMA, नांदूर IMA, जळगाव जामोद आणि पश्चिम विदर्भातील सगळ्या छोट्या मोठ्या जिल्ह्यातून आम्हाला इथे या CME साठी मदत भेटते. तर मी सर्वांचे अभिनंदन करतो. आणि मागच्या वर्षी जसं कोविडची एकदम सेकंड वेव्ह होती आणि त्यामुळे फिजिकल CME आम्हाला घेता आली नाही, फक्त 1 वर्षाचा खंड पडला. पण या वर्षीच्या टीमनी प्लॅन A प्लॅन B दोन्ही तयार ठेवला होता. फिजिकल CME पण घ्यायची आणि वेबिनार पण घ्यायचं. याचं प्लॅन वेल प्लॅन 1-2 महिन्यापासून यांची तयारी होती आणि फिजिकल CME आम्हाला घेता नाही आली. तर हा वेबिनार फार चांगल्या पद्धतीने आपण आयोजित केला. त्याबद्दल मी संपूर्ण IMA खामगावच्या टीमचे धन्यवाद देतो. धन्यवाद.
Thank you, Dr. Nilesh Tapre, sir. Now I welcome Dr. Nilesh Tiblewal, sir, as observer for this CME. Dr. Tiblewal, sir, has done MBBS MS from GMC Nagpur. He is practicing as general surgeon and endoscopist at KHAMGAON since 23 years at Sanjeevani Hospital. He is a director at Silver City Multi-Speciality Hospital, KHAMGAON. I request Dr. Nilesh Tiblewal, sir, to say a few things.
Good morning, everybody. मंचावर उपस्थित सर्वांना मी इथे स्वागत करत आहे. मी माझे शब्द फक्त 2 मिनिटात संपवतो. मी फक्त ऑब्झर्वर म्हणून इथे मला अपॉइंट केलेलं आहे. मी ऍक्च्युअली पॅरेंटल इथेच IMAतच मेंबर आहे. तर मी आता कालपासून हे वेबिनार पाहत आहे. फार चांगल्या प्रकारे व्यवस्थित एकदम सायंटिफिक तरीकेने एकदम व्यवस्थित तरीकेने हे सर्व अरेंज केलेलं आहे. त्याबद्दल मी ऑर्गनायझिंग कमिटीचं अभिनंदन करतो. आणि आता पुढे आपल्याला जे पॉइंट्स 4 पॉइंट साठी आपल्याला MMC कडे सर्व डिटेल्स पाठवा लागेल. तर ऍज अ ऑब्झर्वर माझी जे काही मदत लागेल मी तुम्हाला पूर्णपैकी माझ्याकडून देईल असं मी आश्वासन देतो आणि माझे 2 शब्द संपवतो.
Thank you, sir. Our second observer is Dr. Ajabrao Vasu, sir. He has done MBBS DGO from GMC Nagpur. He is a life member of Indian Medical Association, Indian Society of Colposcopy and Cervical Pathology, AOGIN, FOXY, ISEOG, Fetal Medicine Foundation. He has done 2 paper presentation in International Conference AOGIN 2010 and IFCPC 2020. 1 paper presentation in National Conference AICOG 2015. 2 paper presentation in State Conference AMOGS He was medical officer at General Hospital KHAMGAON and doing private practice at Chikhli, Buldana. He has a special interest in colposcopy. He is WHO IARC certified master trainer in cervical pre-cancer diagnosis and treatment. He is Foxy recognized colposcopy trainer. I request Dr. Vasu sir to enlighten us with his thoughts. Over to you, Dr. Vasu sir.
Thank you for inviting me. Dignitaries on dais. Really, this is a very good CME protocol for general practitioners and specialists also. I am in touch with KHAMGAON Medical Association since 20 years. Really, they are conducting very good CMEs. Really, that helps, benefits the general practitioners also. So I am very thankful for invitation. I am observer for this CME. Really very good topics are covered in this CME. Thank you very much for inviting me. Thank you.
Thank you, sir. Now I conclude this inauguration session and I invite Dr. Amrish Khatod for his lecture on various thromboembolic episode in post-COVID patients. For this session, I invite Dr. Gulab Pawar and Dr. Samruddhi Mende to chair this session. I request Dr. Samruddhi Mende to introduce our speaker.
त्याचं नाव नको मी म्हटलं तर हे करून देणार इंट्रोडक्शन वाचून देणार मी इंट्रोडक्शन मी वाचतो कन्क्लुडिंग तिला देता की कसं व्हायचं वर्ष.
We have pleasure to inform you that Dr. Amrish Khatod has joined as consultant in Department of Cardiovascular and Thoracic Surgery. He completed his MBBS from TNMC Mumbai, MS from IGMC Nagpur, and MCH CVTS from JJ Hospital Mumbai. He has years of experience as assistant professor at Super Speciality Nagpur. He has excellent track record with 500 cardiac surgeries, 1,000 vascular surgeries, and 200 thoracic surgeries, having more than 6 years of experience in several hospitals. The following are his areas of special interest: CABG, bypass surgery, varicose vein management, lung and vascular surgery, AV fistula surgery for dialysis.
Amrish Khatod, sir.
He is joining soon. Actually, he had some emergency. He is coming back.
Yes, sir. Yes, sir. Sir, you are muted. Kathod, sir, you are muted.
Hello?
You are audible.
Yes, please. 1 second, please. I'm just casting my screen. Sorry for the delay. I'm just loading my PowerPoint presentation. 1 second. I'm just linking my computer with Zoom. Just give me a second. Yeah, is my screen visible?
Yes, sir.
Yeah. Should I start?
Yes, sir.
Yeah. Good morning to everyone. Actually, it's afternoon. First of all, I like to thank KHAMGAON IMA for giving me this opportunity and considering me worth enough to present my presentation. So my topic for the day will be arterial thrombosis in COVID-19 scenario, variant presentation. I chose this topic for reasons because this is seen mostly in post-COVID patients. Right now we are suffering. We are seeing. Yeah.
We are getting an echo. एक तो लैपटॉप का साउंड बंद करना पड़ेगा या तो मोबाइल का. हाँ, if you are going to talk from mobile and present from laptop, then you'll have to mute the audio from laptop.
Hello.
Yes, sir. You are audible.
Hello. Now I'm not getting any echo, no?
Yes, there is. Now
It's okay, sir.
Sorry. So we are right now currently facing scenario of post-COVID patients presenting with either mucor or arterial or venous thrombosis or pulmonary thromboembolism. So COVID-19, you know, is a very dreadful disease. Not only thrombotic events have been reported in critical patients, critical side, but also are seen in post-COVID phase. It is not only venous and pulmonary thromboembolic phenomenon, but incidents of arterial thrombosis have also been reported. some of them have been really critical and presentations have been unusual. I am presenting you 4 different cases which had very varied presentation, but common symptom was post-COVID. So case 1, it is related to coronary artery thrombosis. You know, as coronary artery thrombosis is a very critical disease. A 35-year-old, very young aged patient presented with symptoms of COVID-19, that is fever and cough, after a history of travel to COVID endemic area. Patient was managed conservatively as per COVID protocols and was on steroids. On day 10, patient was complaining of burning chest pain and epigastrial pain. So initial ECG was done, and you can see there was mild ST elevation in 2-3 AVF. Sorry, I could not get a better image, but 2-3 AVF shows ST elevation, mild ST elevation, but young patient you don't suspect you don't suspect MI. So we repeated a ECG after half an hour, and this is a very clear image. You can see 2-3 AVF have ST elevations of 1.5 something mm. So we decided, since it was post in COVID scenario, we decided to go for a CAG, and CAG suggested of right coronary artery thrombosis. I couldn't get the video of CAG, but it showed a proper thrombus in right coronary artery. Patient was thrombolized with streptokinase. Patient did well and recovered and now on antiplatelet. As vessels were normal, it was just a thrombotic phenomenon. Stenting was not done. Patient was only managed by thrombolysis. Then there was another scenario. In this patient, 45-year-old female presented with pain in abdomen and lower limb numbness on same day. So for USG abdomen was done, and it's suggestive of acute necrotizing pancreatitis post mesenteric artery thrombosis, and Doppler evaluations of femoral and popliteal artery showed complete lumening obstruction in femoral and popliteal artery. And on day 1 swab was done, which was COVID-19 negative, and day 3 swab was done, which showed COVID-19 positive. Patient underwent embolectomy. The pulsations of femoral artery and popliteal artery were recovered, but because of acute necrotizing pancreatitis and severe levels of amylase and lipase, patient later on went to MODS, multi-organ dysfunction syndrome, and succumbed. So these were 2 different cases with different presentation. So there was another patient, 21-year-old male, non-diabetic, no history of tobacco, no history of trauma, presented with acute pain in right lower limb and numbness. This is just a young male with no precursor suggestive of any arterial thrombosis or disease. Patient had no history of fever but came from COVID endemic area. Patient Doppler revealed complete lumen occluding thrombus in femoral artery. Patient underwent femoral embolectomy. A thrombus load was removed from the patient. Histopathology of arterial was done to rule out aorta arteritis or arteritis, but it ruled out negative. So ruling out all the diagnosis, it was probably a post-COVID complication. Patient did well and had this was a thrombus load that was extracted from patient. You can see complete femoral artery with branching, popliteal artery branching thrombosis. I can show you the video also. This was femoral artery embolectomy, which was done for the patient using a Fogarty of number 4. Femoral artery was opened and embolectomy was performed. You can see the Fogarty is inserted in femoral artery. And now with the help of Fogarty, you will see a lot of thrombus load being removed from femoral artery. Here you can see now the fresh clot. The clot has been evacuated, and later on the flow will be established. See, you can see here fresh clot being removed from the femoral artery. So now we have seen a coronary artery thrombosis. We have seen a mesenteric artery thrombosis. We have seen femoral, means lower limb thrombosis. This is another presentation. 82-year-old lady with history of COVID 3 months back presented with gangrenous lower limb. And to my amusement, the patient presented with complete venous thrombosis. It was not arterial thrombosis. Patient developed venous thrombosis and later on developed venous gangrene. Patient was presented with septicemic shock. Patient underwent guillotine amputation, and second day, patient presented with upper limb thrombosis. So patient had lower limb thrombosis, upper limb thrombosis. 2D was done whether there was any thrombus load in heart, but there was no thrombus load in heart. So this was completely out of the book presentation. Means patient had a lower limb venous thrombosis and upper limb arterial thrombosis. The only explanation that could be given in this stage is procoagulation state. That is a consequence of COVID-19, as we all know. So you can see the COVID-19 has presented with different challenges. It has shown, means patient has been presented with different types of symptoms and different types of complications. Two things responsible for COVID-19 patient presenting with such arterial, venous, or you may say coronary artery thrombosis or pulmonary thromboembolism is the inflammatory cascade which COVID-19 patients, which COVID-19 initiates. And second thing is, which can be correlated, is giving corticosteroids. Corticosteroid also causes precoagulant state. So the inflammation caused by COVID-19 also, along with administration of corticosteroids, may be responsible for developing such type of variant artery or venous thrombosis. My take on COVID-19 coagulation thing to the amount of, you may say, prophylaxis to be given is, if the patient is moribund or patient is developing severe symptoms or in an ICU care, thromboarterial prophylaxis should be given in such patients. Patient above 50 years of age should also be put on rosuvastatin and ecosprin. So take home message, ischemia or arterial thrombosis should be kept in mind in this COVID area, because early diagnosis and treatment is key to prevent complication. Either it is arterial thrombosis or either it is venous thrombosis. Early diagnosis and treatment is the key. Presentations are varied and unusual. Sometimes patient presents with paresthesia, sometimes patient presents with pain, sometimes patient presents with difficulty in walking, sometimes patient presents with swelling in both the limbs. The incidence of arterial thrombosis has increased in COVID area, and a lot of patients have landed in amputation or MI. So early diagnosis, treatment, and keeping the diagnosis in mind is key to prevent such complications. Thank you. Finally, again, I thank KHAMGAON IMA for giving me this such opportunity, and thank all the participants for listening me patiently. Thank you.
Thank you,
sir.
Dr. Amrish Khatrod, sir, for your wonderful presentation. Now, I invite Dr. Anand Rathi to give his concluding remarks.
Thank you, sir. As we have seen large havoc in COVID period regarding thromboembolic events like MI, DVT, pulmonary embolism, but you have enlightened us on all topics of thrombosis. You have covered everything and made us very comfortable in our day-to-day practice. Sir, just I want to confirm till how much time we have to continue aspirin?
See, if patient is more than 50 years, and if patient has some history of tobacco intake, or if the patient has hyperlipidemia, patient should be continued on ecosprin. If patient is younger age with no risk, no other risk of any arterial diseases like hypertension, diabetes, then 1 to 2 years aspirin should be continued. And I don't find any role of dabigatran or direct thrombin inhibitors if patient is not critically ill or patient is not sick. If patient is critically ill, direct thrombin inhibitor should be given up to 3 months of post 3 months.
If patient has no any this thromboembolic events, is there a role of anticoagulants in them?
No. I don't think there is any role. It's not helpful. It might be. It is a double-edged sword. So anticoagulation should be used carefully.
Okay, sir. One more thing, if we can start anticoagulation as related to D-dimer levels.
Yes. D-dimer levels are indicators. If D-dimer levels are high, patient should definitely be given thromboembolic prophylaxis.
Sir, is there any cutoff to start this anticoagulation for
there is no such
regarding
study because this is acute. So if patient is moribund or if D-dimer levels are high, should consider for prophylaxis. There is no exact cutoff for such patients. If levels are 2 to 3 times high, they should definitely receive thromboembolic prophylaxis.
Sir, just I will confirm from Dr. Samruddhi, as I have covered this medicinal part, whether she want to ask regarding any surgical like entities.
No.
Okay, sir. Thank you, sir. We are really enlightened and really got our knowledge updated. Thank you.
Thank you.
Thank you, sir. Now,
Thank you.
I invite Dr. Ashish Tapadia for next topic, approach to patient of jaundice in general practice. For this session, I invite Dr. Ashok Bavaskar, sir, and Dr. Deepa Mantri, madam, to chair this session. I request Dr. Deepa Mantri to introduce our speaker.
Good afternoon, everybody. I am Dr. Deepa Mantri from practicing as pediatrician at KHAMGAON. I am here. It gives me a privilege to introduce Dr. Ashish Tapadia. He is a practicing gastroenterologist, hepatologist, and therapeutic endoscopist at dedicated self-owned hospital at Akola. He has done his MBBS from Ahmednagar, and he's diplomate of National Board in Medicine from Pune Hospital. He's also doctorate of National Board in Gastroenterology from Global Health City at Chennai. He has many publications also, like one on C-reactive protein and neutrophil to lymphocyte ratio, 2, metastatic adenoid cystic carcinoma, 3, bacteremia in SBP. He was ex-registrar in medicine at Pune Hospital. He was also the ex-registrar in Hello.
Yeah, you're audible, madam.
Sorry for the disturbance. He was also the ex-registrar in gastroenterology and transplant hepatology. He was the consultant gastroenterologist at, he's the consultant gastroenterologist at his own hospital, Dev Kamal Hospital, Akola. He is interested in teaching and academics. He has many communication skills, and he's full of compassion and empathy. Thank you.
Dr. Ashish Tapadia, sir, you can take over from here. Dr. Tapadia, sir.
हाँ जल्दी कर
there are some network issues, and Dr. Tapde sir is joining soon, and he'll be with us within minute or so.
Where is Dr. Ashok Bavaskar, sir?
He is joining soon, ma'am.
Okay.
I think some network issue must have arisen.
Yeah, definitely.
I think we are running before time.
Yeah. This is the thing.
Unlike Indian Railways.
₹1000 extra discount.
Dr. Tapde sir, you can take over from here.
Okay, thanks.
Yeah, the screen is ready to share.
I'll share my screen.
Yeah.
Welcome, sir.
Thank you, ma'am. Thank you. Thanks, KHAMGAON IMA for giving me opportunity to speak in front of all of you. Thank you. Without wasting the time, I'll just start my topic. Approach to liver diseases. So outline of my talk will be approach to jaundice, approach to deranged liver function on the liver function test. So first, jaundice basics. Yellowish discoloration of eyes is called as jaundice. It is the product of hemoglobin breakdown, that is the metabolite of heme protein, and bilirubin is excreted in stool as a stercobilinogen, in urine as a urobilinogen, and it was and small quantity will goes into the liver through enterohepatic circulation. Normal total serum bilirubin is usually less than 1 mg per deciliter. Biochemically or clinically, it is evident if bilirubin is more than 3. So bilirubin metabolism is once the senescent RBC after 120 days got destructed into the spleen in the heme, and this heme get converted into biliverdin through enzymes biliverdin heme oxygenase, and this biliverdin get converted into bilirubin through biliverdin reductase, and bilirubin then taken complex with the albumin into the blood, and this bilirubin albumin complex is taken into the liver as a complex, and this bilirubin albumin complex in the liver get conjugated, bilirubin conjugated into the unconjugated bilirubin becomes conjugated with UDP, the glucourinosyl transferase, and once it becomes conjugated, it is excreted through bile duct and through the ampulla into the duodenum. In the duodenum, small quantity goes back to liver as an enterohepatic circulation. Rest of the quantity becomes excreted in the stool as a stercobilinogen, and in the urine as the urobilinogen. So what are the types of hyperbilirubinemia? When we call increase in bilirubin, it is of two types, whether it is indirect, direct or mixed. In indirect hyperbilirubinemia, almost 85% of the fraction should be indirect to tell it as a predominantly indirect hyperbilirubinemia. And indirect hyperbilirubinemia, it is unconjugated bilirubin, it is water insoluble. It is increases in increases in case of RBC hemolysis, like hemoglobinopathies, including sickle cell anemia, thalassemia, enzymes abnormality like G6PD deficiency, cell structure defect like hereditary spherocytosis, ellipticocytosis, and in Gilbert syndrome and Crigler-Najjar syndrome. Crigler-Najjar syndrome we usually see in children, and it is of two types, Crigler-Najjar 1 and Crigler-Najjar 2. In 1, there will be complete absence of UDP glucourinosyl transferase activity, so patients will develop kernicterus and brain damage, and 2 is the milder form of the Crigler-Najjar syndrome. In Gilbert syndrome, which we usually see in adults, it is a congenital enzyme defect of lipid glucouranosyl transferase, and there is only decreased conjugation abnormality. Bilirubin usually goes only up to 2 to 5, especially with exertion and fasting, and it is seen in up to 5 to 7% of general population. Then direct bilirubin, to tell it as a direct hyperbilirubinemia, more than 50% fraction should be direct. So in it is a conjugated bilirubin. In liver disease, usually conjugation ability remains intact. So we see predominance of conjugated bilirubin, not unconjugated. Thus, direct bilirubin increase in obstruction, cholestasis, cirrhosis of the liver, hepatitis, primary biliary cirrhosis, or primary biliary cholangitis. Conjugated bilirubin is not elevated until liver loses 50% of its excretory capacity. Then what are the causes of jaundice? So first, we should rule out this older and confusing terminologies. Previously, it used to be echoluric or choluric jaundice. Echoluric is hemolytic, means always in medical jaundice, in that only indirect bilirubin is raised. That is, as I told, unconjugated bilirubin is not excreted into the urine. So in that case, there will urine will be echoluric, and in choluric, that is hepatic, it can be medical or cholestatic. But to avoid this confusing terminologies, we usually use only two words: direct bilirubinemia or indirect hyperbilirubinemia. So what are the causes of bilirubin rise? Isolated disorders of bilirubin increase, that is only increase in bilirubin without enzyme defect. It is seen in either hemolysis, Crigler-Najjar, Gilbert syndrome, Dewey-Johnson syndrome, or Rotor syndrome. And in liver diseases, it is usually associated with increase in liver enzyme, either OT, PT, alkaline phosphatase, or gamma GT. It is seen in acute hepatitis, cirrhosis, primary biliary cirrhosis, or primary biliary cholangitis, infiltrative liver disorders. And in biliary obstruction, we can see in case of CBD stone, malignancy, benign, or other malignant biliary strictures. So first approach will to the jaundice, history and examination. So together, history and examination, usually 80% of the cases we can come to the diagnosis. So first of all, we go to the history. In history of prodrome, that is presence of fever, chills, myalgia, body pain, arthritis, or arthralgia. It usually goes towards prodromal history of viral hepatitis. Then associated fever, either with viral hepatitis or any bacterial infection, or with associated cholangitis, will have fever. Pain in abdomen. Pain in abdomen is usually seen in cases of the obstructive pathologies or gallbladder, cholangitis, cholecystitis. Then hepatitis pain is usually mild. It is only because of stretch of the liver capsule. Then history of alcohol intake, history of drug intake, and surgery. And in examination, we should check for signs of liver cell failure, scratch marks, organomegaly, and ascites. So the important in that is the history. Most important in the evaluation, we should always check for onset, duration, and progress of the jaundice, whether it is static, whether it is increasing, or whether it is fluctuating. Then prodromal symptoms, as I explained. Then alcohol use, exposure to over-the-counter medications, complementary alternative medicines, that is Ayurvedic medications, are usually associated with drug-induced liver injury. Anabolic steroids are associated with liver dysfunction, and even physician-prescribed drugs are sometimes associated with the liver dysfunction. Then parenteral exposures, IV drug abuse, tattooing, or sexual activity. And with this, if the patient presented with jaundice, we should always check for loss of appetite, loss of weight, bleeding tendencies, and malabsorptive states. Because usually loss of appetite, loss of weight, bleeding tendencies are associated with cholestatic jaundice, and in those cases, in elderly patients may have malignancy. So underlying malignancy should be ruled out with these findings. Then in physical examination, always check for nutritional status of the patient. Nutritional status can be assessed with temporal muscle wasting, then proximal muscle wasting, or signs of malabsorption in the form of loss of hair, drying of the skin, or oral ulcerations. Then we should check for signs of liver cell failure, including xanthomas, jaundice, spider angiomas, paper money skin, gynecomastia, parotid enlargement, then caput medusae, pulmonary edema, diphtheria contraction, and bloody spots. Then lymph nodes, especially left subclavicular lymph node, that is Werkhouse node, to check whether it is pancreatic or gastric malignancy infiltrating into the liver. A periumbilical node, which we called as Sister Mary Joseph nodule. Then associated rise in JVP or right-sided pleural effusion or edema if this jaundice is because of congestive hepatopathy. Liver and spleen palpation, or that is hepatomegaly, nodular liver, cirrhotic liver. Splenomegaly usually points towards portal hypertension. Then if the GB, whether GB is palpable or not, whether patient is having Murphy's sign in case of acute cholecystitis, or Courvoisier's law, that is if in painless jaundice, if gallbladder is palpable, it is seldom because of gallstone, usually some underlying malignancy will be there. And presence of ascites will go toward either two things, whether patient is having chronic liver disease, that is cirrhosis of the liver, or malignant ascites, or sometimes tuberculosis of the abdomen causing ascites and hepatic infiltration can be discovered. So physical examination and history is important in making the diagnosis. Is the cause of jaundice is extrahepatic, and once we ruled out it is direct or indirect, and once we saw it is direct hyperbilirubinemia, then whether it is intrahepatic or extrahepatic. In intrahepatic, excellent history usually distinguish whether it is intrahepatic or extrahepatic. So the feature which tells that whether it is intrahepatic or extrahepatic are abdominal pain, lump in abdomen, fever, and previous history of hepatobiliary surgery usually goes towards the extrahepatic cholestasis. And in intrahepatic cholestasis, patient usually have prodromal history, that is viral fever, drugs, alcohol, family history of liver diseases, and usually they are painless, only mild pain because of stretch pain. So these are the findings to rule out whether it is intrahepatic or extrahepatic. Then what are the causes of cholestatic or direct hyperbilirubinemia? So these are intrahepatic causes and extrahepatic. And in the extrahepatic, I have divided it into extrahepatic benign and extrahepatic malignant. In intrahepatic causes, drugs. So drugs which we usually use cause amoxicillin, clavulanic acid, methotrexate, valproic acid. These are the drugs. Then amiodarone. These are associated with drug-induced liver injury, viral hepatitis, alcoholic hepatitis, primary sclerosing cholangitis, PBC, BRIC and PFIC, cholestasis of pregnancy, and long duration of total parenteral nutrition. They are associated with intrahepatic cholestasis jaundice. Then extrahepatic benign causes are choledocholithiasis, Meniere's syndrome, postoperative stricture, chronic pancreatitis causing stricture, biliary ascariasis, pancreatic pseudocyst causing compression, choledochal cyst. And extrahepatic malignant will include CA gallbladder, CA head of the pancreas, cholangiocarcinoma, periampullary carcinoma, and lymph node metastasis causing obstruction to the CVD. So what are the investigation I should order in cases of the jaundice? So first will be complete liver function test to assess the liver cell injury, then to assess the cholestasis, and to assess the synthetic function of the liver. So to assess the liver cell injury, we have transaminases, that is SGOT and SGPT. They are the intracellular enzymes found in hepatocyte. They are raised after hepatocellular injury, either infection or toxin, infection, ischemia, or toxins like alcohol, CCl4, drugs, or NSAIDs, mushroom like aminophthalate. And there are two forms, SGOT and SGPT, that is aspartate aminotransferase and alanine aminotransferase. So AST, SGOT, it is found in many other sources excluding liver like heart, muscle, intestine, and pancreas. So it is not that much specific for liver disease. It is made in cytosol and mitochondria. Often follows the degree of ALT to an extent, and its normal range is up to 40 units per liter, and it is elevated in the ratio of 2 or 3:1 in cases of alcoholic liver disease, that is alcoholic. Then alcoholic liver disease. Then ALT, that is alanine aminotransferase. It is primarily found in cytosol of the hepatocytes. It is more specific for liver, released when there is cell injury, either or destruction, and normal level differs lab to lab. But in general, we both ALT and AST normal level of the most of the reference lab is up to 40. But nowadays updated levels for ALT in males is up to 30 and in females is up to 90. So the test for liver cell injury are AST and ALT. The peak of AST and ALT has no correlation with the severity of liver disease. Whether if rise in ALT, if whether 200 or 2000 doesn't matter. It doesn't tells about the severity. Yes, but ALT and ALT are present in other tissues also, and the degree of and a pattern of rise in ALT can be helped in diagnosis. So in cases of the normal liver, as we see, the normal AST and ALT is around 30. But in case of cirrhosis, we usually get mild increase only up to 100 to 200. In case of chronic hepatitis, it is up to 300. In alcoholic hepatitis, it usually goes into 100 to 300. But in case of viral hepatitis, it usually goes up to 500 to 2000. And in case of toxemic injury or ischemic injury, it will goes up to 5 to 10,000. So the degree to rise to which AST and ALT rises will give us the clue of underlying etiology, but it doesn't give us the severity of the liver disease. Then the ratio of AST and ALT is important. If the ratio of AST to ALT is more than 2, it is usually seen in alcoholic liver disease, and ratio less than 1, it is seen in acute or chronic viral hepatitis. In absence of alcohol use, if patient is teetotaler and doesn't use alcohol, in that case, if the ratio of AST to ALT is more than 1, it usually suggests underlying cirrhosis. Then we should go ahead with the test for cholestasis. Test for cholestasis include alkaline phosphatase, gamma glutamyl transpeptidase, 5-nucleotidase, which is not readily available, and liver imaging like USG abdomen, MRCP, and EUS. Then synthetic function of the liver. Synthetic function, it includes serum albumin, prothrombin time, that is INR. So this is the single most important function which gives us the underlying severity and whether patient is getting recovered from the disease or not is given us by the albumin and INR, because these two tests will give whether tell us whether liver is recovering or not by the synthetic function. So albumin reflects liver synthetic function. Its half-life is around 21 days. Levels are decreased in cirrhosis. Other causes are prolonged severe hepatitis. Also, it decreases as a negative inflammatory marker in trauma, inflammation, and malnutrition. Then prothrombin time. It reflects the synthesis of vitamin K dependent coagulation factor, that is 2, 7, 9, and 10, and serves as a real measure of liver dysfunction. It is calculated, INR is calculated as patient's PT divided by control PT into ISI. The causes of rise in INR will be synthetic dysfunction as in cases of cirrhosis or vitamin K deficiency. So whether it is liver disease or vitamin K deficiency can be distinguished by giving vitamin K, and 30% reduction in the PT in 24 hours usually seen in deficiency states. So, we have decided, now we'll go towards the test for liver cell morphology, that is liver morphology by ultrasonography, CT scan, MRCP, or fibroscan, or shear wave elastography, or acoustic radiation force imaging. So this gives us the liver stiffness. So as we told, first we see whether enzymes are direct, bilirubin is direct or indirect. After that, whether it is hepatocellular or cholestatic, and then synthetic function. After synthetic function, liver morphology, and then test for the etiology. What are the causes of liver diseases? Then we should first see for viral marker, including hepatitis B, hepatitis C, hepatitis A, and hepatitis E. Then autoimmune marker, including ANA, ASMA, LKM1, and serum IgG levels, serum ceruloplasmin for Wilson's disease, and serum iron studies for hemochromatosis. So then we'll go towards the cases. First case is 40 years old gentleman presented with the history of anorexia, nausea, vomiting, and jaundice since last 15 days. There is no past history of jaundice, blood transfusion, or any surgery. He has been drinking alcohol 4 packs per day for last 15 years, and there is no history of any drug intake, including Ayurvedic or allopathic. So what is the diagnosis in this case? Investigations in that case is bilirubin is 7, AST is 900, ALT is 808, alkaline phosphatase is 124, gamma GT is 375, and albumin 3.6, INR 1.4. So what is our diagnosis in this case is whether it is acute alcoholic hepatitis, acute viral hepatitis, acute drug-induced liver injury, or none of the above. So as we see in this case, patient is alcoholic, consumes significant amount of alcohol since last 15 years, along with AST is more than 900, AST is 900 and ALT is 808. The ratio of AST to ALT is more than 2:1. So it goes plus increase in gamma glutamyl transpeptidase. So it goes towards the history of alcohol induced liver injury. But usually AST and ALT are less than in cases of alcoholic hepatitis. But as the ratio is more than 2, it is more suggestive of alcoholic hepatitis. So any other diagnosis we want in this case, any other investigation, we should go ahead with whether ERCP, MRCP, CT or UHG. So first basic test in this case, as we do not suspect any sort of obstruction here, we'll go ahead with UHG abdomen, which reviewed nodular liver, mild ascites, splenomegaly with collateral. So it's suggestive of underlying liver cirrhosis. So take home messages from these cases: not all patients with chronic alcohol intake and jaundice will have alcoholic liver disease. They are prone to other forms of liver diseases also, as in non-alcoholics, and never forgot to take the history of recent drug in all cases of acute hepatitis and ask for abdominal imaging on all cases. In case 2, 20-year-old female with a history of recurrent jaundice along with fatigue since last 3 years after physical exertion. So jaundice with fatigue and after physical exertion. In this case, bilirubin was around 2.7, direct is 0.9, indirect 1.8, enzymes are normal. Then other liver function, including albumin, globulin and synthetic function of the liver. In case of INR, everything is normal. Only one hemoglobin was 9.8 and PBS showed microcytic hypochromic anemia. So in this case, young lady along with jaundice, fatigue and physical weakness, anemia with predominantly indirect hyperbilirubinemia with normal synthetic and hepatocellular function. But these points, what other history will come to know in this, we want to know in this case will be degree of rise in bilirubin, whether patient took any blood transfusion, previous anemia, pain in abdomen, drugs, family history of jaundice or anemia. So what investigation will order here? Or liver function test for hemolytic anemia and ultrasound of the abdomen. So in case test for hemolytic anemia, osmotic fragility is normal, but HB electrophoresis showed beta thalassemia. Coombs test, direct and indirect, both are negative. Serum ceruloplasmin is normal and UHG showed mild hepatomegaly. So what is our final diagnosis in this case is hemolytic anemia with beta thalassemia minor with unconjugated hyperbilirubinemia as a presenting recurrent jaundice. Then fourth case will be 30-year-old female presented with recurrent pain in abdomen. So pain in abdomen for last 3 years with jaundice, with fever, with rigor chills for last 2 months. So 30-year-old female presenting with abdominal pain, jaundice and rigor. So this will point towards Charcot's trial, that is fever, pain and jaundice. So in this case, what are the important other history we will want to know? This pain in abdomen, fever, rigors with chill, anorexia, weight loss to rule out malignancy, diabetes as CA head of the pancreas in newer case, recent cases associated with diabetes, or any previous surgical intervention, whether patient is having any benign biliary stricture, biliary ascariasis or stone disease. So her investigation revealed HB is of 8, TLC is 14,000, serum bilirubin is 7, out of that direct is 5.2. SGOT is 97, SGPT is 112, alkaline phosphatase is 764, and INR is, that is prothrombin time is 12, and amylase is 364. So in this case, it is associated with predominantly conjugated hyperbilirubinemia with raised alkaline phosphatase, which is suggestive of extrahepatic cholestasis in the form of obstruction, and ultrasound showed GP stone with dilated CBD and prominent head of the pancreas. So in this case, we should rule associated pancreatitis is also there. We should rule out whether patient is having chronic pancreatitis or patient causing stricture or benign biliary stricture, or there is associated stone disease. So ultrasound will give only clue that there is dilated CBD, but to find the etiology, we will go what differential diagnosis will keep in this case are CBD stone, biliary ascariasis, chronic pancreatitis with sphincter of Oddi dysfunction, then the cholecystectomy, periampullary carcinoma. So what our next investigation will be either endoscopic ultrasound or MRCP. In this case, endoscopic ultrasound reveals stone in the distal CBD, and also the MRCP reveals stone in the distal CBD. So whether to go ahead with endoscopic ultrasound or MRCP depends upon the local expertise and availability. So if we have MRCP available, we should go ahead with MRCP. But if you have US available, and if we think by doing the US we can see the etiology, and at the same time we can go ahead with ERCP and stone removal. So at that time US will be better than ERCP. So it is operator dependent and depending on the availability at that place. So the final diagnosis is CBD stone. For that ERCP with removal and stone clearance has been done. Then case 5, 26-year-old gentleman presented with fever since 7 days, anorexia, nausea, and jaundice since last 7 days with no comorbidity and other contributory history. So this is the prodromal symptom, that is fever, anorexia, nausea, and jaundice. So with young male with prodromal symptoms presented with jaundice. In this case, bilirubin was 9. AST is 1000, ALT is 2000, 125, alkaline phosphatase and gamma GT is only marginally reached with normal of albumin and INR. So in this case, this reflects predominantly hepatocellular injury with ALT more than AST along with prodromal set. So this is some sort of hepatitis. So for the upper UHG abdomen showed mild hepatomegaly and viral marker showed HBsAg positive. So what is our diagnosis in this case? Whether it is acute hepatitis B, chronic hepatitis B, or acute reactivation of chronic hepatitis B, or acute hepatitis E over HBV carrier state, or acute hepatitis A on HBV carrier state. So mere presence of hepatitis B doesn't imply that this rise in HGOT and HGPT or this liver dysfunction is because of chronic hepatitis B. So whether it is because of hepatitis B or other super added infection or some other etiology like drug, we should always see the replicatory marker. So how will we proceed in this case? We will see for IgM HBC core, which is negative, HBeAg, which is negative, and HBV DNA viral load. These all things are negative, but we came to know that HEV IgM is positive. So, and HAV IgM is negative. So this is the case of chronic HBV carrier who developed acute hepatitis E. So it is acute hepatitis E on HBV carrier state, and family screening revealed 2 sister and mother are also HBsAg positive. So take home message is that in case of acute hepatitis like picture with HBsAg positive, always ask for all the viral marker, that is acute marker, HAV IgM, HEV IgM, IgM anti-HBsAg and anti-HCV. So in all an HBs objective question does not necessarily mean that HBV is replicating or causing liver injury. Always ask for replicative marker for HBV once you detect HBsAg positivity and HBeAg and HBV DNA viral load. Then 26th case, 26-year male presented with jaundice 6 years back and diagnosed to have hepatitis. Thereafter, he has been having repeated episodes of jaundice with loss of appetite. So jaundice with loss of appetite, that is fasting, and since last 6 years. There is no history of transfusion, no history of alcohol intake, no family history of liver diseases, or no other any contributory history towards his liver dysfunction. His bilirubin levels are in 2010 2.8, 2012 3, 13, 1.9, 15, 2.9, only around 3.5 with other normal liver function. Is hemoglobin normal, AST, ALT, alkaline phosphatase and albumin, everything is normal. So what are the possibilities in our case? Acute hepatitis, intrahepatic cholestasis, familial unconjugated hyperbilirubinemia or CBD stone. So acute hepatitis is ruled out because there is no prodrome, OTPT normal. So intrahepatic cholestasis ruled out as OTPT and alkaline phosphatase gamma GT normal. CBD stone, no, because there is no pain, no fever. So we left towards with the familial unconjugated hyperbilirubinemia. So as I told, it is not acute hepatitis because no prodrome and AST and ALT normal. intrahepatic cholestasis because there is no pruritus and no alkaline phosphatase and gamma GT normal. So the diagnosis here is the Gilbert syndrome. That is, it is a genetic disorder, autosomal recessive, defect in bilirubin conjugation, affects up to 8% of general population. Asymptomatic unconjugated hyperbilirubinemia usually goes up to 5 and rest of the liver function test is normal. So important points in Gilbert syndrome are hemolysis needs to be ruled out by HB electrophoresis and retic count. Management rule out other causes of hemolysis and just a reassurance. And avoid fasting because fasting precipitates increase in bilirubin. Then other two cases, case B and case C. In case B, 23-year-old male with a bilirubin of 1.8, direct 1.5, alkaline phosphatase is 80, AST 87, ALT 99, and HBS AG positive. And another patient with the same liver function with enzymes around 100 and anti-HBC positive. So it is one is chronic hepatitis B and one is chronic hepatitis C based on the liver enzymes more than 40. So do the case of B and C have liver cirrhosis? So in these cases, this we have to rule out whether patient is having associated cirrhosis or not. So to check for cirrhosis, we have to go ahead with blood test, low albumin, deranged PT-INR, imaging like CT, UHG and MRI, endoscopy show to check for signs of portal hypertension, fibroscan to check for liver stiffness, hepatic venous pressure gradient to check for HVPG, that is to check for significant portal hypertension, and liver biopsy in the last. So tools to diagnose for cirrhosis in ultrasonography, we can come to know about coarse ecotexture of the liver, irregular contour of the liver, presence of ascites, splenomegaly, abdominal wall, abdominal collaterals, then portal vein diameter and flow, splenic vein diameter and flow. So other tests to diagnose cirrhosis are fibroscan. To the fibroscan is like a sonography probe only, which we have to keep over the liver at 5 places, and the mean value in kilopascal will come to know, and through that we'll come to know whether patient is having significant fibrosis or cirrhosis. Then we can check for HVPG by passing the catheter into the hepatic vein. We first take the free hepatic pressure, and then by wedging the balloon into the hepatic vein, wedged hepatic pressure. And if HVPG is more than 5, it is suggestive of suggestive of portal hypertension, and more than 10, it is suggestive of significant portal hypertension. And in the liver biopsy, we can see the nodular liver nodularity and fibrosis. To diagnose cirrhosis, endoscopy reveal normal esophagus, and these are the esophageal varices, dilated veins. Then fibroscan, this is the probe which we keep at the 5 places and take the mean value. So if the categorize it into F1, F0 to F1 fibrosis, F2 to F3 fibrosis, F4 and F5, and more than F5, that is cirrhosis. So usually 2 to 7 we call it as an absent or mild fibrosis. 7 to 9.5 is the significant fibrosis, that is F2. Severe fibrosis is 9 to 12.5, and more than 12.5 it is F4, that is cirrhosis. So if the fibroscan value is more than 12.5, it signifies that there is presence of cirrhosis, even without other tests. Then these are the fibroscan. It is typical machine available. It is the fibroscan, that is liver elastography. This is shear wave elastography. This is the same principle we follow into the fibroscan, but this software we can accommodate in the normal sonography machine, and we can check for the shear wave elastography. It is little bit inferior to fibroscan, but easily available and can be used locally also. So approach to jaundice patient: first, jaundice history, physical examination. Also always important to rule out drugs which are causing liver dysfunction. Complete liver function test, whether hepatocellular or cholestatic. Once we ruled out hepatocellular versus cholestatic, imaging to check for biliary obstruction, features of cirrhosis or portal hypertension or liver SOL. Then at the etiological diagnosis by viral, autoimmune or other special etiology based on the clinical scenario. Thanks for your patient and attentive. Thank you.
Thank you, Dr. Thank you, Dr. Ashish, for your wonderful session. As obstetrician, we are very afraid of acute hepatitis in pregnancy, as the rate of maternal mortality is very high. Can you give some tips for us to manage acute hepatitis in pregnancy?
Sir, if a patient, if a female presents with acute hepatitis in pregnancy, we have to rule out whether patient is having, first we have to check whether this is the previous hepatitis which is now getting flared, or patient is getting some hepatitis A or E in the pregnancy, or patient's maternal condition causing her hepatitis, that is acute fatty liver of pregnancy or HELP syndrome. So first we have to rule out these cases. In case if it is a viral hepatitis, that is HAV or HEV, we have to manage it conservatively. But HEV is usually associated with very high maternal mortality rate because of some autoimmune cross reactivity with the placenta and the fetal antigen. So in case of HEV hepatitis in pregnancy, we should be careful. Once these are not any viral hepatitis, it is because of some maternal condition like acute fatty liver of pregnancy or HELP syndrome. In these cases, we have to check with the Swansea criteria. So in the Swansea criteria, we can check patient's liver function test, LDH, bilirubin, then uric acid, and accordingly, if patient is having acute fatty liver of pregnancy, we have to manage it as a acute liver failure, and the final treatment will be only delivery. Same for the HELP syndrome also. And only if patient present with cholestasis of the pregnancy, this cholestasis is usually a benign condition. In that cases, usually we have to do ursodeoxycholic acid and manage them conservatively till second or till third trimester of the pregnancy. But if it is unbearable, that is termination of the pregnancy or delivery of the baby is the only answer.
Okay. Thank you, Dr. Ashish. Now I would like to invite Dr. Ashok Bhavskar sir to give his concluding remarks.
Thank you, Dr. Vinod. Very informative and a very lucid talk on approach to a patient of jaundice, but none other than Dr. Ashish. He has explained all the things regarding how should we our approach to a patient of jaundice in terms of history, in terms of investigations, in terms of special investigations to know the etiology of the patients of jaundice. When we see a patient of jaundice in our day-to-day practice, it becomes very difficult for us to go as far the investigation part is concerned. But Dr. Ashish has very nicely explained which investigation is essential in which setting, and even the serological investigations, the markers for acute and markers for hepatitis B also, they were very nicely explained by Dr. Ashish. Dr. Ashish, just I would like to ask one thing regarding in which setting do you recommend angiography of hepatic angiography?
Hepatic angiography.
Yeah. Is there any specific? Is there any indication for hepatic angiography?
So nowadays, no, but if only hepatic angiography, we see if patient is having, we are suspecting Budd-Chiari syndrome. In case of the Budd-Chiari syndrome, we will think of doing hepatic angiography or tips placement for both for diagnostic and therapeutic purpose. But other than clinical or what's the experimental or research purpose, only we'll do the HVPG or angiography.
Ashish, Ashish.
Yes, sir.
I have got one question. I am Dr. Mantri here.
Yes, sir. Yes, sir.
What is about chronic active hepatitis?
Sir,
how to diagnose it? Chronic active hepatitis, how to diagnose it, how to treat it, and what is the role of steroids in it?
Sir, chronic active hepatitis, first we have to see what is the okay. First, what is chronic? So if it is more than 6 months, it is chronic. Then active means enzyme should be more than 2 times upper limit of normal, that is more than 80. Then if patient is having chronic active hepatitis, we have to check for what are the etiology for chronic hepatitis, whether it is hepatitis B or hepatitis C. If we ruled out it is hepatitis B and hepatitis C, then we will check for whether patient is having autoimmune liver disease. or Wilson's disease. For checking autoimmune liver disease, we'll go ahead with ANA, ASMA, LKM1 and serum IgG levels. And with IgG levels, we'll do the simplified scoring. Or if it is acute, autoimmune hepatitis, we'll go ahead with steroids and followed by azathioprine. But if it is not autoimmune hepatitis also, then we have to check for whether patient is having underlying Wilson's disease. So for that Wilson's disease, we'll go ahead with 24-hour urinary copper along with serum ceruloplasmin. If we have to see for some sort of etiology, only with the etiology we can treat. If there is no etiology, I don't think so there is any indication to give steroids. If only it is autoimmune, we have to give steroids, otherwise no. If we give steroids in case of B and C, they will flare, they will reactivate and will go into acute on chronic liver failure.
Thank you. Ashish, one more question is there. Our general population is 5% positive in HBsAg.
Yes, sir. Yes, sir.
That is well known fact.
8%. 8%.
But how to differentiate when a patient comes with jaundice and we go for investigations and the patient comes positive for HBsAg? So whether it was from the general population or is it a newer one?
Yes. So if we say check for HBsAg positive and patient is HBsAg positive, but in that case, if liver function test is normal, sonographically liver is normal, fibroscan we do if HBP if values are less than 7.5, HBV DNA is less than 20, and HBeAg is negative. This is the points towards inactive carrier disease, which we call as a chronic HBV infection and active carrier. Chronic HBV infection only. But in these cases, if patient is having disturbance in liver function, whether increase in HGOT or HGPT more than 2 times upper limit of normal, other thing, fibroscan values more than 12.5, UHG showed cirrhosis, and viral load more than 2 lakh, and HBeAg positive. This is active hepatitis. In these cases, we have to treat. And family history of liver cancer. If a HBsAg positive patient, his mother or father is having the history of liver cancer, this is the indication to start antiviral, whether entecavir or tenofovir, irrespective of viral load, because HBsAg integrates with the DNA of the into the liver DNA. So as a HIV, we can't remove HIV. Same thing, we can't remove HBsAg. Even if HBsAg is negative, but if a patient is previously infected with hepatitis B, his core antigen will be there into the human body for lifelong. So in those cases, so if a patient is having family history of liver cancer, we have to treat with antiviral irrespective of viral load.
Okay, I don't think there are many questions in the chat box also.
Yes, there is one question from Wali Prakash Shankar Rao. He is asking, what is the role of Ayurvedic medicine in hepatitis?
There is no role of Ayurvedic medicine in the hepatitis. First, and if we give Ayurvedic medicines in the hepatitis, it will cause superimposed DILI, drug-induced liver injury. We have seen most of the patient coming to us, you usually come to us after taking Ayurvedic medicine. They sometimes in the nose, sometimes through mouth. Even nowadays we are taking this Corona. In Corona, Guduchi or Goodwill. I have seen 3 cases of acute liver failure because of Goodwill. So I don't think so there is any, and nowadays even Harrison or our all books have the chapter, this Chinese herbal or Ayurvedic medicines are associated with enormous increase in liver injury. So first, initially in India, most common cause of drug-induced liver injury was AKT. But nowadays, most common cause of liver injury along with AKT is these Ayurvedic medicines.
Chalo, thank you. Thank you, Ashish, for a very good talk. And you also answered to almost all the queries regarding the jaundice. On behalf of myself and my co-chairperson, Dr. Deepa Mantri, I would like to thank the IMA office bearers for giving us an opportunity to chair this session. Thank you.
Thank you, sir. Thank you, KGCON team, for giving me opportunity to present my thoughts on jaundice. Thank you.
Thank you, sir. For the next lecture, I invite our chief guest, Dr. Prakash Marathi, sir, for his topic on legal literacy for doctors. For this session, I invite Dr. Sadanand Ingre and Dr. Nitin Nandurkar as chairpersons. I request Dr. Nitin Nandurkar to introduce our honorable speaker.
Thank you, sir. Good afternoon, friends. The next topic in CME is legal literacy for doctors, which I think is a very important topic nowadays. And the speaker is Dr. Prakash Marathe, sir, who is also our chief guest and a very well-known personality. So I will give a short introduction of sir. He is an ophthalmic surgeon and passed his MBBS and MS from Vijay Medical College, Pune. He is past president of IMA Pune and Maharashtra Ophthalmic Society. He is senior vice president of IMA Maharashtra, also managing committee member of All India Ophthalmic Society. He has done a lot of social work in India and abroad also. He had participated in international mega eye camp at Kenya. He has done a lot of presentations for public awareness on TV and different social media. He has received a lot of awards. To mention a few important: President Appreciation Award by National Indian Medical Association, also by Maharashtra IMA, then Special Felicitation Awards. So all we know, he is a very well-known personality. So I request sir, please sir, enlighten us and guide us. Thank you.
Hello, good afternoon, all of you. Am I audible?
Yes, sir.
Yes, sir.
Thank you, Dr. Nitin Nandurkar, sir, for the wonderful introduction. Since morning, I have been witnessing this conference. Even yesterday, I could hear so many topics. It is a wonderful conference organized by our KHAMGAON IMA team, that is KGCON-2022. I must congratulate our president, Dr. Surekha Mende, then Dr. Anand Rathi, Dr. Vinod Rajankar, Dr. Atul Rajput, Dr. Smita Deshmukh, Mrs. Dr. Rajankar, and organizing team of IMA KHAMGAON. I think at peripheral part of Maharashtra, such wonderful talent is seen, and so many speakers what I could listen today were very nice. Now, I am also thankful to your team for inviting me for this talk. I think most of us are academically very good. Like we are taught in medical colleges what to do, what not to do, and we are that way very nice clinicians. I am trying to share my screen. Is the screen visible? Hello, is the screen visible?
Yes, sir. Yes, sir.
So academically, everybody is good in his or her field, like surgery, then pediatrics, gynec, ophthalm, everything. But in the past, like 20, 30, 50 years ago, what medical practice was there, not the same as on today. So there is so much of difference. To be a very good clinician was the requirement in the past. To be a doctor was sufficient enough to tackle general public. But in today's era, where there are doctors around, all the patients and society, they are Google doctors. And all these Google doctors, they feel that they know everything when they come to you. When they come to you, they try to teach doctors and medical fraternity that how this disease is having this particular diagnosis. This can be the differential diagnosis. what type of treatment you can give to me or my relatives or my friends. And when there are so many questions, and with the sword of Consumer Protection Act, various medical litigations, what you are seeing at and around, I think medical fraternity is on the defensive side. There were days when doctors used to take bold decisions about using very many medicines, little bit trial, so many surgeries, and they were trying to save the patients. And that was the help for general public and the society. But in today's era, whatever step you have been doing is looked at with suspicion by the patients, their relatives. They want everything in positive mode. Whatever you treat, they are asking you the word, doctor, is it guaranteed? Will I get 100% cure with this? Will my patient be living after this particular operation? In ICU, when you are treating the patient, relatives will expect that definitely there will be a life and life and life. Death is the thing what they will never want. And that too, in medical premises, in ICU, in hospital, in clinics, that death is not acceptable by the patients and societies. This is the worst thing, I think. Whosoever is there on this earth and having life probably has to go one day. The patients who are not taking care of themselves, like they are having so many bad habits, like tobacco, alcohol, sleepless nights, enjoying their life with so many things in the market. And whenever they want to enjoy, they want longest life, maybe 100 years life. So when if 70, 80 years patient who is admitted in ICU and in the hospital getting treated, suppose there is unfortunate incidents and medical fraternity cannot give that success to the patient and relatives, I think they feel that there was some negligence. So when you are facing these things in your life, only academician doctor is not enough. You must be ready to face various challenges. Medical knowledge, definitely it is needed. You must be a very good clinician. You must be a very good surgeon. You must be a very good negotiator. You should have patient-doctor relationship. You should be talking in a very nice, polite manner with the patients and relatives. In the past, the sentence, what do you know? What do you understand? I am the doctor. I know everything. That phrase was the proud phrase in medical fraternity. But in today's era, no, you can't do so. Relatives are always there to ask questions. Whatever procedure you are doing, consent is a must. That consent may be in CCTV surveillance, maybe in the documented format, maybe foolproof if it goes in court of law. To avoid any litigation, I think the documents are going to save you. For that, you must know so many things. If you are running a clinic, in the past, sitting with your table, chair, BP apparatus and stethoscope was enough. Some sort of injections and tablets. Our forefathers, they have started their practice like this. Nowadays, there are various rules and regulations and laws regulating your profession. Even if you are running the hospital in the past, in the clinic, you could have given that saline in the side room. Nowadays, number of beds, whether the hospital is registered under Hospital Bombay Nursing Home Registration Act, then the newly expected law, that is Clinical Establishment Act, cashless insurance, TPA, then NABH, everything. Whether your practice is foolproof in that sense or not, patients and relatives and government, they expect a lot from you. These are few things at a glance you can see. First important thing is record keeping. Record is the thing which saves you in the court of law. Don't forget this. The patient comes to you after 5 years, says, doctor, you have operated my left eye, and you don't have record. You have to accept what the patient says. And if he has any complaint, you don't have anything to defend. But on your case paper, if you have written that such and such eye was operated on such and such date, this was the procedure, whether it was eventful, whether there was any complication, what sort of expectation of prognosis was there at that time, whether it was guarded prognosis, whether patient had diabetes, whether patient had hypertension, whether there was any retinopathy, how much chance of vision regaining was there. All these things, if there on the record, probably you can defend your case, maybe with the patient's relatives and in the court of law. In the past, physical preservers of documents, that is case paper, that is indoor case papers, OPD case papers, operative notes, everything. But nowadays, digital format preservation of these documents also can be done. For record keeping, indoor and outdoor, that is outdoor, somewhere it is written 2 to 3 years, somewhere it is written 5 years. So 5 years, you must preserve your case papers, outdoor case papers. Indoor, somewhere it is written 5 years, somewhere it is written 7 years, and somewhere 10. So up to 10 years, indoor case papers you can preserve. Whenever it is the pediatric patient, till he attains majority, that is 21 years of age, you must preserve that document. Because pediatric patient, when attains maturity, can go in the court of law when he becomes major. Again, in the medical legal cases, 30 years you can keep that document. And if there is litigation, you can keep that document with you lifelong. Whenever the patient comes to my clinic, I have got the physical case paper and it is available whenever the patient comes, and then entry is made. The case paper is available within 2 minutes because I have kept it in alphabetical manner. That is surname, name, and middle name, not date wise. So whatever format you have been using, you must preserve your documents. So case papers, indoor and outdoor documents. Then receipt books, from income tax point of view, whenever you are giving the receipts and accounts and audits, 8 years they expect your receipts to be kept. So 8 years is the period. Up to 8 years, you must maintain your accounts register. Then OT register is there. Then whatever stock you are having, that register is there. Profession tax, everybody knows. In state of Maharashtra, you have to pay 2,500 per year. And in the past, there was scheme. It may be there today. That is, you pay for 4 years and 5th year is the free year for you. There is special registration, online registration you must do, and you must be registered under profession tax. Clinics in Maharashtra, you did not register, but if it is the hospital, you must register it under Bombay Nursing Home Act. In big cities, it is corporation. Otherwise, in whichever city you are practicing, that registration must be done. It is needed medical legal point of view because it becomes the official premises to treat the patients. So surgery is done in the authentic manner at authentic and proper place. That's the documentary proof. When you are treating patients, and suppose there is any medical legal litigations, in the past, the professional indemnity insurance in lakhs was enough. You must have heard the cases against medical fraternity and doctors. They are in crores of rupees. It is unfortunate incidents. Throughout the life of the doctor, he may not gain those many crores that he may vest in that one of the cases. So you must have your professional indemnity insurance. You can have your personal as well as hospital. And take one important point from you here. Don't forget to renew your professional indemnity insurance. You must renew it before the due date. If there is lacunae, if you are missing that last date of renewal, probably that particular previous date, that is 2 years ago, 5 years ago, is not well covered. So the continuity of professional indemnity insurance is a must. That date must be documented with you in a proper way, and don't forget. Sometimes insurance agents, they ask you, they remind you, sometimes they may not. Don't depend on them. You yourself must remember those dates and renew your professional indemnity insurance. There are some private insurance companies and there are some government insurance companies like United India, National Insurance and all that. So invest your sum of the amount for that particular year in professional indemnity insurance. It is a must nowadays. Then administrative point of view, some of the patients, when you do the surgery and treat them, they are under insurance, their Mediclaim policies. So they present their bills. They expect cashless facility. In some of the hospitals, that cashless facility is available. At few other hospitals, it may not be available. Reimbursement you can provide. But when they are issuing the bills to your hospital, you should be in a process to give them that document. And if that insurance is passed, probably you will get these patients. There is some malpractice done by various medical agencies to fetch the patients at various hospitals. So don't fall under that. TPA is the thing which comes in between while settling those insurances. NABH is the thing nowadays. I think it is the basic requirement for various mediclaims. To upgrade your hospital, that particular NABH is little costly, but basic NABH, definitely you can try. SHOP Act was needed in the past. Nowadays, SHOP Act is not needed for medical fraternity. PCPNDT is the worst thing in medical profession, which has spoiled the lives of many more gynecologists, obstetricians, radiologists, sonologists. But the worst thing is, like even cardiologists, they have that sonology machine. They are also asked to register under PCPNDT. Even ophthalmologists, we had that thing in our Pune city. And we are in the court of law, and hence there is a stay that ophthalmologist sonography machine cannot be used for sexual determination. And even if it is not used, government is trying to force that all these machines, including veterinary, are to be registered. So you must be careful whenever you are doing your practice. If you are doing your practice in a proper way, still there are various things in this slide you can see. That is, there was Indian Medical Council, that is MCI, and nowadays it is National Medical Commission. And the same way in the state of Maharashtra, it is Maharashtra Medical Council. So we are practicing under that. Don't forget to renew your MMC registration. If you are registering yourself as MBBS, that is general practitioner, you are only general practitioner on paper. If you are MD radiology, you must register your MD radiology qualification with Maharashtra Medical Council. Then only you are treated as radiologist. If you are registering MS surgery with MMC, then you are surgeon. Then if you are super specialty, even that qualification has to be registered with Maharashtra Medical Council. Don't forget this. So that is called as additional qualification. I am requesting all specialists and super specialists here. Just see whether your specialty qualification or super specialty qualification is registered with Maharashtra Medical Council. Otherwise, when the case goes in the court of law, you are not the specialized person in that particular field. And another thing, what everybody knows, that you have to renew your registration every 5 years. All of us are answerable for civil and consumer codes. CPA, that is Consumer Protection Act, is the worst thing what medical fraternity is facing nowadays. The claims are going beyond lakhs, and nowadays they are in crores of rupees. So you have to take care. There are district forums, there are state forums, there are national forums, and you have to be foolproof when you are doing your practice. Suppose there is any unfortunate death, you must have experienced this, that police, they take that doctor and they lodge the complaint against 304. 304 means it is non-bailable. You cannot get bail. But there is the provision that there was no intention to murder in that case, even if the patient is dead. So it is 304A, where there is bail which can be given. So insist the police officer, all these organizations like IMA and various specialty organizations can tell police that 304 cannot be applied. It is 304 you have to apply, and then your colleague can be saved. Then there is one more thing like Information Act, Human Rights Commission. Biomedical waste is the thing which is problematic everywhere in the state of Maharashtra as well as whole India. Forthcoming acts like In spite of this Bombay Nursing Home Act, there is one more act which is at the doorstep, that is Clinical Establishment Act, which is little different from Bombay Nursing Home Act. In the past 4-5 years ago, government of Maharashtra was trying to bring this act that was anti-cut practice law. It was framed, but it is not applicable yet. There are various licenses. And next point, what you are saying is all these P's. Don't get involved. Be careful from all these P's. What are those P's? Press, that is media. Politician, that is again double-edged sword. They may be beneficial, they may be dangerous. You yourself can be politician, plus point as well as negative point. Then pleader, police. Police can be your friend, but tackle them in a proper way. Poor people, sometimes sympathy is shown, but they also can be troublesome. And physician is our own colleague. See, remarks, bad remarks by our own colleagues is the worst thing. And that can take you into litigations. So we all must be careful not to comment in a bad way with our colleagues. Janta Darbar nowadays, and then media trial is the worst thing to have. Even if doctor is not the person who has done the problem, still media feels he is the person who has done that mistake. Then local supervisory board and committee that can be formed, which is dealing with those two parties and trying to settle the claim. Next important thing is defamation through media and plague boards. Nowadays, plague is very cheap. That board, everything they are putting everywhere and blaming the doctors and medical fraternity. Demanding money by cheating a dispute or a wild allegation of negligence and misbehavior. Whenever there is negative report, negative result, or death, or some morbidity, they are trying to blame doctors and medical fraternity. Asking for refund of fees for alleged failure of proper treatment. Suppose medical fraternity is not charging anything. Probably they are only worried about the result. But in India, I think private practice, they have to pay thousands of rupees, maybe in some cases lakhs of rupees. So they expect some 100% result. If there is no 100% result, what they feel, result is not there. Why should we put thousands of rupees and lakhs of rupees? Then they try to ask you to refund the money. They try to ask you to less that amount. So asking for ransom for next doctor's total or exaggerated fees. This is the worst thing nowadays. They're asking for that amount back. In abroad, in various countries, where medical treatment is free for the patients. So they are bothered about the results only, not bothered about the amount, because there is Mediclaim which is taking care. That cover is there for each and everybody. In India, there is a class, poor people cannot go to government hospital, all of them. They expect private practitioners to treat them. But when there is no good treatment, what they expect, they try to trouble. When they can't pay proportionately, they feel that why they are asking this much money to be paid. Then mental harassment is the worst thing which is there for medical profession, abuse. And very bad is the violence, which was not there 5-10 years ago. But nowadays, they are taking medical hospitals, medical fraternity and doctors and doing the violence. You cannot defend yourself like this. I think for this, the role of various associations and organizations like specialty and super specialty organizations is very, very important. We have seen few incidences like candle picketing and demonstrations on the streets against medical practitioners. And for all these things, what we expect on this platform from all of you, don't make any loose comment against your colleague. On that particular moment, you may feel that you are correct and your colleague is wrong. But on some other day, it may be vice versa. So loose comment from the medical colleague is the thing which can lead to various litigations. We must save our fraternity first. See, there are no loyal patients and no loyal relatives and no loyal friends. One day, your friend is in trouble, tomorrow you may be in trouble. So whenever you are discussing with patients and relatives, no loose talk, no loose comment about your colleague. And for that, you have to be under one roof, under cover. And that roof and cover is like the bodies, Indian Medical Association, All India Ophthalmological Society, Surgical Society, Pediatric Society, Gynec Society, like dealing with academics as well as all these brotherhood is there amongst all these organizations. You must be together. You must meet in your cities with various meetings and with all these topics where you can help each other. There can be associations like social organizations, Rotary and Lions. You can be well acquainted with them if you are interested to. Some of you are politically oriented. Your career may be there. Then you can have various friends in various medical, other than medical professions, and they can be of some help. There may be enemies, there may be friends. So identify them accordingly. The policies are prepared by these political people. Unfortunately, in our country, though they are only 10th pass or 12th pass or not even graduates, they are going to rule. That is an unfortunate thing. But the laws are framed by these people. So they can be friends as well as enemies, but they are policy providers, policy decision makers. So usefulness of associations is very important, and laws and rules, whenever government is not doing in a proper way, I think associations are taking our issues to that level and talking to them. You are not doing this well for medical fraternity. Sometimes they listen, sometimes they do not. And I think with all these words, I have tried to cover the aspects related to legal literacy for medical profession. Hope this topic will be useful for all of you. And what I have tried to tell you, maybe other than academics, but these things are important in our day-to-day practice. Thank you for the opportunity once again. Thank you.
Thank you, Dr. Marathi sir, for your wonderful session on legal literacy for doctors. Now it is very crystal clear the importance of record keeping and getting the certified from various authorities for safe day-to-day practice. Now I would like to invite Dr. Sadanand Nigre sir to give his concluding remarks.
Good afternoon. I thank you very much, Dr. Prakash Marathi sir, for giving this very excellent lecture on legal literacy for the doctors. Indeed, the lecture was very informative, very helpful for doing our day-to-day practice. Sir has explained about the various acts and laws which are related to our practice. One thing or one law he has forgotten to mention is very important, especially for gynecologists or general practitioners who are doing medical termination of pregnancies. That is Medical Termination of Pregnancy Act.
Yes, sir.
Just a few days back, there is a very unfortunate incident in our Vidarbha area, Arvi town. One gynecologist is arrested and she is still in the custody for many days. The only fault was that she was not knowing the details of the MTP Act and POSCO Act. This one more POSCO Act should also be, the gynecologist at least should be aware of this. She was not aware. What she thought that I have taken the consent, written consent of the minor girl's parents. So I am empowered to do her termination of pregnancy. Actually, it is not like that. If a girl is less than 18 years of age, we cannot do her termination of pregnancy with her consent, with even her parents' consent. We have to first do her MLC case, we have to inform the police, we have to do medical legal case, informs the civil surgeon, then only we can do this. Just because of lack of knowledge of this act, she is suffering, her whole family is suffering. She has done nothing wrong. Her center was registered, everything, she was qualified, everything was okay. Another thing is that regarding the income tax, sir has mentioned, we doctors should have a little bit knowledge of Income Tax Act. It is not very much difficult. It is very simple. At least we should know what is the procedure of income tax survey and search and seizure. I personally have experience of income tax survey. One fine afternoon when I was taking my tea break, income tax people entered my house and they started searching everything, cupboards and suitcases and drawers and everything, which they were not allowed, they were not authorized at all. But I was not aware that under income tax survey, they are allowed to enter your house. They are not at all allowed to enter your house. They are empowered to survey your only working premises. Yes, I request all our friends to go through these very simple acts. Again, I thank you, sir, for this, and take away message from this lecture is records and consent. Record, if your record is very nice and consent is proper, you will be saved from any accidental things in your practice. Thank you. Thank you very much.
Thank you, sir.
Thank you, Marathe sir, and thank you, Dr. Sadanand Ingre sir. For the next topic, decoding preventive oncology, past, present, and future, I invite Dr. Prasad Sor. For this session, I invite Dr. Akhtar Hussain sir and Dr. Rahul Khandare to chair this session.
Thank you, sir. Thank you, sir. Good afternoon, everyone. I am Dr. Rahul Khandare, practicing physician at KHAMGAON. I am here to introduce Dr. Prasad Sor, the only oncosurgeon, the first oncosurgeon in Western Vidarbha region. Currently, he is practicing at Akola. He has done his MBBS from Mumbai and his MS General Surgery from IGGMC. He has done super specialty, DNB super specialty in oncosurgery from Kolkata. He has also done MRCS surgery and fellowship from Tata Memorial Hospital, UIC. He has worked as an assistant professor in surgical oncology at Government Cancer Hospital, Aurangabad. He is currently working, practicing at Niramaya Cancer Hospital in Akola. He has an experience of many oncological surgeries, and that too, his special interest is in breast conservation and minimal invasive surgical methods. He has many publications to his name, and he is member of Association for Surgeons of India, Indian Association Gastrointestinal Surgery, Indian Association of Oncosurgeons, and Vidarbha Surgeon Association. To have such a renowned speaker for this session, I would like to welcome him, and over to you, sir.
Good afternoon, everyone. Can I share my screen?
Yes, sir. Yes, sir.
Audio चालू है, sir. My screen is visible.
Yes, sir.
Am I audible to everyone?
Yes, sir.
So, good afternoon, everyone. Thank you, Dr. Mende, madam, Dr. Anand Rathi, sir, and organizers of KHAMGAON IMA for giving me Dr. Akhtar Hussain, sir, Dr. Rahul Khandare, sir. My topic for today is preventive oncology. आभाळ फाटलेले घालू कुठे मी टाका, धरणी दुभंग गेलेली मारू कोणा मी हाका. This phrase describes a grave situation of earthquake, and I'm very sure when diagnosis of cancer strikes to a family, the situation is not different from this. We as doctors and oncologists see patients and families spending lakhs of rupees on diagnostic tests, PET scans, and for treatment. But how much time and effort we take to stay away from cancer? So this is open secret. Today I'm going to discuss. So parts of my presentation today would be three. The first is problem statement and horrible morbidity, and third one would be picture journey of seeing morbidities of cancer surgery. First is problem statement. So we generally see around 10 lakh people in India per year diagnosed as cancer. It is estimated that by 2030, almost 1 in 4 people might develop cancer. By 2030, India might be called as cancer capital of world. So this is such a horrible situation. And what are common cancers in India? In men, it is lung and oral cavity, and in women, it is cervix and breast. So what are causative factors of malignancy? The main role is played by diet, I would say wrong diet, and tobacco, and others are food additives, medicines, pollution, alcohol, sun exposure, and occupational hazards. We need to understand risk factors for malignancy first. So there are few non-modifiable factors like old age and family history, and few modifiable like unhealthy lifestyle, westernized lifestyle, poor diet, lack of physical activity, overweight and obesity, environmental factor, occupational carcinogens, radiation, chemical exposure, and alcohol. First and foremost, tobacco and tobacco related cancers. So cigarette smoke or tobacco has 70 types of chemicals in it, and they can practically cause all types of cancer in your body. It is very hazardous. Alcohol can cause 7 types of cancer, including breast, bowel, oral cavity, and esophagus. If you are overweight or obese, you have risk of having these 13 types of cancer: breast, kidney, bowel, endometrium, and esophagus. Yes, infection do cause cancers, namely HPV. They cause genital cancers, penile cancers, cervical cancers. Hepatitis and HIV also causes cancer. This slide shows that we have habit of running after bus and after its departure, and many a time we may miss the bus. Same applies to cancer. We should run to prevent the cancer, and we should not run after it is diagnosed. So we should be knowing warning signs, warning signals of cancer. So if there is change in your bowel bladder habits, it could be malignancy, a non-healing ulcer, unusual bleeding or discharge, unusual PV bleeding, postmenopausal bleeding, breast lump, dysphagia, obvious change in wart or mole, or cough. These are 4 stages of malignancy or cancer. You see, first and second stage, the survival rates are great. In first, if you are diagnosed in first stage, there are 98% chances that you can get cured, and second, it is 88%. But as soon as you reach to stage 3, the survival drops to 52%. That means it is very important to get diagnosed early if you're going to have malignancy. So what are modalities with which we treat malignancy? Mainly 3 modalities are established: surgery, then chemotherapy and radiation. Few immunotherapy modalities are also available. So what is new in surgery? We do a lot of organ conservation, breast conservation, limb conservation, laparoscopy, thoracoscopy, robotic surgeries, plastic surgical reconstruction, and chemoport insertion for giving chemotherapy. I'd like to highlight this picture. Here a stoma model is shown with stoma bag. Many times we have to we have to do abdominal surgery and we have to form a stoma. In these patients, there would be a bag to collect the feces, and patients do get disturbed because of this. Many a times they refuse the surgery, and so curative option of surgery. But we have to sit with them, we have to counsel them, we have to make them understand that with stoma bag you can look like this model also, and you can behave normally, you can function normally. Palliative care is a treatment form which is offered to patients who cannot get cured. So we offer them pain control with narcotics. We add life to their days and we do not extend their life. We offer them good end of life care and pain-free dignified death. So now second part will start, cancer prevention. So really, can we prevent a cancer? Yes, definitely. It is lifestyle related disease and we can change our lifestyle to healthy one. We can definitely prevent the malignancy. It is said that apple a day keeps a doctor away. So a healthy apple a day will keep malignancy away. So we should be eating healthy food. We should be keeping ourselves active. We should get screened for malignancy. We should have healthy weight. We shouldn't be overweight or obese. We should be smoke free and we should limit alcohol. That is the healthy mantra to prevent malignancy. This is health pyramid. There are two main parts. One is diet and one is physical activity. In diet, we should include more of grains, vegetables, milk, fruits, and we should reduce amount of oil and meat. The second main important part is daily physical activity. Many people will correlate with this slide. They always jump to gym. We see a lot of crowd in gym in January and we see empty gyms in December. So we should do regular exercise. That is a brisk exercise of 30 minutes of any type, any way, brisk walk, cycling, running or swimming, anyway, but it should be regular. Our young generation is addicted to this form, processed food, fast food, and it is this food is processed at high temperature. Multiple methods are done on these foods to make them delicious, and because of that there are a lot of carcinogens in them, and consuming them regularly would increase our risk of having malignancy. A lot of ladies would be angry on me by seeing this slide, but yes, cosmetics overuse really can cause cancer, skin cancer and lip cancer. And men too use hair color. So there is no permanent solution for cosmetics or beauty products. We just cannot stop them, but we can use branded products. We shouldn't change brands frequently and we should limit their use. We use a lot of aerosolized chemicals like room freshener, but they have aerosolized chemicals and inhaling them would increase our risk of having lung malignancy. We should reduce exposure of X-rays, radiation to our support staff. Plastic, yes, a lot of being said and done about plastics, but we still use them regularly. We should not heat the food in plastic. We should not freeze the food in plastic containers. We should not store water in plastic bottles. I would like to ask this question to audience. Where do you keep your mobile phones while sleeping? And I'm sure that 90-95% will answer that they sleep bedside. They keep their mobile bedside. So there is a study going on that has suggested that if we use mobile phone radiations, radio frequency waves continuously for 30 years, then that can increase risk of having brain tumors. So we should limit use of mobiles. I don't know how safe milk or oxytocin free milk we are drinking, but we should find a way to have a safe milk. Even microwave, we shouldn't use reuse food or reheat food in microwave because it processes food at very high temperature and it induces carcinogens in food and so increases our risk of having malignancy. Stress is also so important. We are ready to serve a patient at any time at night also, but we are not ready to have our lunch time fixed. So stress-free life is also must to avoid risk of malignancy. Yes, vaccines are also there. cervical cancer could be prevented by HPV vaccine. So it is advisable for young girls. Early detection provides best opportunity for successful treatment. Cancer screening examinations are tests performed when you are healthy, and reliable screening tests are available for certain cancers like cervix, breast, and colon. We should add technology to kill the cancer, and we should add lifestyle changes to prevent the cancer. The word itself says that I can survive. It takes just 4 or 5 minutes more to see a few surgical picture journey, I would say, to show the morbidity. In this picture, the patient was operated for lower lip malignancy, squamous cell carcinoma. In that, lip was resected and marginal mandibulectomy was done, and the defect was reconstructed with radial forearm free flap. This is surgery of commando, squamous cell carcinoma buccal mucosa, and the reconstruction was done with PMMC flap. See the morbidity of a procedure. This is total laryngectomy surgery. Whole of the larynx was removed for malignancy, and a patient was not able to speak. So we have introduced Provox, a device which will produce voice. In this surgery, whole of the half of the face of patient was removed because there was malignancy, and reconstruction was done with free flap and scalp flap. Such a morbid procedure. Then this is forehead flap for defect reconstruction of face. This is a young lad with maxillary cancer, and his left eye shows proptosis. His left eye was not having any vision. We have to remove his complete maxilla, left eyeball. This is a specimen. You can see tip and eyeball removed along with. And the defect was reconstructed with ALT flap. He is looking good, but such a morbid procedure, he has to lose his eyeball. This old age man was operated for head neck malignancy, and the reconstruction was done with radial forearm free flap. This is hemiglossectomy. Half of the tongue was removed, and it was reconstructed with radial forearm free flap. This is breast malignancy with breast enlargement. Here, breast conserving surgery was done. Breast was preserved. The tumor was removed. Axillary lymph node dissection was done, and the defect and symmetry of the breast was maintained. This is total gastrectomy. Whole of the stomach has to be removed. This is again a breast conservation. This is pancreatic duodenectomy specimen after adenocarcinoma of periampullary region, known as Whipple's procedure. Again a breast conservation. This is again a breast conservation. Whole of the breast, almost whole of the breast was removed, and the flap was harvested from back, LD flap, and it was filled in the breast. And this is our final cosmesis. This is again a squamous cell carcinoma of lip. Whole of the almost half of the lower lip was removed, and it was reconstructed with radial forearm free flap. This is RPLND, retroperitoneal lymph node dissection. You can see IVC, aorta, common iliac arteries, and vein. This was done for testicular tumor. This is surgery done for CA penis, total penectomy with perineal urethrostomy with bilateral inguinal block dissection. And this is surgery for lower jaw squamous cell carcinoma. His lower 1/3 of mandible was removed. You see chin is lost, and we have to reconstruct it with fibula flap, free fibula flap harvested from lower lip. We have grafted the lower lip, and this is his final cosmesis. So it is better to stay away from oncosurgeon's knife. So preventive oncology is really important. We should stay away from malignancy. Thank you.
Excellent.
Thank you, Dr. Prasad Sur, sir, for your wonderful session. From this session, we came to know how one can prevent various cancer conditions by only practicing some change in your day-to-day habits. Now, I would like to invite Dr. Akhtar Hussain, sir, to give his concluding remarks.
Thanks, Dr. Soor, sir, for his excellent presentation. It was full of tips how to prevent malignancy, because he has very well shown that it is rather very difficult to do surgical work. It is very morbid. So it is always better if you prevent malignancy, and there are so many take-home messages given by Dr. So, sir. I appreciate his talk and thank him for the excellent presentation. Thank you, sir.
Any questions from audience? Sir, there is one question. Role of genetic study in oncology.
Yes, sir. 5% of malignancy, mainly breast and ovarian malignancies, could be familial, could be genetically inherited. So if more than 3 members of same family are having same malignancy, then there is definite role of genetic study. Genetic mutations could be done, and we can diagnose that whether other members of family also have risk of having malignancy or not.
Thank you, sir.
What is the cost of this procedure, sir?
So these procedures like BRCA1 and 2 mutations are quite costly, around 75,000 or some is the cost of procedure.
Okay.
So these are quite costly.
Okay. Thank you, sir.
Thank you. Thank you, KHAMGAON IMA, for giving me opportunity. Thank you.
Thank you, sir.
Dr. Soor, sir, I think you are a very nice facility which is available for the Vidarbha all patients, cancer patients, because as we know, all the patients who are suffering from the cancer, when they come to know that they are having cancer, they realize how to go to Tata Hospital and how to go to Mumbai only, because these people's idea is only Tata Hospital is the place where they can get the proper treatment. But I think your hospital, it is a very good opportunity for all of cancer patients. And I want to ask one more question, that is it different schemes which are available for the poor patient in your hospital?
Not right now, madam. I have applied for them, and few months I might start with facilities.
Okay.
Thank you. Thank you for kind words. Thank you.
Thank you, sir. Now it's time for lunch. We will meet again after 30 minutes. Thank you.
Hello, Sunil sir from Zerotech. Am I audible? Hello, Mr. Sunil from Zerotech. Hello. Deepak Bhatt sir.
Yeah.
Can you am I audible?
Yes, sir. You are audible.
Okay.
Mr. Sunil is there. Sir.
सुनील सर, स्क्रीन शेयरिंग पॉसिबल हो जाएगा ना हमारा सबका, चारों स्पीकर का?
नहीं,
इसको पिन करना।
अच्छा, आपका चालू है स्क्रीन शेयरिंग।
मेरा
we are live also as of now.
ओके,
करेक्ट सर?
यस
सर, गौरव दिख रहा है बराबर?
नहीं, बैकग्राउंड इज परफेक्ट।
Sir, we'll start in next 5 minutes. Just be aware that it is streaming live as of now on all platforms.
सुनील सर, वो कंट्रोल्स दिए क्या होस्ट और ये?
अभी सर 2:30 बजे
और मुझे इसमें पूछना था, इसमें रिकॉर्डिंग का ऑप्शन है क्या? हम लोग हमारा रिकॉर्ड कर सकते हैं क्या अलग से?
सर अपन उसमें स्टूडियो उस पे रहेगा, ऑनलाइन रहेगा, तो उसमें से एक्सपर्ट निकाल सकता है। नहीं तो मैं आपको रिकॉर्डिंग आपको दे देता हूँ। इस पर आई जस्ट स्टार्ट द रिकॉर्डिंग वंस यू स्टार्ट।
ठीक है ना, इसका रिकॉर्डिंग अगर पॉसिबल रहा तो आप
ठीक है सर।
ये वाला जो पूरा सेशन है 2 घंटे का 10 कॉन का,
and just give us 5 more minutes, we'll resume in 5 minutes.
Okay. पराग सर, श्वेता मैडम को बोल दिए क्या?
यस मैडम इज
ओके
मैम इज ऑनलाइन। आशीष इज देयर?
हाँ सर।
ग्रेट। मास्क निकाल ले।
निकाल देता हूँ। बैकग्राउंड बराबर सीधा दिख रहा है ना?
हाँ, ये परफेक्ट। मेरा बैकग्राउंड मुझे नहीं दिख रहा है, कैन यू सी?
सर आपका वीडियो ऑफ है।
अब आया होगा?
हाँ, अब आ गया सर।
ओके। और जो स्पीकर रहेगा उसका पिन करेंगे वीडियो।
हाँ।
बाकी लोगों का अपन वीडियो ऑफ करेंगे।
वेल्थ वाले बहुत वेल्थी लग रहे हैं यार।
पंकज भाऊ नमस्कार।
नमस्ते सर।
सर मंत्री सर, आपको भी वेल्थी बनाने के लिए प्रेजेंटेशन करने।
पंकज भाऊ का वेल्थ लेने का अपने को उनके तरफ से इक्विटेबल डिस्ट्रीब्यूशन करना है।
वाह, क्या बात।
नाइस टू सी यू मैम, थैंक यू। पंकज सर, मैम,
eagerly waiting to hear you all.
ग्रेट।
आप सीखते आज रहा आपसे सब कुछ।
अरे नहीं, इट विल बी अ ग्रेट जर्नी। बहुत अच्छा, इट विल बी अ ग्रेट।
बिल्कुल, थैंक यू।
मैडम
गौरव,
हाँ
स्क्रीन शेयरिंग स्टॉप करना।
हाँ, किया, स्टॉप किया सर, अभी नहीं है।
ओके, आई विल ट्राई। हाँ, ये सब मेरा देख लेता एक बार, ये हो रहा कि नहीं हो रहा। इज माय स्क्रीन इज गेटिंग शेयर्ड?
यस सर।
या, परफेक्ट, great. So I'll stop the screen share now for time being. Ishan sir, Shankapal sir, good afternoon.
Good afternoon, sir.
Deepak sir. Background.
Just check.
Now it's okay. Perfect. Deepak, perfect.
Thank you.
सर थोड़ा दीपक सर का इको हुआ शायद, देखना एक बार, चेक कर लेना।
दीपक सर फिर से एक बार। हेलो दीपक भट्ट सर। Great. Shweta ma'am is close now.
Yes.
We'll exactly start at 2:30. 1 minute more.
Just let me know when to start.
Yes, ma'am.
Hello, everyone. So I'll be starting the session. Okay. Is it time?
Just 30 seconds.
Yeah. Okay.
नाही तिकडेच ठेवलं म्हणजे मग कसं तू एकदमच खाली उठतोय.
Welcome, dear friends, for the last but not the least, rather the best session of the day. You all must be saturated with knowledge. Let's now relax with a new field, new venture in our KGCON 2022, that is WealthCon. First of all, I will thank the WealthCon team for giving us the opportunity to have their time. And of course, this series is meant for doctors and is created by doctors. I call upon Dr. Rajendra Goti sir and Dr. Prashant Shankpal sir as the chairpersons for this session. WealthCon team, Dr. Shweta, Dr. Parag, Dr. Gaurav Latta sir, Dr. Deepak Bhatt sir, Dr. Ashish Jhunjhunwala sir. I request you, you can have the screen. Thank you.
Thank you so much, Dr. Vinod. Am I audible?
Yeah.
Yes, yes.
Thank you. So good afternoon, everyone. This is Dr. Shweta Matreja here, radiologist from Mumbai and Chief Administrator of WealthCon India. On behalf of WealthCon, I'd firstly like to express my sincere gratitude to the President, Dr. Surekha ma'am, the Secretary, Dr. Vinod sir, and the entire team of IMA KHAMGAON branch for giving us this opportunity. I would also personally like to thank Dr. Anand Rathi sir and Dr. Aniket Mende sir for coordinating with us so that we can bring to you all this basic investor course today. So you will all agree that it is always good to be alert and vigilant. But there is a widespread misconception amongst doctors that finance is a very difficult subject and dealing with numbers is not our cup of tea. Now, WealthCon is a financial education drive by the doctors, of the doctors, and for the doctors. Its main aim is to create awareness about financial literacy and make doctors self-reliant in all financial matters, be it personal finances or taxation, investments, insurance, loans, you name it, and we know it. So I would personally like to introduce you all to our first speaker, Dr. Parag Tapre sir, pediatric and neonatal surgeon from Akola, a proud WealthConian since 2019, and as we fondly call him, the Iron Man of WealthCon. Over to you, sir.
Thank you, Shweta ma'am. Thanks a lot for your kind introduction. I'll share my screen and please let me know whether screen is. My screen is visible?
Yes, sir.
Yes, sir.
Okay. Now I'll pin this my video.
It is pinned, sir.
Okay, great. So, namaskar and good afternoon. First of all, I will like to thank KHAMGAON team for inviting us. And it's our journey of darkness to light and from ignorance to the knowledge. Welcome to WealthCon. What is WealthCon? Is it a medical association? Is it a company? Is it an NGO? No. It's an ideology. It's an ideology of financial education drive for the doctor by the doctors. It's a revolution created by none other than our mentor, guru, philosopher, guide, Dr. Ramnath Gupte sir. First of all, I would like to thank him for creating a huge pool of financially educated doctors. You can imagine, it is a community. WealthCon is a community of 20,000 plus doctors. And these are spread across India, but not only India, 12 other countries of the world. And as I already told you, it is a financial education drive for the doctors by the doctors. This is our regular disclaimer. It's our educational platform. We are not a financial advisor. We do not provide any financial advisory services. All the speakers of WealthCon are super specialty doctors, We are not a SEBI registered financial advisor or agent. All the metaphor examples used here are for the illustration purpose only, and they are not intended to demean any person, class, or community. To start with any program of our WealthCon, we'd like to thank all the participants, all the organizers, in spite of their busy schedule and their family time. Sunday is a family time. Still, we are sitting here in a post-lunch session of this KHAMGAON meeting. So thank you all. And before starting our main discussion, I'd like to tell you one metaphorical story of a Rajhans, ज्याला आपण मराठीत राजहंस म्हणतो. आणि ही एक मेटाफिजिकल स्टोरी आहे. राजहंसाला आपण दूध आणि पाणी जर मिक्स करून दिलं तर राजहंस फक्त त्यातलं दूध पितो आणि पाणी सोडतो. त्याचप्रमाणे आय रिक्वेस्ट ऑल ऑफ यू टू टेक व्हॉट एव्हर यू लाईक, and if you don't like anything, please discard it. It's a request to all of you. So you take it what you like, and please don't judge anybody from our team. So what are the objectives of our today's webinar? We can read this. The main objective of our webinar is to make the doctor community self-reliant, Atmanirbhar in financial matters. And at the end of this webinar, you will be able to select the good quality mutual funds, good quality shares, and I will definitely tell you at the end of this webinar, you are all at par with your financial advisor. जो कुछ financial advisor हमें advise करते हैं और इतना difficult करके रखते हैं, उनके at par आप रहेंगे at the end of this 2-hour program. So let's begin our financial education journey. Why this financial education is important and necessary? You must be knowing on the right side of our panel, this is a 5% club. And this 5% club, they hold 80% of the wealth of our country. Can you imagine? And 90%, 95% other janta, they will hold the 20% of the wealth of the nation. And what is the reason? इसके पीछे कारण क्या होगा? The कारण is the financial education. The only difference between 5% and 95% is the financial education. So it's our drive. It is our thinking that it is the financial education of our doctors by the doctors. And there are few myths about the financial education. अभी श्वेता मैडम ने भी बताया था कि बहुत सारी चीजें हमारे दिमाग में बैठाई गई है, कुछ मिथ्स है, एज ओल्ड मिथ्स. फॉर एग्जांपल, मनी इज नॉट इंपॉर्टेंट. एग्री, मनी इज नॉट इंपॉर्टेंट, बट वॉट एवर इंपॉर्टेंट इन लाइफ यू रिक्वायर, इट विल रिक्वायर मनी. फॉर एग्जाम्पल, गुड एजुकेशन. फॉर एग्जाम्पल, अब कोरोना काल में अगर किसी को कहीं एडमिट करना है, कोई अच्छे हॉस्पिटल में जाना है, फॉरेन एजुकेशन लेना है, ऑल द इंपॉर्टेंट लाइफ थिंग्स इन अ लाइफ, दे रिक्वायर मनी. अनदर मिथ इज रिच पीपल आर बैड. जो पैसा कमाता है वो बुरा आदमी है. हमारे बॉलीवुड की मूवीज, हॉलीवुड की मूवीज, एवरीबडी टेल्स अस कि ये बड़ा आदमी हुआ है, इसने बदमाशी करके ही बड़ा आदमी हुआ होगा. वो एक जमाने में ठीक था, लेकिन लेट मी टेल यू डियर फ्रेंड्स, दिस 5% पीपल, they pay near about 20 to 25 lakh crore of direct taxes, income tax. And on the basis of that income tax, 95% janta, they are getting good roads, they are getting good quality hospitals and everything. So how can we tell that rich people are bad? First of all, we have to break this myth that rich people are bad. एक जमाने में था कि जो दूसरों को लूट के लोग अमीर बनते थे, लेकिन अभी वैसा नहीं रहा है. अनदर मिथ इज डोंट स्पीक अबाउट मनी इन फ्रंट ऑफ द चिल्ड्रन. बच्चों के सामने पैसे की बातें मत करो. बट लेट मी टेल यू वन थिंग, हम लोग बच्चों के सामने सिर्फ इन्वेस्टमेंट की बातें बताते नहीं हैं, लेकिन घर के बच्चे हमारे सामने स्पेंडिंग के बारे में सब देखते हैं. सो दे आर एक्सपर्ट इन स्पेंडिंग, लेकिन उनके सामने हम क्या नहीं रखते हैं, तो इन्वेस्टमेंट की बातें नहीं रखते हैं. सो इट इज ऑल्सो वन मिथ. अनदर मिथ इज शेयर मार्केट इज सट्टा, बहुत रिस्की है. तो लेट मी टेल यू, शेयर मार्केट अभी 150-200 साल से पूरे वर्ल्ड में काम कर रहा है. अगर सट्टा रहता तो इतने दिन तक काम नहीं होता. दूसरी बात, जिन लोगों को सट्टा करना है, सट्टा लगाना है, वो कोई भी चीज के ऊपर में सट्टा लगाते हैं. हमारे एरिया में देखा होगा आपने, क्रिकेट मैच के ऊपर सट्टा लगता है. यहां तक कि बारिश आने के बाद में टीनातून पाड़ी पड़ेल का याच्यावरही सट्टा लागतो. आई रिमेंबर दोज डेज, मुझे याद है कि उसके भी ऊपर सट्टा लगता है. और वी हैव द बिग सेंटर्स, अकोला, खामगांव, these are the big center for this kind of bookies. So apart from intraday, which is a speculative kind of thing, share market is not satta. अगर आप ठीक से उसमें पढ़ाई करो, और आप देखो, हम लोग मेडिकल ग्रेजुएट्स हैं, हम लोग मेडिकल की इतनी बड़ी बड़ी किताबें पढ़ सकते हैं, तो ये तो शेयर मार्केट को हम लोग क्यों नहीं पढ़ सकते? हम पढ़ सकते हैं, मार्केट को हम समझ सकते हैं. दूसरा है कि शेयर मार्केट में रिस्क है. अब वो अभी तो बीच में एक अच्छी सीरियल आई थी, रिस्क है तो इश्क है. तो कैसा है कि रिस्क तो है. अब कैसे 2 व्हीलर 4 व्हीलर चलाने में भी तो रिस्क है. रोज के हजारों लोग उस रिस्क के कारण अपनी जान गंवा के बैठते हैं. वैसा तो उतना तो रिस्क नहीं है. तो हम लोग शेयर मार्केट को पढ़ सकते हैं, सोच सकते हैं. और एक मिथ है कि फाइनेंस बहुत डिफिकल्ट है, हम अपने को जमेगा नहीं. लेट मी टेल यू, वेल्थ कॉन में we have a 500+ स्टुडंट ऑफ 7th ग्रेड, 7व्या वर्गातली मुलं आहेत, त्यांचा एक ग्रुप आहे, फ्युचर इन्व्हेस्टर अँड एंटरप्रेन्योर फाइन ग्रुप. 7व्या वर्गातल्या मुलांसाठी जितकं जे गणित आवश्यक आहे तेवढंच तुम्हाला आवश्यक आहे टू नो द फायनान्स. वी आर टीचिंग देम हाऊ टू सिलेक्ट गुड क्वालिटी फंड्स, गुड क्वालिटी शेअर्स 7व्या वर्गाच्या 12 वर्षाच्या 14 वर्षाच्या मुलांना. So with all responsibility, I can tell you, finance is definitely not a difficult subject. क्या इंपॉर्टेंस है, क्यों रहना चाहिए फाइनेंशियल एजुकेशन? देखो, अभी लाइफ एक्सपेक्टेंसी बढ़ गई है. यू मस्ट बी सीइंग योर पेरेंट्स, अवर नेक्स्ट अगली जनरेशन के 80+ हमारे पेरेंट्स है. लाइफ एक्सपेक्टेंसी हमारी जो थी एट द टाइम ऑफ इंडिपेंडेंस और आज एक नियर अबाउट 2 टाइम्स का फर्क पड़ गया है. कॉस्ट ऑफ लिविंग बढ़ गया है. जो पहले हम लोग कॉस्ट ऑफ लिविंग था और आज का कॉस्ट ऑफ लिविंग बहुत बढ़ गया है. ऐसा कंसीडर करो कि हम लोग अभी 65-70 तक हम लोग हमारी प्रैक्टिस कर पाएंगे, लेकिन 70 के बाद में 15-20 साल तक हमें एक पैसिव इनकम के ऊपर में वी आर नॉट एबल टू डू द वर्क, बट वी हैव टू हैव, हमारे लिए कुछ पैसा लगेगा हमारा रोजमर्रा की काम करने के लिए, हमारा को जिंदा रहने के लिए. वो कैसा करना है, वो उसके बारे में भी हम आज बात करेंगे. प्लीज 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 डोंट कंसिडर योर चिल्ड्रेन एज योर रिटायरमेंट प्लान. एक बहुत अच्छी मुझे खलील जिब्रान की एक छोटी सी पोएम याद आ रही है, उसके कुछ मैं लाइंस बोलता हूँ कि योर चिल्ड्रंस आर नॉट योर चिल्ड्रन, दे आर द सन्स एंड डॉटर ऑफ द लाइफ्स लॉन्गिंग फॉर इटसेल्फ, दे कम थ्रू यू बट नॉट फ्रॉम यू, एंड दो दे आर विथ यू येट दे बिलोंग नॉट टू यू। वो तुम्हारे नहीं है, वो तुम्हारे साथ में रहने वाले नहीं है। पूरी दुनिया बहुत बड़ी हो चुकी है, एक ग्लोबल विलेज हो चुका है, बच्चे तुम्हारे साथ में रहेंगे ऐसा कोई आवश्यक नहीं है। सो डोंट कंसिडर योर चिल्ड्रन एज योर रिटायरमेंट प्लान। एंड लास्ट बट नॉट द लीस्ट, नेवर एवर आउटसोर्स योर इन्वेस्टमेंट डिसीजन टू एनीवन एल्स। अपने इन्वेस्टमेंट डिसीजन जो है वो किसी के ऊपर में मत छोड़ो, खुद आत्मनिर्भर बनो, खुद अपने इन्वेस्टमेंट डिसीजन लो एंड बी अ फाइनेंशियली एजुकेटेड। हम लोग डॉक्टर लोग हैं, हम डॉक्टर लोगों को ना थोड़ा सा निमोनिक्स और इसके बारे में बात करना अच्छा लगता है। सो दिस इज अवर टिपिकल वन फॉर्मूला विच इज गिवन फॉर द डॉक्टर्स फॉर द फाइनेंशियल एजुकेशन, टैबलेट ECTIL। व्हाट दिस ECTIL स्टैंड्स फॉर? हम लोग क्या बात करने वाले आज? हम लोग बात करेंगे अगले 30 मिनट में, हम लोग हमारे अर्निंग्स के बारे में बात करेंगे, हमारे स्पेंडिंग्स के बारे में बात करेंगे, कुछ इन्वेस्टमेंट्स के बारे में बात करेंगे, टैक्सेशन के बारे में बात करेंगे, यहाँ पे इंश्योरेंस का आय लिया है ECTIL में, और लोन्स के बारे में बात करेंगे। सो लेट्स बिगिन। व्हाट इज अर्निंग और इनकम? इनकम क्या होता है? एक्टिव इनकम और पैसिव इनकम। एक्टिव इनकम क्या है कि हम हमारा टाइम, हम हमारा स्किल, हम हमारा नॉलेज देने के बाद में जो रिटर्न्स हमें मिलता है, हमारा टाइम, नॉलेज, स्किल्स, हमारे OPD में हो, OT में हो, जो भी हम लोग हमारे स्किल्स प्रोवाइड करते हैं, उसमें से जो भी हमें पैसा मिलता है वो हमारा एक्टिव इनकम। लेकिन आपने देखा होगा कोरोना टाइम में, फर्स्ट सेकंड वेव के टाइम, ऑल सर्जन्स या तो उनके पास में पेशेंट पहुंच नहीं पा रहे थे, या तो पेशेंट को रिस्ट्रिक्शन था इसलिए पेशेंट आ नहीं पा रहे थे। तो दिस 3-4 मंथ वेर अ बिग डेंट फॉर लॉट ऑफ आवर डॉक्टर फ्रेंड्स। फिजिशियन लोगों का ठीक था, लेकिन बाकी सर्जिकल फील्ड्स में देयर वाज अ बिग डेंट फॉर आवर एक्टिव इनकम। तो तब सबके ध्यान में आ रहा था कि नहीं, अभी एक पैसिव इनकम का सोर्स हमें रहना चाहिए। So what are the passive source of income for us? As I have enumerated here, become an investor, own a business, और कुछ रॉयल्टीज, कुछ राइट्स उसमें से मिलता है। उसमें से बिजनेस ओन करना है या फिर रॉयल्टीज करना है, उसके लिए थोड़ा डिफिकल्ट टाइप ऑफ स्टडी लगता है। बट डेफिनेटली बाय इन्वेस्टिंग योर एसेट्स you can be a passive investor, or you can generate the passive income. And I can tell you with the full responsibility, if you can earn a passive income from your investments, that is nothing like it. I will come on that topic in a few future slides. हम लोग ना, सब लोग स्पेंडिंग के बारे में बहुत बड़ा हमारा PhD हुआ रहता है। There is one Parkinson law कि no matter how much money you earn, you tend to spend the entire amount and save a little. यहाँ पे दो ग्राफ है, टिपिकल पार्किंसन लॉ के दो ग्राफ है। दिस रेड ग्राफ इज अ लो इनकम, कि उसका इनकम कम है, ऊपर का ग्राफ है कि उसका इनकम ज्यादा है। दोनों का इनकम कितना भी बढ़ा तो भी नीचे की जो ब्लू लाइन है वो है इन्वेस्टमेंट या सेविंग, वो सेविंग कभी भी बढ़ता नहीं है। सो वॉट एवर इनकम यू हैव, यू आर हैविंग PhD इन स्पेंडिंग। हम लोग टिपिकल है 2-3 लाख रुपए महीने का कमाने के बाद में एक पोस्ट ग्रेजुएट स्टूडेंट जब भी अपना प्रैक्टिस चालू करता है, एम रहता है कि भाई 2-3 लाख रुपए कमा लूंगा। जैसे ही उसका इनकम 2-3 लाख तक होता है पर मंथ, उसका चालू हो जाता है कि इसको मैं खर्चा कहाँ करूं, इसको स्पेंड कहाँ करूं, और वो स्पेंड करते करते दे कम टू द एक्सटेंड कि उनके पास में कुछ सेविंग रहती नहीं है। स्पेंडिंग के अगर कोई इनकम हमें होता है, हम लोग कुछ इनकम करते हैं, आता है घर में पैसा आता है, तो दो चीजें हो सकती है। एक तो हम लोग उसको स्पेंड करेंगे या तो सेव करेंगे। सेव करेंगे तो क्या, जैसे 100 रुपए कमाया तो 80 रुपए सब खर्चे में चले गए, 20 रुपए रह गए, तो उसको या तो फिर हमने कोई इग्नोरेंस पॉलिसीज में डाल दिया, या फिर रियल एस्टेट में डाल दिया, या फिर खर्चा कर लिया। सो स्पेंडिंग के भी दो टाइप्स है। दीज आर द टिपिकल वेल्थकॉन डेफिनेशन ऑफ पॉप्स एंड पॉन्स। वेरी इंटरेस्टिंग कंसेप्ट। पॉन इज क्या, प्रोडक्ट ऑफ नीड। अब प्रोडक्ट ऑफ नीड्स क्या है? जब हम लोग खर्चा करते हैं, स्पेंड करते हैं, तो प्रोडक्ट ऑफ नीड क्या है? जो लिविंग एक्सपेंसेस है, रूटीन कार है, इलेक्ट्रिसिटी है, हमारे क्लिनिक में लगने वाले एक्सपेंसेस है, दीज आर द रिक्वायर्ड फॉर लिविंग यूटिलिटी एंड कन्वीनियंसेस। तो दीज आर द प्रोडक्ट ऑफ नीड। उसमें कोई डाउट नहीं, इसमें खर्चा होगा ही, एक खर्चा करना ही चाहिए। बट देयर आर सम प्रोडक्ट ऑफ प्रेस्टीज which are not at all required for your survival,
They are only required for prestige and style sake. For example, बड़ी कार, बड़ा घर, बड़ा ज्वेलरी, हाई फाई फोन, वो नहीं रहना चाहिए ऐसा मैं नहीं बोलता हूँ, लेकिन वो अगर करते रहे और उसमें से भी ज्यादा, उसके लिए हम लोग बहुत सारे लोन्स लेते हैं, उसके ऊपर भी मैं आऊंगा आगे, तो दैट विल बी क्रिएटिंग अ बिग प्रॉब्लम फॉर अस. सो हाउ टू डिफरेंशिएट पॉन्स एंड पॉप्स, कैसा डिफरेंशिएट करना कि हमारी नीड क्या है और प्रेस्टीज के लिए हम लोग क्या कर रहे हैं. तो उसके लिए हमारे मेंटर ने एक फेसबुक टेस्ट या पार्टी टेस्ट इन्वेंट किया है. सिंपल है, जो चीज आप फेसबुक पे पोस्ट करना चाहते हो, बड़ी कार, जो चीज आप पार्टी में दिखाना चाहते हो, द थिंग विच यू वांट टू पोर्ट्रे इन फ्रंट ऑफ ऑल द पीपल, उनको दिखाना चाहते हो, शो ऑफ करना चाहते हो, वो सब प्रोडक्ट ऑफ प्रेस्टीज है. उससे ज्यादा कुछ फर्क नहीं पड़ता. सामने आपके हाँ हाँ करते लोग, पीछे जाने के बाद में आपल्या नावानी बोटं मोडतात. सो एनीथिंग which you want to portray in front of people on Facebook or party, that are the product of prestige. This is a typical pyramid of income and assets. In नीचे में जो है low income low asset, that we call as लीला. 70% people are having low income, almost 6 to 8 lakh per annum income होता है. उनके पास में इनकम इतना कम है कि वो लोग assets create नहीं कर पाते. सेकंड ग्रुप है 20% पीपल, 25% पीपल आर हाई इनकम लेकिन असेट्स नहीं है, जिसमें हम सब डॉक्टर लोग आते हैं. इनकम है लेकिन हमारा पूरा इनकम, वी आर एक्सपर्ट इन रियल एस्टेट, बहुत सारे रियल एस्टेट लेके रखे हैं, उसके बारे में भी मैं आऊंगा आगे नेक्स्ट स्लाइड्स में. बट वी आर अ ग्रुप ऑफ हाई इनकम बट लो एसेट्स एंड ओनली 5% पीपल आर हाई इनकम हाई एसेट. हमारा एम ये होना चाहिए कि हम लोग हाई इनकम लो एसेट से लेकर हाई एसेट्स में कैसे जाएंगे. इसके लिए क्या करना चाहिए, इसका हम लोग आज एक बेसिक इन्वेस्टर कोर्स में देखेंगे. अब इन्वेस्टमेंट्स, क्या सेविंग और इन्वेस्टमेंट में फर्क क्या है. सेविंग क्या है कि हम लोगों के पास में 100 रुपए हमारे पास में आए तो हम लोगों ने उसमें से 70-80 रुपए खर्चा कर लिए और जो 20 रुपए बच गए वो हमारे सेविंग हो गए. और व्हाट इज इन्वेस्टमेंट, तो इन्वेस्टमेंट के जो कॉम्प्लिकेटेड डेफिनेशन में अपन नहीं जाएंगे. Investment is buying appreciating asset is an investment. For example, anything which puts money into your pocket, तुम्हारे खीसे में जो पैसे लाके देता है वो तुम्हारा एसेट हो गए. फॉर एग्जाम्पल, एक यहाँ पे एग्जाम्पल एक चिकन का दिखाया है. शी इज गिविंग एग्स एवरी डे, सो दैट चिकन इज अ एसेट फॉर अस बिकॉज दैट इज गिविंग अस अ इनकम ऑन अ डेली बेसिस. And anything which takes away the money from your pocket is liability, including here we have shown a small dog here which is not having, it takes money from us, it takes money from your pocket. This is for just example. So these are the example of liabilities. And what I was talking about, like जो asset हम समझते हैं, जो हमारे balance sheet में assets है, हमारा बड़ा घर, हमारा furniture, these are all pseudo assets because they are difficult to sell. उसमें इमोशनल इन्वॉल्वमेंट रहता है. ज्वेलरी, दैट इज अ सूडो एसेट. अगर ज्वेलरी बेचने का काम आया तो घर में कितना महाभारत होगा, ये सब अपने को, सब लोगों को पता है. सो व्हाट आर द ट्रू एसेट्स? द ट्रू एसेट्स आर इजी टू सेल, उनकी लिक्विडिटी रहती है, देयर इज नो इमोशनल इन्वॉल्वमेंट. एग्जांपल है कैश है, एफडी है, म्यूचुअल फंड्स, लैंड प्लॉट, कमर्शियल बिल्डिंग है, गोल्ड कॉइन्स है. दीज आर ट्रू एसेट्स. एसेट्स में भी देयर आर 3 टाइप्स ऑफ एसेट्स. फिजिकल एसेट्स, फॉर एग्जाम्पल गोल्ड, रियल एस्टेट, मशीन्स में भी अपनी सोनोग्राफी मशीन है, सिटी स्कैन की मशीन है, दिस आर ऑल मशीन्स, एमआरआई की मशीन है, दिस आर ऑल फिजिकल एसेट्स. फाइनेंशियल एसेट्स आर मेनली ऑफ 2 काइंड, जेनरिक, इक्विटी एंड डेट. इक्विटी तो आप समझ सकते हैं, शेयर मार्केट में जो भी होता है, और डेट इंस्ट्रूमेंट्स आर जहां पे हम हमारे पैसे लेंड कराते हैं कुछ फाइनेंशियल इंस्टीट्यूशन को, उसके बारे में भी हम लोग आएंगे. And there are few intangible assets like brand, trademark, copyright. So we'll mainly concentrate on gold, equity, real estate and debt in this seminar. So this is the diversification. एक एवरेज अगर एज हमारे जो भी अभी आज के सेमिनार में जो भी लोग हैं, तो मैक्सिमम लोग जो भी है उनका एवरेज एज इज 45, अराउंड 45. ऑल ऑफ देम आर, मोस्ट ऑफ देम आर पोस्ट ग्रेजुएट डॉक्टर्स, प्रैक्टिस में है, 45 इयर्स हो गए हैं. सो उनका डाइवर्सिफिकेशन ऑफ फंड्स और डाइवर्सिफिकेशन ऑफ पोर्टफोलियो कैसा रहना चाहिए, तो एक अप्रोक्सीमेशन है 10, 40, 40 और 10. 10% ऑफ योर पोर्टफोलियो शुड बी इन गोल्ड. रियल एस्टेट में 40%. रियल एस्टेट के बारे में मैं बोलूंगा नहीं क्योंकि रियल एस्टेट में हम लोग सब एक्सपर्ट हैं. हमारे पास में बहुत सारे रियल एस्टेट्स के प्लॉट, शेती, नंतर मग घरं घेऊन ठेवलेले आहे आम्ही, त्यामुळे त्याच्याबद्दल मी बोलणार नाही. बट इक्विटी डेफिनेटली वी हॅव अ एज ऑन आवर साइड, सो वी शुड at least have a 40% of our exposure to the equity, and debt product is 10%. Those who are senior citizen like 60, 65 year of age, they can change this ratio little bit. यहाँ पे 10, 40, 10, 40 कर सकते हैं. Like equity में 10% और debt product में 40%. या debt में इसलिए कि उसमें हमको हमारा कैपिटल का प्रोटेक्शन होता है, वहां पे रिटर्न ऑन इक्विटी हमको ज्यादा जरूरत नहीं रहती है. जितना पैसा है उतना अपने पास में रहना जरूरी है और हमारी एक्सपेंसेस निकलना चाहिए. इसलिए फॉर सीनियर सिटीजन इट विल बी 10, 40, 10, 40. सो दिस इज रिगार्डिंग डाइवर्सिफिकेशन. वो तो हमको सबको पता है कि डोंट पुट ऑल योर एग्स इन अ सिंगल बास्केट, एंड दैट इज द रूल ऑफ डाइवर्सिफिकेशन. सो व्हाट आर द नाउ कमिंग टू द इक्विटीज और ट्रेडेबल इक्विटी एंड डेट मार्केट. So there are generic product and package product. जैसा हम देखते हैं ना generic medicine and combined medicines. So उसी टाइप में generic product है शेयर मार्केट में होते हैं शेयर, जहाँ पे हम लोग कोई भी आजकल जो भी जीरोधा है या फिर जहाँ से भी ब्रोकर के ऐप से हम लोग शेयर्स खरीद सकते हैं. इजी टू अंडरस्टैंड. लिटिल डिफिकल्ट इज बॉन्ड एंड डिबेंचर्स. बॉन्ड क्या होता है कि गवर्नमेंट के कुछ बॉन्ड्स रहते हैं, एंड बॉन्ड एंड डिबेंचर्स आर द डेट प्रोडक्ट्स. डेट प्रोडक्ट की क्या क्या खासियत रहती है कि उसमें जो इन्वेस्टमेंट रहता है वो फिक्स रहता है, उसका टेन्योर जो रहता है वो फिक्स रहता है, इंटरेस्ट रहता है जो फिक्स रहता है. सो हमको कितना पैसा मिलेगा सब फिक्स रहता है. सो दीज आर द बॉन्ड एंड डिबेंचर, बॉन्ड बाय द गवर्नमेंट एंड डिबेंचर बाय प्राइवेट कंपनीज. सो दीज आर द जेनरिक प्रोडक्ट. बट अगर आप जेनरिक प्रोडक्ट में नहीं जाना चाहते हो तो पैकेज प्रोडक्ट में क्या क्या होता है, तो एक्सचेंज ट्रेडेड फंड, फॉर एग्जाम्पल निफ्टी बीज है, लिक्विड बीज है, गोल्ड बीज है. दिस आर द एक्सचेंज ट्रेडेड फंड. ये सॉर्ट ऑफ म्यूचुअल फंड ही है, बट इसका एक्सपेंस रेशियो बहुत कम रहता है और वो एक्सचेंज में हम उसको ट्रेड कर सकते हैं. हम जीरोधा पे या फिर कोई भी प्लेटफॉर्म पे उसको खरीद सकते हैं और बेच सकते हैं. एंड डायरेक्ट म्यूचुअल फंड. सो अगेन दिस टिपिकल डिफरेंस ऑफ डायरेक्ट एंड रेगुलर म्यूचुअल फंड के बारे में हमारे नेक्स्ट स्पीकर आपको बताएंगे, बट आई एम गिविंग द पासिंग रेफरेंस हियर. डायरेक्ट म्यूचुअल फंड का मतलब होता है कि जो म्यूचुअल फंड्स हम डायरेक्टली कंपनी से खरीदते हैं वो होगा पैकेज प्रोडक्ट. और डबल पैकेज में क्या होगा, कंपनी एजेंट को बताती है और एजेंट हमको बेचता है, उसको कहते हैं रेगुलर प्लान्स ऑफ म्यूचुअल फंड. एंड डबल पैकेज में और एक प्रोडक्ट आता है इग्नोरेंस पॉलिसी. उसके बारे में भी मैं आपको बताऊंगा इग्नोरेंस पॉलिसी क्या होती है. अभी एक दिस इज वेरी इंपॉर्टेंट एंड वेरी प्रोफाउंड कंसेप्ट ऑफ पावर ऑफ कंपाउंडिंग. हमको पता है, हम 7th स्टैंडर्ड में सीखे हैं कंपाउंडिंग क्या होता है, बट एक माइंड ब्लोइंग कंसेप्ट है. इट्स 8th वंडर. हमारे मेंटर कहते हैं कि इट इज 8th वंडर ऑफ द वर्ल्ड. कि पावर ऑफ कंपाउंडिंग में क्या क्या हो सकता है मैं आपको आगे के 2 स्लाइड में बताऊंगा. एक रूल ऑफ 72 है. इसको सिंपली क्या है कि इंटरेस्ट रेट है, अगर किसी का 6% है, फॉर एग्जाम्पल हमारा फिक्स जो डिपॉजिट है उसका इंटरेस्ट रेट फॉर एग्जाम्पल अगर 6% है, तो 72 डिवाइडेड बाय 6. सो जो भी इंस्ट्रूमेंट हमें 6% का इंटरेस्ट देता है उसमें 12 साल में 12 ईयर्स में हमारे पैसे डबल होंगे. If principal amount is 1 lakh, it will become 2 lakh with the interest rate of 6% after 12 years. अब डिफरेंट इंस्ट्रूमेंट मैं यहाँ पे आपको एग्जांपल दिखा रहा हूँ. बैंक एफडी में अप्रोक्सीमेटली 6% अपने को मिलता है, तो 12 ईयर्स फॉर डबलिंग. म्यूचुअल फंड का अप्रोक्सीमेट एवरेज इज 12%. इट विल टेक 6 ईयर फॉर मेकिंग योर 1 lakh to 2 lakh. एंड देयर आर, थोड़ा सा आपने अगर पढ़ाई किया, थोड़ा सा अगर तुमने टाइम स्पेंड किया, तो कुछ कोर्सेस वेल्थकॉन के भी है और बाहर में भी आप खुद आत्मनिर्भर होकर कर सकते हो. तो एडवांस इन्वेस्टर कोर्स है जिसमें अप्रोक्सीमेटली 18% ऑफ अगर हमको मिलता है रिटर्न, तो 4 साल में आपका डबल हो सकता है. एंड हमारा फ्लैगशिप प्रोग्राम है ट्रेड वेस्टिंग मेंटरशिप प्रोग्राम, विच अप्रोक्सीमेटली गिव्स यू 2% पर मंथ इजीली. नियर अबाउट 1700-1800 डॉक्टर ऑलरेडी ग्रेजुएट्स है, टीएमपी ग्रेजुएट्स, those who are earning 24% easily with profit with peace. एंड इट विल मेक योर इन्वेस्टमेंट डबल इन 3 years. अब ये एक बहुत अच्छा एक चार्ट आप ध्यान में रखो. बैंक एफडी का रेट ऑफ इंटरेस्ट 6%, 2 साल में डबल होगा, 12 साल में डबल होगा. 1 लाख का 2 लाख 12 साल में और 2 लाख का 4 लाख होगा 24 ईयर्स में. तो पावर ऑफ कंपाउंडिंग देखो, अगर म्यूचुअल फंड है तो 24 साल में तुम्हारा 1 लाख का एट द रेट ऑफ 12% इट विल बिकम एटलीस्ट 16 lakhs. और अगर हमारे पास में अगर 24 साल है, जितना जल्दी चालू करेंगे इन्वेस्टमेंट वो आपके लिए अच्छा है. तो 18% जो कि एडवांस इन्वेस्टर कोर्स जो है वहां पे 24 साल में, उतना ही 24 साल में योर इन्वेस्टमेंट कैन बिकम 64 lakh. एंड टीएमपी जो ट्रेड वेस्टिंग मेंटरशिप प्रोग्राम है, जिसमें ट्रेडिंग भी होता है, इन्वेस्टिंग भी होता है, तो 24 आवर में 2.56 crore. सो दिस इज अ पावर ऑफ कंपाउंडिंग एंड इट इज अवेलेबल टू ईच एंड एवरी वन ऑफ अस. रिगार्डिंग इन्फ्लेशन, इन्फ्लेशन एक इनविजिबल एनिमी है. इट इज अ टैक्सेशन विदाउट लेजिस्लेशन. अप्रोक्सीमेटली 6% एनुअल इन्फ्लेशन रहता है. देयर आर 2 types of inflation, price inflation and lifestyle inflation. I will tell you. इन्फ्लेशन क्या होता है? जो 2010 में शुगर 10 रुपीज पर केजी था, वो अभी अप्रोक्सीमेटली 40, 45, 46 रुपए किलो है 2020-2022 में. गोल्ड जो 10,000 तोला था, अभी 47 से 50 के बीच में है. लैंड, 1 acre ऑफ लैंड यू यूज्ड टू गेट एट 5 lakhs, नाउ इट इज ऑलमोस्ट 25-30 lakhs. निफ्टी जो कि 2010 में 5,000 था, वो अभी 2022 में 17-18 हजार तक पहुंच गया है. दिस इज ऑल इन्फ्लेशन. दिस इज नथिंग बट द इन्फ्लेशन. इन्फ्लेशन के कारण इतना हुआ है. प्राइस इन्फ्लेशन क्या होता है? जो 6% जो महंगाई जिसे हम कहते हैं इन्फ्लेशन को, दैट इज 6% अबाउट. एंड व्हाट इज लाइफस्टाइल? जैसे जैसे हम लोग वी आर गोइंग अहेड, हमारी लाइफस्टाइल चेंज हो रही है, हमारे लाइफस्टाइल के एक्सपेंसेस बढ़ते जा रहे हैं, एंड दैट इज लाइफस्टाइल इन्फ्लेशन. तो दिस आर द 2 types ऑफ इन्फ्लेशन. सो हमारा जो भी कुछ इन्वेस्टमेंट हम लोग करते हैं उसमें से रिटर्न कितना मिल रहा है, एक बहुत इंपॉर्टेंट कंसेप्ट रहता है और वो हमें कैलकुलेट करते आना चाहिए. देयर आर ओनली 3 कंसेप्ट्स और एकदम क्लियर कट है. CAGR, कंपाउंडेड एनुअल ग्रोथ रेट, वो पॉइंट टू पॉइंट होता है. मैं बताता हूं कैसा होता है. IRR, दिस इज इंटरनल रेट ऑफ रिटर्न, इग्नोरेंस पॉलिसीज में होता है. एंड थर्ड इज XIRR, दैट इज इंटरनल, दैट इज एक्सटेंडेड इंटरनल रेट ऑफ रिटर्न. CAGR में क्या होता है? जैसे गोल्ड, रियल एस्टेट, तूने प्रॉपर्टी लिया और बेचा, एक पॉइंट को लिया, एक पॉइंट को बेचा, पॉइंट टू पॉइंट. सो वो कैलकुलेट करने के लिए आपको CAGR का फॉर्मूला यूज करना होता है, कंपाउंडेड एनुअल ग्रोथ रेट, गोल्ड, रियल एस्टेट में. IRR क्या होता है? दो वी आर नॉट प्रमोटिंग एनी इग्नोरेंस पॉलिसीज. इग्नोरेंस पॉलिसीज क्या होती है? जिसमें इन्वेस्टमेंट एंड इंश्योरेंस, इसका कॉम्बिनेशन करा के हमको जो हम जैसे इग्नोरेंट लोगों को जो बेचा जाता है उसको हम इग्नोरेंस पॉलिसी कहते हैं. यहाँ पे ईयरली आप एक पर्टिकुलर अमाउंट पॉलिसी में डालते हो, तो इसका आपको IRR कितना मिलता है ये आप निकालेंगे और वो हम लोग आपको कैलकुलेट करके दिखाएंगे नेक्स्ट स्पीकर. तो आपको पता चलेगा कि हम लोग अभी तक क्या कर रहे थे. एंड XIRR में क्या होता है कि जहां पे म्यूचुअल फंड में हम लोग जो SIP लगाते हैं और SIP का जो एक महीने में कुछ कम पैसा डाला, दूसरे महीने में कुछ ज्यादा डाला, जो इरेगुलर हमारे इन्वेस्टमेंट रहते हैं उसको कैलकुलेट करने के लिए आपको XIRR निकालना होता है. बस ये 3 चीजें अपने को पता रहना चाहिए. एंड दिस इज वेरी इजी. गूगल पे या फिर हमारा एक्सेल शीट पे आप डेफिनेटली इजीली इसको कैलकुलेट कर सकते हो. नॉट अ बिग डील, नॉट अ बिग थिंग. व्हाट इज अ पोस्ट टैक्स पोस्ट इन्फ्लेशन रिटर्न? इसका रेफरेंस बाद में भी आएगा, लेकिन जस्ट मैं अभी एक पासिंग रेफरेंस दे रहा हूं. फॉर एग्जांपल बैंक का FD है 7%, हम लोग सभी लोग 30% टैक्स ब्रैकेट में आते हैं. सो हमारा पोस्ट टैक्स यानी टैक्स देने के बाद में रिटर्न इतना आता है 4.9%. अगर इन्फ्लेशन 6% को हम लोग गिनते हैं, सो आवर रिटर्न विल बी -1.1%. इट मीन्स इफ यू इन्वेस्ट 100 rupees इन बैंक FD, you will get 98.9 rupees after 1 year. ये तो 1 साल के बाद में हुआ, 2 साल के बाद में और कम होगा, 3 साल के बाद में और कम होगा. So your FD is not going to beat your post tax post inflation return. अब हमारे म्यूचुअल फंड्स में बहुत बार हमारे एजेंट्स लोग बोलते हैं कि सर हमारा क्या एक 1% तो कमीशन है सर. तो उसके लिए तुम इतना क्यों कर रहे हो? लेकिन लेट मी टेल यू, ये 1% नहीं है, ये 1% है तुम्हारे प्रॉफिट का 10% है। फॉर एग्जाम्पल 100 रुपए आपने म्यूचुअल फंड में डाला, तो आपका म्यूचुअल फंड अच्छा करे बुरा करे 1% एजेंट को मिलना है, बराबर है। सो कल जाके मेरे म्यूचुअल फंड ने अगर प्रॉफिट आया, वो 100 के 110 रुपीज हो गए, वो 110 रुपीज में से 1 रुपी वो एजेंट का रहता है। सो 10 रुपीज प्रॉफिट में से 1 रुपी, दैट इज 10%। और कल जाके आपका म्यूचुअल फंड अगर सिर्फ 5% रिटर्न देता है, 100 रुपए के 105 रुपए होते, तो वो 5 रुपए में से भी एजेंट को 1 रुपए मिलना है। सो 20% ऑफ योर प्रॉफिट, सो इट इज अ ह्यूज कॉस्ट। और वो क्या करेगा, सिर्फ तुम्हारे फॉर्म भर देगा और तुम्हारा एसआईपी चालू करेगा। उसके लिए इफ यू कैलकुलेट ओवर द पीरियड ऑफ 10 ईयर, 15 ईयर, 20 ईयर्स, वो कंपाउंडिंग होके इतना ज्यादा पैसा जाता है, विल बी सरप्राइज टू नो दैट यू आर गिविंग लॉट ऑफ मनी टू योर एजेंट्स। सो वी डोंट प्रैक्टिस any agent in between us and financial institutions. Regarding taxation, next topic is a taxation. Dear friends, taxes, death and taxes are certain. अगर हमने कुछ इनकम किया, हमारे पास में कुछ इनकम आया, तो हमारे पास में दो ही रास्ते, या तो फिर हम लोग उसको एसेट्स में इन्वेस्ट करेंगे जिसके ऊपर इनकम टैक्स देना पड़ेगा, और फॉर एग्जांपल हमने अगर इनकम टैक्स नहीं भरा और हम लोगों ने कैश जनरेट किया, जो कि वेल्थकॉन के पहले हम लोगों में से काफी लोगों का वो रहता था कि कैश करो, टैक्स भरने की जरूरत नहीं है। लेकिन अगर कैश जनरेट हम लोग करने के लिए बिल्कुल डिप्रैक्ट करते हैं, वी डोंट एडवाइस कैश जनरेशन। अगर कोई कैश जनरेशन करता है तो कैश का करेगा क्या, या तो रियल एस्टेट में लेगा, आज लेगा कुछ दिनों के बाद में बेचेगा तो लॉन्ग टर्म कैपिटल गेन, फिर से कैश जनरेट होंगी, वो कैश कुछ तुम्हारे पास में से जाने वाली नहीं। और कल जाके फिर से वो डिमोनेटाइजेशन का जैसा अगर आ गया तो हमारा पूरा का पूरा कैश, we can see what happened to that cash। और नहीं तो हम लोग क्या करेंगे कि उसको स्पेंड करना चाहेंगे, प्रोडक्ट ऑफ प्रेस्टीज लेंगे वो कैश से, और जो भी कैश से तुम खरीदोगे उसके ऊपर में आपको जीएसटी भरना है। और मैक्सिमम जो लग्जरियस आइटम है उनके ऊपर में जीएसटी है 28%। सो तुम कैश में स्पेंड करो या इन्वेस्ट करो, आपको टैक्सेस भरना है। सो डेथ एंड टैक्सेस आर सर्टन, यू कैनॉट सॉरी, आप उनमें से टैक्सेस को अपन नहीं कर सकते, टैक्स देना ही पड़ेगा सॉरी। सो टैक्सेशन, वी ऑल नो दैट टू टाइप्स ऑफ टैक्सेस, डायरेक्ट टैक्सेस एंड इनडायरेक्ट टैक्सेस। इनकम टैक्स कम्स अंडर डायरेक्ट टैक्सेस, उसमें सिक्योरिटी ट्रांजेक्शन टैक्स जो हम लोग शेयर पे देते हैं, या कॉर्पोरेट टैक्सेस, दीज आर द टाइप्स ऑफ डायरेक्ट टैक्सेस। जीएसटी हो गया, एक्साइज हो गया, कस्टम हो गया, दीज आर द इनडायरेक्ट टैक्सेस। हमारा जो इनकम टैक्स रिटर्न का अगर आपने देखा होगा, अभी तो सबका चल रहा होगा, ऑडिट चल रहा होगा, या फिर सब लोगों ने इनकम टैक्स रिटर्न भरा होगा अपना, तो उसमें हेडिंग ऑफ इनकम 5 ही हेडिंग रहते हैं, सैलरी, हाउस इनकम। हम लोग हमारे इन्वेस्टमेंट में से नंबर 3, 4 और 5, इस तीनों, ये 3 चीजों में हम लोग हमारा इनकम बढ़ा सकते हैं बाय डूइंग इन्वेस्टमेंट। बिकॉज एफएनओ अगर करते हैं तो इट्स अ बिजनेस इनकम, फ्यूचर एंड ऑप्शंस। कैपिटल गेन, जो भी शेयर हमने खरीदा और बेचा उसके ऊपर में जो कैपिटल गेन हुआ वो भी हम लोग कर सकते हैं। और डिविडेंड से, इंटरेस्ट से हम लोगों को, ये 3 चीजों से हम हमारे इन्वेस्टमेंट से हमारा पैसिव इनकम जनरेट कर सकते हैं। वही कैश जनरेशन हम लोग अवॉइड और हम लोग डिप्रैक्ट करते हैं। वी डोंट एडवाइज कैश जनरेशन बाय एनीबॉडी एट द वेल्थकॉन फोरम, बिकॉज एज आई ऑलरेडी एक्सप्लेन टू यू, कैश जनरेशन करके भी हम लोग उसको खर्चा करने वाले हैं, उसके ऊपर जीएसटी पे करने वाले हैं। उससे अच्छा है कि आप इनकम टैक्स भरो, पोस्ट टैक्स इनकम से असेट जनरेट करो और असेट से पैसिव इनकम जनरेट करो। एट वेल्थकॉन वी रिकमेंड टैक्स सेविंग के लिए 1 and 2 प्रोडक्ट, 2 लाख का इन्वेस्टमेंट हम लोग कर सकते हैं टैक्स सेविंग के लिए। उसमें ELSS, उसमें से भी ग्रोथ ELSS फंड, दैट इज इक्विटी लिंक सेविंग स्कीम्स, जिसका लॉकिंग रहता है 3 साल का, एंड TPF। और न्यू पेंशन स्कीम में 50,000, 1.5 लाख ऊपर ATC में और 80 CCD में 50,000, तो 2 लाख every year you can save, plus you can save the mediclaim for yourself 25,000 and for your parents more than 60 years 50,000 तक हम लोग उनका मेडिक्लेम भर सकते हैं। ये होम लोन के बारे में मैं आगे आऊंगा। होम लोन का जो इंटरेस्ट है उसमें भी हम लोग थोड़ा सा सेविंग कर सकते हैं। सो दीज आर द ओनली टैक्स सेविंग प्रोडक्ट, इसके ऊपर कोई भी टैक्स सेविंग प्रोडक्ट नहीं है। ELSS, NPS फॉर 2 lakhs, मेडिक्लेम तुम्हारा और तुम्हारे बच्चों का, स्पाउस का और तुम्हारे पेरेंट्स का, दैट्स इट। दीज आर द टैक्स सेविंग प्रोडक्ट, उसके ऊपर में सोचने की जरूरत नहीं है। नाउ कमिंग टू द rest of the part of our tablet ECD, we have seen earning, we have seen spending, we have seen the investments and taxation. Now come to the I, that is insurance. इंश्योरेंस को बस 2 स्लाइड में हम लोग खत्म करेंगे, बिकॉज इंश्योरेंस इज एन एक्सपेंस. डोंट वेस्ट योर टाइम टू स्टडी द एक्सपेंसेस. एक्सपेंस को स्टडी करने की जरूरत नहीं है. एंड नेवर एवर मिक्स योर इंश्योरेंस विद इन्वेस्टमेंट. जो भी हमारी एंडोमेंट पॉलिसीज है, जो भी हमारा मनी बैक पॉलिसीज है, एक तो ये प्रोडक्टिव ऐसा बना है कि जिसमें इन्वेस्टमेंट के साथ में आपको इंश्योरेंस दे रहे हैं, तो इसमें धड़ ये भी नहीं हो रहा है और धड़ वो भी नहीं हो रहा है. उसके बारे में भी हम आपको नेक्स्ट हमारे स्पीकर आपको बताएंगे कि हाउ इट इज नॉट गोइंग टू हेल्प यू इन द लॉन्ग टर्म, जहां पे आपको लाइफ कवर भी नहीं मिल रहा है और आपका रिटर्न भी नहीं मिल रहा है. हमारे लिए लाइफ इंश्योरेंस इज ओनली टर्म लाइफ इंश्योरेंस. बस ये ही एक ही चीज ध्यान में रखना है कि टर्म लाइफ इंश्योरेंस जनरल इंश्योरेंस में है, बिकॉज इंश्योरेंस आर 2 टाइप्स, लाइफ इंश्योरेंस एंड जनरल इंश्योरेंस. जनरल इंश्योरेंस में जैसे हेल्थ इंश्योरेंस है, कार इंश्योरेंस है, प्रोफेशनल इंडेमिनिटी है, ट्रैवल इंश्योरेंस है, दैट इज अ product we can discuss, but for the life we only advocate term life insurance. Term life insurance ही लेना है. Never ever ignorance policy. What are the ignorance policy? Ignorance policy are the policies which are sold by the smart people and the agent to the ignorant people like us to generate income for them, not for us. That is the income for them, not for us. Only way you can earn money from your ignorance policy is by selling them. Just close that policy and sell that policy. Term insurance only, never ever ignorance policy, जहां पे return on investment is not more than 4 to 6% and which is not beating the inflation. अभी तक मैंने ऐसा कोई आदमी नहीं देखा कि जो इंश्योरेंस पॉलिसीज लेके, जो इंडोमेंट पॉलिसीज लेके, जिसने अपना कुछ बड़ा उसने क्रिएट किया होगा. हाँ, इंश्योरेंस एजेंट लोगों ने बड़े बड़े उनके क्रिएट किए हैं, बट नॉट फॉर द पीपल हु आर टेकिंग दैट पॉलिसीज. सिंपल फंडा, बॉटम लाइन इज टर्म लाइफ इंश्योरेंस सम अश्योर्ड इज 20 टाइम्स ऑफ योर एनुअल इनकम. जैसे फॉर एग्जांपल हमारा एनुअल इनकम जो भी है उसका 20 टाइम्स आपको उतना अमाउंट का टर्म इंश्योरेंस लेना है. अब टर्म इंश्योरेंस 20 टाइम्स क्यों? एक 20 कहां से आया? फॉर एग्जाम्पल इफ यू चेक आउट फ्रॉम द प्लैनेट, कल जाके तुम्हारा कुछ हुआ, कम ज्यादा हुआ, तो ये जो 20 टाइम्स वाला जो अमाउंट हमारे फैमिली को मिलने वाला है, उसको फिक्स डिपॉजिट में भी रखा तो भी उन लोगों का उसके ऊपर में जो भी ब्याज मिलेगा उसके ऊपर में उनकी लाइफस्टाइल चलती रहेगी. सो एटलीस्ट 15 टाइम्स, कम से कम 15 टाइम्स ऑफ योर एनुअल इनकम, और आइडियल इज 20 टाइम्स ऑफ एनुअल इनकम. तुम्हारा एनुअल इनकम अगर 20 लाख है, 30 लाख है, मल्टीप्लाइड बाय 20 टाइम्स, तो अब 4-5-6 करोड़ की पॉलिसी आपके पास में रहना चाहिए. टर्म इंश्योरेंस जो कि ज्यादा महंगी नहीं रहती है. प्रीमियम पेमेंट क्या करना है? एनुअली, ईयरली. वो बोलते हैं कि नहीं सर तुम 10 साल का प्रीमियम भर दो, बाद में भूल जाओ, वो नहीं करना. प्रत्येक वर्षाचा प्रीमियम भरा. कोणाला माहिती की तुम्ही कधीपर्यंत राहू शकता, कधीपर्यंत नाही. व्हाई टू पे? एक बार तुमने कंपनी के 10 साल के पैसे भर दिए, कंपनी मोकली हो गई, उनको कुछ करना नहीं, ध्यान नहीं. There are top companies, 3-4 companies I have mentioned here, LIC, HDFC, SBI, anybody, that all of them are good. One more thing, please add MWPA, Married Women's Property Act. ये क्या है मैं बताता हूँ. ये क्या रहता है कि हम लोग हमारे हॉस्पिटल के लिए, क्लिनिक के लिए लोन लेते हैं, और if something happened to us, अगर MWPA हमारे इंश्योरेंस पॉलिसी में अगर हमने डाल के रखा है, तो वो जो पैसा हमारे बच्चों को, हमारे स्पाउस को मिलेगा, उसके ऊपर में बैंक या कोई भी फाइनेंशियल इंस्टीट्यूशन अपना हक जता नहीं सकते हैं अगर हमने MWPA लिया है तो. लेकिन ये हमें पॉलिसी लेते समय ही उसको बताना है कि हमें MWPA होना. वन मोर थिंग, इट इज अवेलेबल फॉर मेल्स ओनली. जैसा मैं लेता हूं तो मेरे इसमें MWPA रहेगा, तो मेरे वाइफ को, दे वोंट हैव, नोबडी कैन क्लेम दैट मनी एक्सेप्ट माय वाइफ एंड माय किड्स. सो MWPA इज वेरी इंपॉर्टेंट फॉर टर्म इंश्योरेंस. एंड ये बाकी के जो है एंडोमेंट प्लान, आनंद, बचत, सेवा, लाभ, समृद्धि, ये सबको बिल्कुल नेवर नेवर उसको लेना ही नहीं है, उसको सुनना ही नहीं है. ओनली थिंग इज टर्म लाइफ इंश्योरेंस. एंड कमिंग टू द लास्ट पोर्शन ऑफ माय टॉक, दैट इज लोन्स. आपने देखा होगा कि 150-200 साल पहले स्लेव्स हुआ करते थे. अभी भी आज भी हम लोग स्लेवरी में जीना जीते हैं. जो स्लेव है वो हमारे लोन में, हमारे बैंक के स्लेव है, हमारे फाइनेंशियल इंस्टीट्यूशन के स्लेव्स है, हमारे क्रेडिट कार्ड के स्लेव्स है. अब लोन तो कोई भी लेना है तो दैट इज नॉट अ गुड थिंग. लोन लेने की जरूरत ही पड़ना नहीं चाहिए. बट अगर लेना ही है तो देयर इज अ क्लियर कट डिमार्केशन बिटवीन गुड लोन एंड बैड लोन. अब वो ऐसा है कि गुड टेररिज्म, बैड टेररिज्म जैसा है. बट यस, देयर आर फ्यू लोन्स which we can take, which increases your productivity. They can create assets, they can save your taxes. For example, your home loan, your business loan, at the most education loan. These three things, these are the good loans. Business loan क्योंकि productivity increase करता है, asset create करता है. Home loan, they can save the taxes up to 2 lakhs on interest. And education loan because you are going for education, and these are the good loans. What are the bad loans? Those who are not productive, don't create assets, don't save taxes. For example, consumer loan, car loan, personal loan, gadget loan, credit card loan. These are all bad loans. Clearly, big no for the bad loans. आपने देखा होगा लोन में जब हम बैंक के पास में, हम लोग में से काफी लोग जाते हैं, गए होंगे. जाने के बाद में हमारी डिग्री, डीएम, एमसीएच, एमडी, कुछ एमएस कुछ नहीं देखते हो. सबसे पहले तुम्हारा इनकम टैक्स रिटर्न दिखाओ. तो जितना जल्दी हो सकता है अभी हम या हमारे बच्चों का इनकम टैक्स रिटर्न, नील के रिटर्न फाइल करना चालू कर दो. बट इट विल क्रिएट असेट्स. और हमारा जो क्रेडिट वर्दीनेस है, वो हमारा एलिजिबिलिटी जो है वो इनकम टैक्स रिटर्न से ही बनता है, बाकी डिग्री से, एक्सपीरियंस से नहीं बनता है. सिबिल स्कोर, मैं सिबिल स्कोर पे भी आऊंगा नेक्स्ट स्लाइड में. और तुम्हारे असेट्स कितने हैं, तुम्हारे इनकम कैसा है, उसी के ऊपर में तुम्हारी क्रेडिट वर्दीनेस रहता है, तुम्हारी एलिजिबिलिटी फॉर द लोन्स रहता है. सिबिल स्कोर क्या है? दिस इज अ क्रेडिट इंफॉर्मेशन ब्यूरो ऑफ इंडिया लिमिटेड. 300 से 900 के बीच में स्कोर रहता है. अगर आपने पूरे के पूरे लोन नील कर दिए तो भी तुम्हारा सिबिल स्कोर अच्छा नहीं होगा. दिस रिपोर्ट इज अ डिटेल इंफॉर्मेशन ऑफ लोन, रिपेमेंट, ईएमआई, डिफॉल्ट, एक्सेट्रा एक्सेट्रा. कुछ ना कुछ मिनिमम क्रेडिट रखना चाहिए. अगर जीरो क्रेडिट तुम्हारे ऊपर रहेगा तो तुम्हारा सिबिल स्कोर अच्छा नहीं रहेगा. तो कुछ ना कुछ क्रेडिट तुम्हारे ऊपर पास में रहा तो तुम्हारा सिबिल स्कोर अच्छा रहता है. सो यू हैव टू प्लान. अगर हमको कुछ लोन लेना है तो तुम्हारा सिबिल स्कोर अच्छा कैसे करना, उसके कुछ ये है. डोंट डिफॉल्ट. जो भी तुमने कर्जा लिया है, तुमने टाइम टू टाइम उसका ईएमआई भर दिया, ईएमआई, तो वहां पे योर स्कोर विल इंक्रीज. तुम अगर गारंटर हो तो तुम्हारा थोड़ा सा स्कोर कम होता है. सो टू टेक एनी लोन, or nowadays this CIBIL score is available on online. Lot of agencies are there who can generate your CIBIL score. So at the end of my talk, अगर ये 5 चीजें भी अगर हमें पता चली ये 15, 20, 25 मिनट के टॉक में, तो that is sufficient enough. जितना जल्दी हो सके उतना जल्दी हमारा पैसिव इनकम का सोर्स क्रिएट करो. और उसके लिए क्या कर सकते हैं? इन्वेस्टमेंट. जहां पे इन्वेस्टमेंट करके आप यू कैन क्रिएट, एंड आई कैन टेल यू विद रिस्पॉन्सिबिलिटी, जिस दिन आपका पैसिव इनकम, इन्वेस्टमेंट से आने वाला इनकम आपके मंथली एक्सपेंसेस से ज्यादा हो गया, उस दिन समझ लो आपका फाइनेंशियल फ्रीडम आपको मिल गया. फिर यू कैन प्रैक्टिस, यू कैन स्टडी, you can enjoy your life, you can enjoy your hobbies, and one of the biggest benefactor is myself. I am creating and I am doing whatever I like because of this financial freedom given by WealthCon to me. Spending के बारे में, avoid product of prestige, pay yourself first. It's very good concept. क्या है कि 100 रुपए हमने कमाते तो हमारा रहता है कि पहले खर्चा करेंगे बाद में सेव करेंगे. नहीं, 100 रुपए कमाए तो 20 रुपए, 25 रुपए, 30 रुपए, 40 रुपए खुद के लिए रखो, खुद के लिए सेव करो. पे योरसेल्फ फर्स्ट. और जो बाकी बचता है 60-70 रुपए, 60 रुपए, 50 रुपए, उसको खर्चा करो, उसको स्पेंड करो. सो पे योरसेल्फ फर्स्ट. इन्वेस्टमेंट, डू इट योरसेल्फ. थोड़ा सा पढ़ाई करो, थोड़ा कुछ प्लेटफॉर्म्स है, कुछ ग्रुप्स है, आप ज्वाइन हो जाओ. Most of the programs, most of the things on WealthCon website and WealthCon Telegram group are free. You can join them. Start early. पावर ऑफ कंपाउंडिंग बताया मैंने, जितना जल्दी स्टार्ट करोगे आप या आपके बच्चे, उतना आपका पावर ऑफ कंपाउंडिंग होगा. हमारे साथ में कुछ लोग हैं जो 12वीं से 12th के बाद में ही उन लोगों ने स्टार्ट कर दिया था. सो दे हैव गॉट अ ह्यूज पोर्टफोलियो. इवन इंटर्नशिप के 1200 रुपए मिलते थे, उसमें से 300 रुपए बचा के 900 रुपए खर्चा करने वाले लोग थे. 300 रुपए का तब से म्यूचुअल फंड लेके रखने वाले लोग हैं. ऐसे हैं हमारे साथ में कुछ लोग. टैक्स इज गुड एट अर्ली स्टेज. नेवर बाय इन्वेस्टमेंट पॉलिसी. इन्वेस्टमेंट और इंश्योरेंस को साथ में मत जोड़ो एंड अवॉइड द कंज्यूमर लोन्स. सो थैंक यू, थैंक्स अ लॉट. खामगांव के सभी जो भी हमारे IMA के मेंबर्स हैं, स्पेशली मेंढे मैडम एंड उनका पूरा टीम, फॉर गिविंग मी दिस अपॉर्चुनिटी, एंड लेट्स बिगिन आवर जर्नी ऑफ फाइनेंशियल फ्रीडम. थैंक यू, थैंक्स अ लॉट.
Thank you, Dr. Parag. It is never too late. So for us, and no goal is too high. If we climb with care and confidence, definitely we will improve in our financial matters after your lecture. Thank you.
Thank you.
Thank you, Dr. Parag. Thank you, Dr. Surekha ma'am, for this wonderful, wonderful session, sir. So for our next session, we have with us our very humble Dr. Ashish Jhunjhunwala sir, consultant radiologist practicing in KHAMGAON. He is with us since the inception of WealthCon in 2017. Sir's interest in finance is out of his pursuits for excellence in all fields of life. So I would like to invite Dr. Ashish to take this very interesting topic and my personal favorite, MPTDS. Now, what is MPTDS? Over to you, Ashish sir.
Thank you, Shweta madam, for such a wonderful introduction. Now, this MPTDS, as Dr. Parag sir has told us about the financial literacy. Now, investment part I will be taking. This MPTDS criteria is copyrighted by Dr. Ram sir. He has devised it after thorough research, and I'm very glad that I'm part of WealthCon since inception. So, from darkness to light and from ignorance to knowledge. Now, what is this MPTDS criteria? It is devised by Dr. Ramnath Gute sir, and he has thoroughly researched about this criteria and made it so simple that keep it simple, that a 7th grade student can select good company stocks. I will tell you how. So, what is why this MPTDS criteria is needed? So, first is do it yourself. Everyone knows about investment in stocks, but which stock to buy? That is a $1 million question. So to screen good companies for direct investment in stocks, mostly the blue chip companies, and this is a important journey to become Atmanirbhar in our finances. So what is MPTDS now? M stands for market capitalization. So we are going to buy share of any company which has more market capitalization of more than 10,000 crores. So what is market capitalization? It is like a size of the company, how big the company is, like number of shares available by that company. It decides the market capitalization. And in this criteria, MPTDS criteria, Ram sir has said that we should invest only in a company which is more than 10,000 crores. So that chiller companies like less than 10,000 crore companies are removed from our list. Then P stands for price of the share. The price should always be in uptrend. I will show you in live demo also how we can see this price. Then T is tax paid by the company. Again tax, when the company earns more, it pays more to the government in the way of tax. So the taxation should always be in uptrend or increasing in or ascending order over last 10 years. And dividend, if the company is earning more, paying more taxes, it gives dividend to the shareholders. it should be again in the increasing order. And the sales, of course, the sales, if the sales is high, the company is in profit, then this is how we are going to select the stocks by applying the MPTDS criteria. M for market capitalization, which should be more than 10,000 crores, price that should be in uptrend always, then tax and dividend and sales. These are again should be in increasing order or ascending order over last 10 years. Now, how we are going to do this? We are going to, I am going to give you live demo from a website screener.in and by using Microsoft Excel. Like few examples I'm going to show you. This is market capitalization. We have sorted it by screener. And in that we have put a criteria of company of market capitalization more than 10,000 crores. So here we can see out of 2,000 or 3,000 companies, there are 200 to 300 companies which has a market cap of more than 10,000 crores. Then here is the chart, price of the share. It is, you can see it's increasing day by day, year on year. So this is the second criteria, that the price should be in uptrend. Here we can see the two examples, Reliance and HDFC Bank. Some dip will be there. This is like Corona crisis where the stock has gone down, but otherwise you can see the it is in ascending order, the price of the Reliance share or the price of the HDFC Bank. These are again the HUL and TCS. Here also we can see the uptrend in the price. Then the tax should be increasing year on year. Where we have to find, I am going to show you in the live example. We can see it in the cash flow statement. And direct tax is paid by the company. We can visually, we can see it, it is negative sign over here because that is a expense to the company, which is paid to the government. But we can see the taxes are paid by the company to the government is increasing year on year. Similarly, the dividends paid to the shareholder, this is also increasing year on year. And then the sales, here also the sales are increasing year on year. We can see this in our profit and loss statement of the company. I will show you in the live demo also. Now, this MPTDS criteria, this is basically for passive investment. Apply any this MPTDS criteria and filter out bad stocks. This is actually exclusion criteria. It's not like that those companies which are not fulfilling the MPTDS criteria are bad, but we have to apply some different criteria. And MPTDS criteria, this is for basic investment, basic knowledge for for the people who don't know anything about the share market or who don't know which company to select or not. And there are 3D. What we can do is diversification. We can select 20 to 30 best performing shares across various sectors. Then we can do the SIP and deep buying, systematic investment plan, SIP, in which we regularly buy the shares. Say, for example, 5th of every month, we can put some 10,000 amount where we are going to buy the shares of 20 to 30 companies. Then deep buying, whenever there is a dip in the share price, we can accumulate more at that time so that our average out will be good. Then the duration, we have to keep minimum for 7 years. Like this is a gestation period. In any share investment or any property, if we go, there is a gestation period. So it's not like that if we have purchased a share and after say 1 year or 2 years, we are saying that this is in loss. No, we have to wait minimum for 7 years. So, and we can review the portfolio once a year, or if any red flag signs are there with any company, which we get to know from any information. So this was my short talk, but right now I am going to tell you, show you the live demo, how I am going to select the companies.
Presentation live demo.
We will go to screener.in. So here I am putting market capitalization.
Ashish, your screen is not visible.
Your screen is not visible.
पुराना वाला
Okay.
ये करके हाँ, now it is visible.
Okay. So market capitalization 10,000 crores. And now see, these companies we have got, and now this is in descending order. So first is the Reliance Industries, which is a like huge market cap. I'm going to show you the example of Infosys. Now, after this query, market capitalization, we can see the only there are 337 results. Out of like 3,000 companies, we have got 300 companies, which are more than 10,000 crores. Now, if we see the price chart over here, this is by default by 1 year. We'll put it to max. Now here we can see the graph. The price of the share is increasing year on year. Some dip will be there, but otherwise overall the price is increasing. Now when we go in cash flow, here the direct taxes, this column is there. I will select this. Visually also you can see the taxes paid by the company is increasing. So here now I am going to plot the chart. Here you can see the taxes paid by the company is increasing year on year. Now the dividends paid. So here again we can plot a chart and we can see this dividends paid is also increasing year on year. And when we go in a profit and loss, here the first column is of sales. Here also you can see in the March 2010, it was 22,000, then 27, 33, 40, 50. So increasing, we can visually also see it, and we can see it in Excel also. And on chart, we can see this sales. This is clearly uptrend. So very easy criteria devised by Dr. Ram sir to filter out good companies. And now as you can see that this company is fulfilling all our criteria of MPTDS. Market capitalization more than 10,000 crore is increasing day by day. Taxes paid by the company to the government is increasing, and then dividend paid by the company to the shareholder, it is also increasing, and the sales of the company, that is also increasing. So this is how we can filter out good companies. Now, as everyone can see here, like Infosys satisfies all our criteria of MPTDS, and now we can go and buy the share of Infosys Limited. It's very, very easy criteria, MPTDS criteria, developed by Dr. Ram sir after thorough research. So even the 7th grade student can apply these 5 criteria and select the stock of a good company. So
Yeah, you can stop your screen share. Okay, great.
yeah. So any doubts will be answered by Dr. Ram sir at the end of our session. But still, you can write it in the chat box. Any questions? If anything, any step, if somebody has any doubt.
We don't have any doubts, sir.
Great.
Thank you, Dr. Ashish Jhunjhunwala, sir. This is a new pehchan of Dr. Ashish Jhunjhunwala. We never thought of radiologists. So many things are behind this big radiologists in our city. I'm sure all the doctors in KHAMGAON will be very soon will be becoming wealthy because of the WealthCon. Thank you very much.
Thank you, Madam and KHAMGAON for giving me the opportunity to give a talk on MPTD's criteria.
Thank you, Dr. Ashish, for this crisp and crystal clear demonstration. So we'll proceed to our next speaker, that is with Dr. Gaurav Ladha, pediatrician and allergy and asthma specialist and a financial enthusiast practicing at KHAMGAON. He will be taking the topic of direct and regular mutual funds and ignorance policy. Having built an impressive portfolio in a span of just few years, Dr. Gaurav is here to share with us his knowledge and ideologies. Over to you, Dr. Gaurav.
Thank you, Madam, for such kind words. I would first like to thank you, Dr. Ram sir, for giving this opportunity, and IMA KHAMGAON to give this opportunity to me. Yeah. Is my presentation visible?
Yes.
Thank you. Yeah, so I will be talking on ignorance policy. By the way, Dr. Tapre sir has given the gist of that. I will be talking on it and direct versus regular mutual funds. So before knowing what is ignorance policy, we should know what is post-tax, post-inflation return. Basically, it is post-tax return minus inflation. Example, if the bank FD gives you a return of 7%, then considering most of the doctors being in 30% tax bracket, our post-tax return from that FD will be 4.9%. On an average, for a middle class person, the inflation is 6%. So post-tax, post-inflation return will be 4.9 minus 6, that is minus 1.1%. So basically, you are getting negative return on your bank FD. So any investment which gives negative PTPIR, post-tax, post-inflation return, is ignorance. All investment products of insurance policy are ignorance policies as they don't beat inflation. So types of life insurance are term plan, which is pure risk cover. It's an expense. It doesn't give any money back. Then ULIP, which is insurance plus investment in equity. Then endowment plan, which is insurance plus saving, like Jeevan Anand, Jeevan Saral, and few money back policies, like which you have to pay for 5 years, and after a gap of 5-7 years, you get money back every yearly. That is money back policy. Whole life insurance, pension plan, and child plan. So these are the types of life insurance available in the market. And except term plan, all other plans are ignorance policy. We should never ever mix insurance and investment. The only life insurance we should take is pure and pure risk cover term plan. I'll tell you the reason ahead. So why do we say no to ULIP and endowment policies? First thing is, it is mostly promoted by agents, relatives, and friends, because they are looking for their income. It costs us heavy commission. Our money is being taken by these agents. If we research it, the return we are getting is much less than what the agents are getting it in commission. So it's an insurance plus investment product. Insurance cover is insufficient. Like Tapre sir said, we should have 20% of insurance cover, 20 times of our annual income. But in these policies, we are hardly getting 5, 10, 15 lakh of insurance cover, which is less than many of the doctors' annual income. And it doesn't beat inflation. So that's why we consider all this plan as ignorance policies. We have a comparison chart of endowment policy, Jeevan Anand, ULIP, LI, ICI, Pru Life Group Growth Fund, and term plan plus equity mutual fund. If you can see, the sum assured insurance in endowment plan is 4 lakh rupees. In ULIP, it is 5 lakh rupees. If someday we check out from planet, do you think it is sufficient for our next generation to have 4 or 5 lakh rupees in hand? Definitely not. And if we take pure term insurance, 50 lakh is the example here, but most of us take more than this. If we see the total premium paid 50,000 per annum in this endowment in ULIP plan, and if we say 7,000 is we are paying it from term plan in and the rest amount in mutual funds, the direct mutual funds, then the CAGR we are getting in endowment plan is approximately 6.6%. In ULIP, we are getting it 10.7%, and mutual funds, we are getting it 15.9%. This is example of one of the time period. In ULIP, though this is beating the inflation, but you can see the difference between the equity mutual funds and ULIP plan. It is approximately 5% difference, which is huge money. And the insurance cover is 10 times less in ULIPs as compared to the pure term plan. And again, the ULIP plan is related to market. So market risks are always there. So why to invest in, if you want to invest in market, then why should we go for 10% return and not for 16% return? So we should have only term life insurance, which should be sum assured 20 times of annual income. 20 times means if suppose we our income, annual income is 1 lakh rupees, we should have a term plan of 20 lakh rupees. So if our next generation puts that 20 lakh in FD, then also at 5% of FD rate, he will have 1 lakh rupee every year, and to maintain the same lifestyle, that money will be sufficient to them. The premium payment should be annually till term. The top companies are LIC, HDFC, SBI, ICICI, or you may search other companies also. And the Married Women Properties Act. Married Women Properties Act ensures that the our bank loans and house loans, that money, the insurance money doesn't goes to them. So what to do if you are holding ignorance policy? Many people just hold on ignorance policy due to lack of courage to accept the defeat and temporary losses. उनको हजम नहीं होता कि यार अपन कैसे क्या नुकसान में पैसा निकाल ले. But believe me, नुकसान में पैसा निकाल के अच्छी जगह इन्वेस्टमेंट करेंगे तो उससे ज्यादा पैसा बनेगा. तो सबसे पहले वी शुड एक्सेप्ट कि हमने इग्नोरेंस पॉलिसी ले ली, गलती हो गई, वो गलती को सुधारो और सही डायरेक्शन में जाओ, ना कि वो गलती को कंटिन्यू करो. So you should stop ignorance policy at once, get the surrender value, and invest that money lump sum in direct mutual funds or Nifty Bs. The second part of my talk is direct versus regular mutual funds. Regular mutual funds are those which are brought through mutual fund distributors or agents. And direct mutual funds are those we directly take it. There is no intermediary involved in us, between us and the and AMCs. So the regular mutual funds, mutual fund distributors provide advice, submitting in KYC documents to register and transfer agents. They help in investing process, ongoing services. Basically, they help in paperwork. And for these services, these distributors receive heavy commission. Paperwork is not so difficult that we give them such a heavy commission. So direct plan is better. There is no intermediary involved, no distributor commission. The expense ratio is less. And what are the platforms where we can invest in direct plan is mutual fund utility, respected AMC websites, Zero the Coin, or any other platforms. MFU utility is the site where all the AMCs provide their direct and direct funds at one site. So what is the similarity between direct and regular plan? Both are fund manager and both have same portfolio, same fund manager, same portfolio. Only difference is expense ratio, and this expense ratio is actually the commission which goes to the agent. So direct plan, the expense ratio is lower, खर्चा कम तो पैसा ज्यादा बचेगा. Regular plan, expense ratio is higher, so खर्चा ज्यादा. Net asset value is higher in direct plan and it is low in regular plan. And all the logistics are in direct plan are to be done by us, which is not very difficult. Every one of us know how to handle computer and mobile laptops nowadays. And in regular plan, what agents do is just they do the paperwork for us. Now we can see these are the examples of expense ratio. See, you can see there is a comparison of Axis Blue Chip regular direct funds, Canara Robeco Blue Chip equity direct and regular funds, and Mire Asset large cap direct and regular funds. DIR is for direct and REG for regular. We can see regular plan in Axis 1.7 expense ratio and 0.4 in direct plan, approximately 1.1% difference. In Canara Robeco, direct is 0.34 and regular is 1.93. That is approximately 1.4% difference. And in Mire Asset large cap, direct plan expense ratio is 0.5 and regular plan expense ratio is 1.6. That is difference of 1.1. So approximately 1% expense ratio is the minimum difference between this direct and regular mutual funds. So this 1% of commission is actually 10% of your profit share. See, in this example, we can see Axis Blue Chip Fund, regular growth plan and direct growth plan. Here, in both these policies, a 50,000 SIP is being done from 2013 to 2021. That is 8 years of SIP. So investment value for both the parts is 48,50,000. Here also 48,50,000. The profit loss in regular growth plan is 108%, and in direct fund it is 120%, which is approximately 10%. Expense ratio was 1% was the difference, and the profit difference is approximately 10%. And annualized return is difference is approximately 1%. So this proves that if the agent is taking 1 rupee, that 1 rupee is from our profit money. It is not the money from the investment part. So 8% commission is thus approximately 10% of your profit. You have to remember this, because if we can see here the graph of long time investments in mutual fund. पहले 15-20 साल कुछ नहीं है, थोड़ा सा ऐसा लगता है कि चलो 40,000 डिफरेंस है, कोई सोचता होगा कि 40,000 के लिए इतना कौन माथा फोड़ी करेगा. लेकिन as the time duration increases, this gap increases a lot, 8 lakh, 24 lakhs also. So it is always better to give 1 or 2 hours to study these mutual funds. It is very easy by the KRSA criteria devised by Ram sir, which will be explained in the next presentation. 1-2 घंटे से अगर तुम्हारे 10-15 लाख रुपए बचते हैं तो nothing like that. So what to do if you are holding regular mutual funds? Stop SIP of regular mutual fund. Select direct mutual fund by KRSA criteria. Invest all the money lump sum from regular to direct mutual fund. These are simple steps. So take home messages: don't read, don't listen, or don't buy ignorance policy. Don't waste your time on that. Invest only in direct plan of mutual funds, and how to select mutual fund is will be explained in next presentation by Dr. Deepak. So thank you for the opportunity. Thank you so much.
Thank you, Gaurav Linda, for the nice presentation. Thank you.
Thank you. So there's a very famous saying that goes, a good teacher explains, a superior teacher demonstrates, and a great teacher inspires. So a source of inspiration to many, we are fortunate to have amongst us our next speaker, Dr. Deepak Bhatt, anesthesiologist from Akola. He will be covering the topic of KHAMGAON criteria, which is how to select mutual funds with demonstration. Over to you, sir.
Thank you very much. Is my screen visible and audio?
Yes.
Yeah. Thank you. I am Dr. Deepak Bhatt, a freelance anesthesiologist from Akola. I am a proud WealthConian, and I am thankful to WealthCon and IMA KHAMGAON who gave me this opportunity to speak in front of this august audience. What are mutual funds? Mutual funds are places, asset management companies, where investors will pull in their money. These managers will invest this money in securities. The security will generate returns, and these returns are passed back to the investors. It's as simple as that. Dr. Gaurav has already enlightened many aspects of mutual funds, but how to select them is the thing. Are you aware that there are more than 2,500 mutual fund companies in India? So 2,500 हैं, तो आप easily select कर पाओगे क्या? अगर किसी को बोला तो 2,500 में से 4-5 निकाल लो यार. Is it that easy? Someone will say no, but this has been made possible by Ramsar's KHAMGAON criteria. It's similar to buying a mobile from Amazon. आप Amazon पे अगर मोबाइल सिलेक्ट करने जाते हो तो पहले से सोच लेते हो आपको क्या चाहिए. अरे स्मार्टफोन चाहिए कि फीचर फोन चाहिए, डिस्प्ले साइज क्या चाहिए, बड़ा चाहिए छोटा चाहिए, रैम साइज क्या चाहिए, स्टोरेज कैपेसिटी एंड ब्ला ब्ला ब्ला. सिमिलरली राम सर ने इतना इजी बना दिया है KHAMGAON क्राइटेरिया. एक सिंपल क्राइटेरिया लगा दिया आपने और आपका काम हो गया. This KHAMGAON criteria will help for diagnosis and selection of good performing mutual funds. And post that, once you know that, you will become a mutual fund expert in just 20 minutes. I request everyone to just write down a few notes of this criteria so that it will be very easy for you. इतना easy है, लेकिन आप notes बनाइए तो आपको easy ज़्यादा लगेगा. So what is KHAMGAON criteria? C stands for category of fund. A stands for age, more than 5 years. जितना पुराना उतना अच्छा. Asset under management, it should be more than 1,000 crores. जितना ज़्यादा amount handle कर रहा है मतलब उतना ज़्यादा safe रहने के chances है. Return should be maximum. अच्छा return देगा मतलब अच्छा है. तो 5 साल, 3 साल, 1 साल पे वो top 10 में रहना चाहिए. Expense ratio, गौरव सर ने पहले ही बोला, जितना ज्यादा खर्चा हो रहा है वो अपने जेब से जा रहा है मतलब रिटर्न्स कम हो रहे हैं. सो इट शुड बी मिनिमम. सॉर्टिनो रेशियो, हायर इज द बेटर. अल्फा रेशियो, हायर द बेटर. अब इंडिविजुअली ये क्या क्या है ये देखते हैं अपन. कैटेगरी, वी वांट टू फोकस मेनली ऑन इक्विटी एंड डेब्ट फंड्स. इन इक्विटी विल गो फॉर लार्ज कैप, मिड कैप, स्मॉल कैप फंड्स, एंड फॉर टैक्स सेविंग इन इक्विटी विल गो फॉर Equity Linked Saving Scheme, ELSS. In debt funds, we are interested only in liquid and arbitrage funds. So what will be the prescription for a portfolio? Tax saving तो करना ही है, तो 2 म्यूचुअल फंड ले लो ELSS में से, and post that rest of the amount select 2 mutual funds from large cap, mid cap, small cap, liquid and arbitrage funds. Simple है, ज्यादा सोचने का काम नहीं है. अभी सिलेक्ट कैसे करें कैटेगरी? Go for valueresearchonline.com. ये एक साइट है. It's a very good site which helps you to browse just like Amazon. मोबाइल कैसे सर्च करते हैं वैसे वैल्यू रिसर्च ऑनलाइन समझ लो, सेम थिंग है. उसमें स्क्रॉल डाउन करना है, ये आपको यहाँ पे VRO टूल्स दिखेगा. Go for fund selector. Once you click that, उसके बाद कैटेगरी आ जाएगा और बहुत चीजें आ जाएंगी जैसे Amazon में आ जाती हैं. You can select debt funds, you can select equity funds, you can select whatever you want. And once you have selected it, you just have to click on the end, that is update fund list. यहाँ पे we have selected equity large cap, clicked on update fund list. तो यहाँ पे आपको दिखेगा कैटेगरी में large cap ही select हुआ है. So C stands for category. What is after C is age. So age, launch date जितना पुराना मतलब age उतना ज्यादा. So we want more than 5 years. So यहाँ पे it's more than 5 years. What comes next is asset under management. नेट एसेट्स अपने को 1000 से ज्यादा चाहिए, 1000 करोड़ से ज्यादा रहना चाहिए, तो वैसे सिलेक्ट करेंगे अपन वहां से. नेक्स्ट कम CAA हो गया, अभी R आएगा, दैट्स फॉर रिटर्न्स. वी आर इंटरेस्टेड इन लॉन्ग टर्म, क्योंकि अपन लॉन्ग टर्म में रहने वाले हैं. शॉर्ट टर्म बेनिफिट्स सिर्फ अपने लिए इंटरेस्टेड नहीं है, अपने को लॉन्ग टर्म में रहना है उसमें. तो लॉन्ग टर्म में क्या 3 years and 5 years रिटर्न्स अपने को देखने हैं. इट शुड बी इन द टॉप 10 इन 3 years as well as 5 years. अब कोई कंपनी लॉन्ग टर्म में अच्छी है लेकिन शॉर्ट टर्म में नहीं दे रही, ये तो नहीं हुआ, तो विल गो फॉर 1 year ऑल्सो. वहां पे भी उसने परफॉर्म करना चाहिए. नेक्स्ट कम्स इज एक्सपेंस रेशियो. गौरव सर ने पहले बताया, एक्सपेंस रेशियो जितना ज्यादा अपने जेब से जाता है तो रिटर्न्स कम हो जाते हैं. सो विल गो फॉर लोअर एक्सपेंस रेशियो. दीज आर द एडमिनिस्ट्रेटिव एक्सपेंसेस ऑफ द एसेट मैनेजमेंट कंपनीज, बट दे आर पास्ड ऑन टू अस. अपने जेब से ही जाता है, तो इसमें सबसे लोवेस्ट वाला अपन लेने की कोशिश करेंगे. सॉर्टिनो रेशियो बहुत डिफिकल्ट लगता है ना नाम, क्या है, कौन सा रेशियो है? जस्ट डोंट वरी अबाउट इट, इट इज रिस्क एडजस्टेड रिटर्न. हायर सॉर्टिनो रेशियो बोला तो आपका रिस्क कम हुआ. सिंपल टू रिमेंबर, ज्यादा सॉर्टिनो रेशियो लो, रिस्क कम करो. सिमिलरली अल्फा रेशियो, इसमें रिटर्न पता चलता है. सो हायर अल्फा रेशियो एंड यू विल गेट हायर रिटर्न्स. Just a minute. Oh. So Sortino रेशियो अगर ज्यादा है मतलब क्या होगा? अगर निफ्टी 100 से गिरती है तो आपका म्यूचुअल फंड 100 से कम गिरेगा, मे बी 80 गिरेगा. अल्फा रेशियो ज्यादा है मतलब क्या? अगर निफ्टी 100 से बढ़ा तो आपका म्यूचुअल फंड उससे ज्यादा परफॉर्म करेगा, मतलब इट विल रिफ्लेक्ट द परफॉर्मेंस ऑफ द फंड मैनेजर. अब ये देखें कहां पे? सो सेम पेज, रिस्क स्टैट्स में जाएंगे आप और उसमें आपको सॉर्टिनो रेशियो दिखेगा और यहाँ पे अल्फा रेशियो दिखेगा. ये लाइव दिखाने वाला हूं मैं आपको, सो डोंट गेट एंग्शियस कि ये क्या क्या बोल रहा है. इट्स वेरी इजी, वेरी वेरी इजी. ये कहां पे देखना है, ये कहां से सिलेक्ट कर सकते हैं? प्लेटफॉर्म्स. वन इज म्यूचुअल फंड यूटिलिटी, अनदर इज क्यूएरा, जीरोधा कॉइन एंड रिस्पेक्टिव एएमसी पोर्टल्स. हर एक कंपनी का एक रिस्पेक्टिव एएमसी पोर्टल रहता है, वहां पे जाके आप कर सकते हैं. सो टेक होम मैसेजेस: इन्वेस्ट इन डायरेक्ट प्लान्स ओनली, टेक ग्रोथ एंड ओपन एंडेड पॉलिसीज, अप्लाई कैरसा क्राइटेरिया, and don't go for more than 10 to 12 funds, and invest in SIP mode. Don't run behind fancy and hot named funds. This is the beginning of journey to financial independence. तो थोड़ा समय तो इसमें डाला हुआ अच्छा रहेगा. कुछ समय से, जैसे गौरव सर ने बोला, putting an hour will help you in saving lakhs and eventually it becomes crores. तो अभी कैसे देखें? ऑनलाइन डायरेक्ट दिखा रहा हूं लाइव आपको. सो जस्ट टाइप वैल्यू रिसर्च ऑनलाइन ऑन गूगल, क्लिक ऑन द valueresearchonline.com. स्क्रॉल डाउन, थोड़ा ज्यादा नीचे जाना पड़ता है. लुक फॉर दिस VRO टूल्स. Click on the fund selector. यहाँ पे इक्विटी फ्लेक्सी कैप ऑलरेडी सिलेक्ट किया हुआ रहता है बाय डिफॉल्ट. सिलेक्ट लार्ज कैप, पहले लार्ज कैप देख लेते हैं अपन. फ्लेक्सी कैप को हटा दिया, नीचे गए, यहाँ पे क्लोज्ड एंडेड सिलेक्टेड रहता है, वी वांट ओपन एंडेड ओनली। रेगुलर प्लान्स को उसने डिसलेक्ट किया है, और ये अनरेटेड 1 स्टार 2 स्टार नहीं होना, बिल्कुल नहीं होना, वी वांट ओनली गुड फंड्स। सो इतना सिलेक्ट कर लो एंड जस्ट क्लिक ऑन अपडेट फंड लिस्ट। सो वंस यू हैव डन दैट, स्नैपशॉट में आपको कैटेगरी दिखेगा, यहाँ पे देख सकते हैं आप, इक्विटी लार्ज कैप हैज बीन सिलेक्टेड। इस सभी सिर्फ लिक्विड लार्ज कैप ही रहेंगे। इसमें लॉन्च डेट बाजू में दिख रहा है, एंड आफ्टर दैट इज एसेट अंडर मैनेजमेंट। अभी लार्ज सी हो गया। व्हाट कम्स नेक्स्ट इज ए फॉर एज, लॉन्च डेट जनवरी 13। यहाँ पे आप ऊपर का क्लिक कर सकते हैं। इफ यू क्लिक इट ट्वाइस, जनवरी 13 के पहले का कोई सिलेक्ट हुआ नहीं। सो दिस इज मोर देन 5 years एंड दिस सेटिस्फाइज अ कैरसा क्राइटेरिया। नेक्स्ट कम्स इज एसेट अंडर मैनेजमेंट। यहाँ पे एक 51 दिख रहा है, तो यहाँ पे ऊपर का एरो जो है इसको क्लिक करना है आपने। क्लिक इट ट्वाइस तो ऊपर के डिसेंडिंग ऑर्डर में आ जाएगा। 34,000 वाला दिख रहा है एक्सेस ब्लू चिप, और उसके बाद डिसेंड होते जाएगा। हर एक ऐसे क्राइटेरिया जो है उसका आपको एक एक्सेल शीट यहाँ पे डाउनलोड करने का फैसिलिटी रहता है ऊपर। वंस यू डाउनलोड इट, वो डाउनलोड हो जाता है। यू कैन टेक अ प्रिंट आउट और यू कैन सिलेक्ट फ्रॉम देयर। तो जैसे कैटेगरी सिलेक्ट करने के बाद आपने एज का एक शीट बनाया, उसके बाद एसेट अंडर मैनेजमेंट का शीट बनाया। व्हाट कम्स आफ्टर दैट इज रिटर्न्स। पहले देखेंगे लॉन्ग टर्म। लॉन्ग टर्म में 3 year रिटर्न्स, ये 19, 20, 17 मिक्स है, तो वैसे नहीं होना अपने को। ऊपर का एरो क्लिक करेंगे 2 बार, तो उसमें डिसेंडिंग ऑर्डर में आ जाएगा। तो सबसे ऊपर जो है सबसे अच्छे हैं, 23% इसमें दिख रहा है। अभी 5 year पे भी देखना है अपने को। सो ये 5 year का है। एक्सेस ब्लू चिप 19% दे रहा है। लॉन्ग टर्म में दिया लेकिन शॉर्ट टर्म में नहीं दिया, ऐसे नहीं होना चाहिए, तो शॉर्ट टर्म भी चेक करना है। सो हियर यू कैन सी इट इज 25 मिक्स है पूरा। तो ऊपर का एरो 2 बार क्लिक करें तो 34% कॉन्ट फोकस डायरेक्ट में मिल रहा है। सो अभी 4 हो गए। इसके बाद कम्स एक्सपेंस रेशियो। स्नैपशॉट में जाके एक्सपेंस रेशियो में जाइए, ये कम चाहिए तो एक बार क्लिक करो तो 0.15 कम्स इन निप्पॉन इंडिया सेंसेक्स डायरेक्ट। लास्ट रिमेन्स इज रिस्क रेशियोज। सॉर्टिनो रेशियो यहाँ पे दिख रहा है और अल्फा रेशियो बाजू में दिख रहा है। अपने को दोनों ज्यादा चाहिए। एक्सपेंस रेशियो छोड़ के बाकी सब चीजें अपने को ज्यादा चाहिए। तो सिमिलरली सॉर्टिनो रेशियो को 2 बार क्लिक कीजिए ऊपर, आपको जेएम लार्ज कैप डायरेक्ट में 1.49 वाला दिख रहा है सॉर्टिनो रेशियो, ये सबसे बेस्ट है इसमें। इसका लिस्ट एक एक्सेल में डाउनलोड कर दीजिए। सिमिलरली अल्फा 2 बार क्लिक करेंगे तो कैनरा रोबो को दिख रहा है आपको 5.68 पे। इसका भी एक और शीट डाउनलोड कर दीजिए। सो वंस यू हैव दिस, यू कैन डाउनलोड अराउंड 6 शीट्स डिपेंडिंग ऑन द क्राइटेरियाज। वो 6 शीट में से आपको जो कॉमन है, कॉमन म्यूचुअल फंड्स, उसको आपको शॉर्टलिस्ट करना है एंड उसमें से 2 लेना है। 2 कॉमन रहेंगे तो 2 आप लार्ज कैप के लिए ले सकते हैं। वापस से एक बार लगे तो आपको मिड कैप के लिए दिखा देता हूं। यहाँ पे मिड कैप सिलेक्ट किया और लार्ज कैप डिसलेक्ट कर दिया। अगेन विल गो डाउन। ओपन एंडेड है, डायरेक्ट है, 5, 4, 3 इतने ही सिलेक्ट किए हैं। अपडेट फंड लिस्ट, you go for snapshot category, this is mid cap। तो यही पेज में अपने को 3 चीजें दिख जाते हैं, कैटेगरी, लॉन्च में मतलब एज, और एसेट अंडर मैनेजमेंट। पहले वाले इसमें स्नैपशॉट में 3 चीज मिल जाते हैं। अगेन इसका कैसे करेंगे, मिड कैप का है, लॉन्च डेट देखेंगे इसमें। सो यही है, सबसे पुराना Jan 13 का है, 2013, मतलब 5 साल से भी पहले की बात। तो इसका लिस्ट बना लेंगे। नेक्स्ट कम्स एसेट अंडर मैनेजमेंट। 2 क्लिक किया, 1000 के ऊपर है तो पहले जो 15 है उनको आप लिस्ट बना के सेव कर दीजिए। CAA हो गया। अब वापस आर आएगा, मींस रिटर्न्स। इसका लॉन्ग टर्म में देखेंगे, it's going a bit slow. So here you can see 3 years return. Just click twice on the upper arrow. You have PGIM showing 39% on 3 years. Let's check for the 5 years. PGIM shows 23. So it is the one thing which is common here in 3 years and 5 years return. Let's see what it does in 1 year returns. Click on this arrow, upper arrow twice. Again, PGIM shows phenomenal 58% returns. But mind you, this is because of the COVID crash. That post the COVID crash, the market bounced back. So that's why you're seeing such a phenomenal figure. It doesn't happen in routine. अभी returns हो गए, उसके बाद क्या आएगा? Expense ratio. We have to go back to snapshot, and here you can see expense ratio. We'll go for the minimum. PGIM here also outshines with 0.4% as expense ratio. Last come is Sortino and alpha ratio. तो यहाँ पे वापस सिंगल क्लिक करो, वापस क्लिक करो. PGIM यहाँ पे भी Sortino रेशियो अच्छा दे रहा है. अल्फा रेशियो, लेट्स चेक अगेन PGIM. सो इट्स अ गुड अल्फा रेशियो. सो इस तरह से आप सभी के अलग अलग शीट्स बनाइए. मिड कैप का अलग, मिड कैप के 6 शीट्स, लार्ज कैप के 6 शीट्स, स्मॉल कैप के भी शीट्स बनाइए. उसमें से कॉमन जो है वो आपको सिलेक्ट करने हैं. 2 म्यूचुअल फंड. सो विद दैट I will end my display and thank you very much, WealthCon and IMA KHAMGAON, for providing me this opportunity. Over to you, Shweta ma'am.
Thank you, sir. Thank you so much, Dr. Deepak.
Thank you, Dr. Deepak Bhatt. Now there is Dr. Rajendra Gothi and Dr. Prashant Shankpal sir, chairperson and co-chairperson. Do you want to share certain views or ideas, sir? Dr. Gothi?
Yeah, good afternoon.
Just a minute, sir. एक minute. Madam, Dr. Ram sir has joined.
Okay, okay.
So, please welcome him, and if there are queries, sir will personally answer them, and then we can go ahead.
Okay.
Dr. Ramnath Gute, sir.
Good afternoon, Dr. Ram sir.
Thank you very much.
We are very pleased to have you as the owner of the WealthCon, or maybe the director of the WealthCon, a doctor with us, teaching our people, more than 1,500 doctors. You are teaching how to become a rich person. Not only the skill is important, but all these things are more important than the skill nowadays. So thank you very much. And we will share our difficulties also with you. Thank you. Welcome. I welcome as I am a president to you, sir.
Thank you very much, IMA branch, and thank you very much, Dr. Mede, madam. Just 2 small correction. I am neither owner or neither director. I am a teacher, or we can say I just teach to the student. Second, it is WealthCon is more than 50,000 people. It's growing exponentially because of support, like people, you and many IMA branches are now conducting the programs, and somehow that is this ideology is spreading towards entire medical fraternity. And this was the main idea behind it. Okay, go ahead. I guess this is a offline, and if someone has a query, they can ask directly, or how it is done.
Yeah.
Or there are no query, everything is solved.
Anybody wants to ask any question to sir?
If there are no query, there are 2 possibilities. One is everything is understood, and other is nothing is understood. But I don't think this is possibility, because most our audience are doctors and they understand most of the thing. So second possibility, that no one is understanding, is not at least at our audience level. Okay.
There is a query chat box.
Okay.
By Dr. Anand Rathi. He is asking, is there an app for value research online?
We do not know, but we usually use this website. It may be, but that is just logistic related question.
So I request you to add something to our presentations.
How much time do I have? So accordingly, I'll speak. Madam, President, Madam.
You can talk, sir. No problem. You can add. It is a good thing for us to learn. Actually, everybody is all these things are new for every person. Our skill is different and all these things are new. So actually, this is a good opportunity because we are having 1,500 delegates who are joining this session. So we will give you your.
Can I take 10 minutes? 10 minutes, 5 minutes? I can speak for all day, but that is not things here. Maybe 5-10 minutes.
Okay,
5 minutes.
Thank you. Thank you.
All right. So thank you very much for giving us an opportunity. This is a great privilege to us and our speaker. I must appreciate all the speakers who are very disciplined and everybody in a proper attire with tie, suit and everything. That is a discipline and it is inculcated in our culture, WealthCon community, because discipline is very, very important in finance. Okay. The idea of this WPI, that is WealthCon Passive Investor, is to spread a investment method which is very simple and anyone can do it. Even 7th grade children can select the best mutual fund by using KHAMGAON criteria. I had just posted 2 children. Dr. Parag sir also teaches the fine students. Those are our 7th, 8th grade students. So this KHAMGAON MPTDS criteria are 7th grade level subject. Actually, finance is a 7th grade subject, but it is not taught. We were taught different Pythagoras theorem, sine, cos, tan, that we do not know what to use it. But no one has taught us how to calculate return if I bought a gold at 10,000 and sold at 25,000 in 3 years. 50% people will not able to take. And according to me, if any investor does not know how to calculate return, he is not investing. He doesn't know anything. He's just a speculator or just doing because someone has told, go and just buy. Okay. So these basic things are not taught in the school or nowhere. The reason, it is not important for their school. For school, it is not important. For us, it was never important. For us in 12th science, first priority was getting 98%, 96% learning physics, viscosity and chemical equation, ammonia, nitrogen, then biology, then different families, and then different how to do the meiosis, mitosis, Okazaki fragment, DNAs, everything is we are very much expert. And if you ask any 12th science students or who is appearing for NEET, why are you learning? Or why do you want to become doctor? Why do you want to become engineer? Why do you want to become lawyer? First, they will say, I want to do social service. You ask him or her, is it necessary to become doctor, engineer, to become social service? You can go and start social service right away. That answer is wrong. Thereafter, they will say, I want to use my knowledge or do research. How many of you are, not you, how many engineers and doctors, lawyers are doing research? Hardly 1%. And slowly, slowly counter questions, they will accept at least 99% of the people that they want to have good life. Good life, maybe a good spouse, and they want to send children to good school. And nothing comes free. If you want good health, you need money. If you want to send children for school, you need money. If you want to go for vacation, you need money. Money or finance is an indispensable part of life. At least 1/3 of life is, we will not say wasted, but is used to earn money, whether you agree or no. Internally, you agree on public platform, you may not, because we have data. We don't speak anything. We have data, we collect, and we see the pattern. Which programs are more houseful? We have 1,000 people in just 10 minutes. If I immediately conduct a program of something, maybe not money related, I get 60, 70. Okay, so these all things are necessary. Let's accept the fact. And reality or hard truth of life is that doctor has to pay more premium for services. Whether he goes for anywhere, you will say people will charge more to you. They will come and ask discount in fees. But when you go and ask whether it is vegetable vendor or any hardware shop or any services, they will charge you. Okay, if you go to lawyer and ask for some help, he'll charge more, double. So these are the hard facts. You have to accept. You have to stop this hypocrisy and speaking lie to yourself as well, that I just want to do social service. And I'm not saying that you should not do social service, but accept that these are the things which are important as well. And second thing, you should understand that this is possible to us. The reason I'll tell you, we are the 0.1% of the topmost brain in the country. Is it difficult to find this KRSA MPTDs? No, it is not. It is very much easy. It is just you have to remove that mental barrier and accept that it is possible. In WPI, this WealthCon philosophy of passive investor is very suitable for the busiest to busiest person, because it needs hardly initially 1 or 2 hours for the creating portfolio and 10 minutes every 3 months just to see what is happening. Everything is automatic. Buying mutual funds or shares is easier than buying shoes on Amazon. I'll tell you why. For shoes, you have to do more research, color, shape, size, and all. इसमें कुछ भी नहीं है. 4 parameters, MPTDS. This is possible, and do not underestimate that you cannot do it, and you need experts. So many times, what happens when you start argument with the agents? They will give you example. See, doctor, if someone is ill, he has to go to the doctor. It means you need a specialist. Okay, we completely agree. Doctors needs 10-year education. Okay, but this finance is 7th grade subject. No, where is the specialty? The question is, we agree that we need a specialist. Okay, you are a specialist. Ask your agent. Tell me the standard deviation of the product which you are speaking. Tell me the XIR of my portfolio which you are managing and taking 20, 30,000 fees per year. Tell me the asset allocation. If you are expert, you have to first. I'm not saying that these people are wrong or agents are wrong. They are doing their business with very sincerely. They are convincing you that, doctor, give your money, I'll manage you. You are a busy person. You know what is busy at WealthCon? We say busy means full. You are full. You do not know how to manage time, how to manage money. I'll manage you. It is not their fault. It is your fault, or the fault of person who is not concerned about your money. 1% commission on AUM is not on profit. A 1% commission is on your hard-earned money. Let's say if you invest 10 lakhs, they are taking money from that. So let me give an offer that you buy a house, a rental a property of 1 crore, and agent says, sir, this is 1 crore property, and I'll take 1 lakh every year till you sell this property for next 20 years. Will you agree? No. You buy a property of 1 crore and he says, you have to give me 1 lakh or maybe 2 lakh if property appreciate. Will you give? No. This is exactly what happens. 1% is 10% of profit share. Okay. And the beauty is that even if make loss, that 1% is fixed. So the message from this is be self-reliant. Finance is your responsibility. Okay, no one is there to take your responsibility. Once you accept that this is my responsibility, this everything becomes very simple. Second thing, do not do we can say tips trading, usually intraday, penny stock. Don't do such thing. You focus on your practice. There is absolutely no need to become intraday trader and all those things. Third thing, this may not be appropriate place or may not be received by well, but avoid cash generation. Okay, because when you generate cash, its value decreases over the period of time. And when you go and spend, there is a GST which has always 28 or 28%. So taxes will not be served. So create a portfolio with a proper payment of tax and all the things, and get as financial freedom as early as possible. Next message is that do not be dependent upon your children for your retirement plan. They have their own plan. They will have their spouses, their children. They will look after them, or they may not be available in India that time. Do not know. After 10 years, there will be a lot of changes. So you have to create your own portfolio. Many doctors say, okay, I have a lot of land, but land is not liquid. If you want to pay immediate some money to hospital, you cannot go and sell land. So you need to have some liquid portfolio in the form of stocks, in the form of mutual funds, because liquidity is extremely important in old age. Okay, so these are the few messages which, if someone asks me to speak, I can speak it. Okay, so thank you very much, Parag sir, and thank you, IMA branch. If anyone wants to ask question, I can be there, or I can take a leave if you can want to continue. And do not mind if I speak something which you may not like. And we always say, take whatever is appropriate and discard rest of the things. This is because there are many things which we may not be suitable or appreciated by the people. But there are some truths are little bitter. We have to give bitter medicine to get permanent cure. Correct?
Yes, sir. Thank you, Dr. Ram, sir, for his contribution in our WealthCon. And I am also thankful to Dr. Shweta madam also. Dr. Gothi sir is there as a chairperson, and Dr. Shankpal. Dr. Gothi sir, do you want to share something? Dr. Rajendra Gothi? Okay, sir. Thank you, Dr. Rajendra Gothi sir. Now I will call our organizing secretary for the last concluding ceremony of vote of thanks. Now I am giving the handover to Dr. Anand Rathi, the organizing secretary of the KGCON-2022. Thank you.
So thank you very much. Now we can leave, right?
Yeah, ma'am. Yes, sir.
Okay, thank you. Bye-bye.
Thank you.
Thank you, Dr. Mende ma'am, President IMA KHAMGAON. Now we have approached to the end of our KGCON 2022, and I am privileged to conclude the vote of thanks for such a wonderful educational feast. Over these 2 days, a lot has happened, and we have been updated with very interesting facts and techniques, which are really pearls of general practice, which is our theme of KGCON 2022. I thank Dr. Prakash Marathe sir, our chief guest, Dr. Jignesh Taswala sir, Dr. Umesh Revanwar sir, Dr. Nilesh Tapre sir, for their presence and contribution and valuable guidance. Today's event was not possible without the humongous contribution of our beloved speakers. I would like to take this opportunity and thank Dr. Gopal Soni sir, Dr. Chandan Motwani sir, Dr. Guru Prasad Thete sir, Dr. Amol Kotharkar sir, Dr. Shon Chinchole sir, Dr. Ashok Bauskar sir, Dr. Sanjeev Bhopre sir, Dr. Narendra Bhagwat sir, Dr. Sumit Agrawal sir, Dr. Vivek Talwarkar sir, Dr. Ambrish Khator sir, Dr. Ashish Tapadia sir, Dr. Prakash Marathe sir, Dr. Prasad Sor sir, Dr. Namrata Bhagwat ma'am, Dr. Parag Tapre sir, Dr. Gaurav Ladha sir, Dr. Deepak Bhatt sir, Dr. Ashish Jhunjhunwala sir, Dr. Ramnath Bhute sir, Dr. Shweta Matreja ma'am, and whole WealthCon team. Our chairpersons all had been such a delight who handled the session patiently and added to the knowledge of everyone. So I thank Dr. Manjushri Tibdewal ma'am, Dr. Sandhya Nagargoje ma'am, Dr. Ravi Shankar Jadhav sir, Dr. Raja Bhau Shirsagar sir, Dr. Hari Vadode sir, Dr. Amit Deshmukh sir, Dr. Parag Mahajan sir, Dr. Satish Gore sir, Dr. Anand Jhunjhunwala sir, Dr. Manish Wankar sir, Dr. Pankaj Mantri sir, Dr. Sheetal Chauhan, Dr. Brahmanand Tale sir, Dr. Pranali Deshmukh ma'am, Dr. Praveen Patil sir, Dr. Gaurav Goenka sir, Dr. Ashok Gaikwad sir, Dr. Nilesh Tibdewal sir, Dr. Nilesh Tapre sir, Dr. Ramesh Bhutra sir, Dr. Gulab Kaur sir, Dr. Samruddhi Mende, Dr. Ashok Bhaskar sir, Dr. Deepa Mantri ma'am, Dr. Sadanand Ingre sir, Dr. Nitin Nandurkar sir, Dr. Akhtar Hussain sir, Dr. Rahul Khandare, Dr. Rajendra Gothi sir, Dr. Prashant Shankpal sir, Dr. Prachi Jadhav ma'am, Dr. Narendra Pawar sir. I would also like to thank our PST body for giving me this opportunity as an organizing secretary of KGCON 2020. Our president of IMA KHAMGAON, Dr. Surekha ma'am, we are very thankful to you, and secretary Dr. Vinod Rajankar sir, and treasurer Dr. Atul Rajput sir. And special thanks to my joint secretary Dr. Aniket Mende. And thanks to all BOD members and Women's Wing IMA KHAMGAON, President Dr. Rashmi Rajankar ma'am, Secretary Dr. Smita Deshmukh ma'am for supporting us. And I thank our technical support team, Mr. Raman Marke sir and Mr. Sunil Latawa, for providing such a nice technical support. Last but not the least, I would like to thank our delegates for their active participation and patiently hearing. I would also like to thank all coordinators for making this CME successful. Dr. Vakekar sir from Jalgaon Jamod, Dr. Tapre sir from Akola, Dr. Chate sir from Buldana, Dr. Baekar sir from Buldana, Dr. Rathod sir from Washim, Dr. Kedekar sir from Devgaon Raja, Dr. Tapadia sir from Akola, Dr. Agrawal sir from Akola, Dr. Bora sir from Lonar, Dr. Mante sir from Devgaon Raja, Dr. Dawange sir from Nandura, Dr. Patil sir from Malkapur, Dr. Banole sir from Shegaon, Dr. Mapari sir from Lonar, Dr. Vasu sir from Chikli, Dr. Gothi sir from Nandura, and from KHAMGAON, Dr. Pawar sir, Dr. Solanke sir, Dr. Mukund, Dr. Wankede sir. Now I conclude end of this seminar. Thank you.